Sep Onco Summit recognizing sepsis in oncology. When they handed over the topic to me to carry forward the task what they had created, I found a few very important information. Infection is the second commonest cause of uh, death in cancer patients. It is 9 times more common in cancer patient than in the ordinary patient. And the most important thing, if you have gone through the messages which I have posted on the group, is it has brought all of us together. Surgical oncologist, medical oncologist, hematologist, neuro-oncologist, XYZ, anyone who is a clinician managing cancer patients is definitely worried about infection. चाहे pulmonologist हो, चाहे Dr. Praveen हो, Dr. Prashant हो, and I am sure amongst our invited faculty also. So here we have a common shared goal, how to prevent infection in cancer. It is a very important goal which we have to achieve because we can't afford to lose patients. बेचारा आया तो कैंसर कराने और इन्फेक्शन लेके चला गया. You imagine the tragedy if anyone near or dear to me comes for a cancer treatment and succumbs to infection, not to cancer. So to look into various aspects, we have the conference. And without taking too much time, I will request the Dr. Shikha and Dr. Poonam to take over and let's start the session.
A very good morning to all distinguished guests, esteemed delegates, and experts. I'm Dr. Shikha Modi, and with me is my colleague Dr. Rani Poonam. It's a privilege to welcome you all to Sep Onco Summit, which is dedicated to advancing medical knowledge and is designed to foster dialogue on latest clinical achievements. Without further ado, let's dive into our agenda and begin today's session. To start with our first lecture on life-threatening oncological emergencies in ICU, I would like to invite our chairpersons to the stage. Please welcome on stage Dr. Shagun Bhatia Shah, who is a senior consultant anesthesiology at Rajiv Gandhi Cancer Institute and Research Center, Dr. Parveen Kaur, head of medical ICU, Rajiv Gandhi Cancer Institute and Research Center, Dr. Sahil Kataria, consultant critical care medicine at Holy Family Hospital, and Dr. Jitin Sharma, associate director at BLK Max Super Speciality Hospital. Now I would like to request our chairperson to please introduce the speaker.
Good morning, everyone. Welcome to the RGCRC Code Program 2026, the Sep Onco Summit. Thank you, Dr. Shikha, for the kind introduction. And on behalf of all the chairpersons here, I'd like to introduce Dr. Sachin Gupta, who's our speaker. He is the Director Critical Care at Narayana Super Speciality Hospital, Gurgaon. And he has a lot of achievements. He's the General Secretary, ISCCM, and he's the North Zone Representative, National Executive, ISCCM. He's been the Chairperson, Gurugram Branch, Coordinator, so on and so forth. He's also the Associate Editor of IJCCM and a Fellow American College of Critical Care Medicine. He's authored more than 100 publications, and he's the National Principal Investigator for Dissect, Salute, etc. His areas of interest include focus, advanced hemodynamic monitoring, and extracorporeal therapies in sepsis. Anybody would like to add anything? Give him a big hand. Let's begin the session.
Thank you, chairpersons, for the kind invite, and thank you, Rajiv Gandhi team, for having me here, Prashant, Dr. Praveen, others. So I was given the topic oncological emergencies, and when I searched Google, there were 100 emergencies which came out. 30 minutes में तो 100 emergencies नहीं हो सकती. So what I planned was the basic, most commonest, as an intensivist, what we look at. So my talk will be more of intensive care, right? So how do you look at certain oncological emergencies? And we know that cancer is a leading cause of death, and it's a growing challenge, right? Most of the hospitals have a separate oncological wing. Now we understand this is like a pandemic which is there. There is a lot of global burden because it remains one of the leading causes of death worldwide, despite a lot of significant advances which have been done in understanding the cancer physiology, pathology, as well as treatment modalities which are directed towards it. There is a rising survival, so the expectations of the patients are increasing, right? And so we encounter more oncological emergencies. The thought that if I have cancer, the life is over is not a thought now, right? People do want their cancers to be treated, and obviously there will be certain emergencies in the course of the treatment. And these emergencies may be initial presentation of an undiagnosed malignancies, patients coming with, pathological fractures, you diagnose them, they are myelomas, right? So, or patients with altered sensorium, you look at, find there is hypercalcemia, you diagnose there is a malignancy lying underlying. So this is a dual presentation, and this is another very important issue which a clinician should understand. So I will directly go to the first important emergency that we look or encounter is febrile neutropenia. Now, this is a life-threatening oncological emergency because it is characterized by simultaneously presence of fever, and the cells which have to fight this fever are dangerously low. So dangerously low neutrophil count, and this leaves the body defenseless against infections in the most vulnerable time. So if you have to define febrile neutropenia, there has to be fever, which is single oral temperature of more than 38 or 100.4 or temperatures of 37.2 sustained for over 1 hour. Neutropenia is mandatory, so anything which is less than 1.5 as in 1500, a significant reduction is there. Severe neutropenia, we will call this if it is less than 500. So less than 500 with fever will actually account for a febrile neutropenic patient. They are all inherently immunocompromised. So once you encounter a febrile neutropenia, think this patient as severely immunocompromised patient. So all your treatment modalities and management should be directed towards it. Now, it can be because of multiple reasons. It could be also because of the malignancy per se. It could be because of the treatment of malignancy. So chemotherapy induced. So cancer patients admitted with bone marrow suppression. Sepsis per se can lead to febrile neutropenia. Certain medications like antibiotics, antipsychotics, antithyroid can also lead to febrile as a neutropenia, and SLE, aplastic pneumonia patients presenting with neutropenic crisis. So you have to be very vigilant. As I said, febrile neutropenia only does not mean oncology. Yes, it could be an underlying oncology issue. So if patient has unexplained fever spikes, patient has new organ dysfunction, there is hemodynamic instability, and there are skin and mucosal signs like mucositis, skin lesions, perirectal tenderness. These are classical signs and very, very subtle signs which are there, and these patients need to be evaluated in detail. So you have to suspect neutropenia. You have to look at these causes. Can these patients go into febrile neutropenic state? Investigate in detail what kind of malignancy or what kind of medication these patients are taking, and then you act. So if your patient has if your patient has classical features of temperature of less than 30, of more than 38, or signs of shock, plus severe neutropenia of less than 500 cells, this is febrile neutropenia to define with. And all these patients have to be treated the way we say a surviving sepsis campaign, right? Here the timeline is even stricter. We want everything to be done within first 30 minutes. So administer your first shot of antibiotics within first 30 minutes of presentation of these patients. Now, there is a score called Multinational Association for Supportive Care in Cancer Risk Index score. Now, this score is important to categorize these patients into high risk and low risk. So, if patients have febrile neutropenia with little or no symptoms, no hypertension, no COPD, solid tumor or hematological malignancy, but without prior fungal infection, no signs of dehydration, or with febrile neutropenia with moderate symptoms, patients on an outpatient basis, so not so sick patient and not so elderly, which is less than 60. There are various scoring systems which are available. So you risk stratify based on these scoring systems. So patients can be high risk if your MASCC score is less than 21, or low risk or outpatient. We are mostly concerned with this high risk patients. So patients with neutropenia and patients who have hemodynamic instability, new onset abdominal pain, neurological changes, consolidation, or other organ functions like hepatic function, renal function. These are all high risk patients, which means they need to be admitted. They have to be in the intensive care unit. IV therapy is the choice that they would be giving. So when you're managing these patients, you monitor your absolute neutrophil count, because this is how you diagnose and this is how you manage neutropenic patients. Blood cultures should be taken, and they should be taken from multiple sites if possible. If these patients have a perm cath, or if these patients have a chemo port, take samples from there. Long-term PICC lines, take samples from there. Fresh venipuncture samples for blood cultures have to be taken. Site specific cultures should always be taken in terms of urine, sputum, if they present with consolidation, if they have any bed sores or any wounds, take wound swabs. If you feel the patient has a pulmonary issue, you can do a bronchoscopic alveolar lavage and CSF if there are signs of altered sensorium or suspicion of meningitis. CRP and procalcitonin can help us to differentiate between bacterial versus non-bacterial etiology. Although they are not very pathognomic, they can still be higher in the other infective etiologies as well, but they will just guide you a little. The most important is take sufficient blood cultures, administer your antibiotics within the first 30 minutes of presentation to the hospital. So send your ABGs, look for your lactate levels, do the complete blood count, if possible cultures, and look at your fluid balance and fluid resuscitation. And then once you have done this basic workup, start with other radiological tests. If required, a CT scan, if that pathology is there. If you feel this patient has a viral etiology for the lung infiltrations, look for your respiratory viral PCR, stool for for NAT panel, C difficile. Again, it depends on the presentation, and swabs. So mouth swabs, wound swabs, rectal swabs, axillary swabs. These swabs are also important in terms they will tell us is there colonization in these patients, because febrile neutropenic patients, they can catch any infection. Their own flora can become pathological. So we have to determine what is the source in this particular patient. When we talk about radiology, they have a supporting role. So look for your chest X-ray and CT when you're looking for consolidation and infiltration. You can do your ultrasound, because that will tell us about any ultrasound in intra-abdominal infections. Is this patient presenting with cholecystitis, appendicitis? Is there a mass in the liver, an abscess in the liver, hydronephrosis? So there are a lot of etiologies that can be determined just by a bedside ultrasound technique. So, as I said, the golden rule is administer antibiotics as early as possible. Please follow the local resistance pattern that you see in your hospital. What is the traditional antibiogram that is there in your setup? Try to cover try to give an antibiotic which has an anti-pseudomonal cover. So if the patient is not in shock, even piperacillin tazobactam can do wonders. Yes, carbapenems are there. Cefepime, again a meropenem sparer, what we call it. So these are generally the first choice drugs which are there. If you feel that this patient also has history, or in the past had history of any staphylococcal infection, so look for anti-staphylococcal or anti-MRSA agents, ticoplanin, vancomycin if the patient's renal functions are fine. Antifungal should be added for patients who have prolonged neutropenia or who have high risk patients, high risk for malignancy, and acyclovir, that is antiviral, if you are suspecting herpes simplex or varicella reactivation. So it can't be a blanket prescription that you start all this, but yes, anti-pseudomonal antibiotic, an MRSA antibiotic, antifungal depending on the category of the patient, and antiviral depending on the presentation of the patient. So this is the core principle, that generally a monotherapy is enough for these category of patients, unless and until they are in shock state, they are in multi-organ failure state, that you do. Vancomycin, if your patient is hemodynamically unstable, severe sepsis, MRSA, severe mucocolitis, mucositis, catheter-related infection, skin and soft tissue, or radiographic pneumonia is there, then you can look for vancomycin. Or if you're worried about renal dysfunction, then ticoplanin can also be added here. So this is where you look at gram-positive addition in these patients. Aminoglycosides like gentamicin can be added. once your patients are started on this particular cocktail and you feel your patients are not doing well, you can think about adding an aminoglycoside and an metrogel if your patient has diverticulitis or signs of typhlitis, right, or perianal abscess. So this is only and only in this particular indication where you think of adding an anaerobic cover. As I said, the indications for gram positive is hemodynamic instability, pneumonia, which is documented radiographically. You have a positive blood culture for a gram positive bacteria. You suspect catheter related infections, skin and soft tissue infections, patients, colonizing with MRSA or VRE kind of bugs, or severe mucositis. So only these specific indications are there when you think about adding any gram positive cover. It's not a blanket cover for any febrile neutropenic patients, right? So this is just the entire chart what I had shown. Now, if your patients in next 2 to 4 days, if the what is the fever status? So if the fever has resolved and your current antibiotics are continued and your absolute neutrophil count is increasing, then it is time to step down your therapy, right? And you step down to an oral therapy. But if the patients are not settling, so the fever is not settling, and even if you have added vancomycin, then you look at what is the status. So at 48 to 72 hours, we look for any other occult source. Is this source controlled or not? Why is my fever and why is my absolute neutrophil count not settling? Keep continuing evaluating your hemodynamics and secondary non-infectious complications as well. Patients can present with pulmonary embolism. That can also be, similar presentation, fever, tachypnea, shock. That's a non-infective etiology. So always look for non-infective etiologies as well. Remove catheter if you have any suspicion of line sepsis, because you look at pathogens, staph aureus, fungi, mycobacteria. If these are the suspicious pathogens and you think catheter is the source, if the patient has a tunneled catheter, remove these catheters. Look for signs of endocarditis. If you think line sepsis is there, patient can also have endocarditis. Now, this is high risk patient when the fever is for more than 4 days, and we have majorly talked about it. The more important point is you look for source control if your patient is not settling in 72 to 96 hours after you have initiated the therapy. What about the what what about adding antifungals to these patients, right? Now, what is the clinical status of this patient? If the patient is clinically stable, right, then you can withhold antifungals and you do your radiological test. You do your high resolution CT, look at your serum galactomannan, beta D glucan test, which are more like will tell you is there fungal or not. What kind of fungus, it will not tell you. Or if you have signs of on CT like halo sign, then yes, obviously you will be starting an antifungal therapy. The other therapy is therapy driven approach, where if your patient is unstable or you are not able to do these testing and patient is deteriorating, you actually start an antifungal and you look at mold coverage. So echinocandin group like caspofungin, anidulafungin could be added. If you think there is aspergillosis, you can look at voriconazole or isavuconazole, or even amphotericin B if there is suspicion of mucor. So depending on what is the suspicion, what is the radiological presentation, what is the clinical presentation, you decide what kind of mold coverage you want to administer to your patients. Last but not the least, you look for GM-CSF. You want to increase the neutrophil count. You want your fighter cells to increase. So filgrastim and pegfilgrastim are generally the two agents that you are giving. Filgrastim is a shorter acting, you administer it almost daily. Peg is a longer acting one, and they both help to stimulate the bone marrow to rapidly produce neutrophils. When do you do this? You give this in high risk febrile neutropenic patients, prolonged neutropenia, prophylaxis, and in high risk chemotherapeutic agents. You generally administer 24 hours after the last chemotherapeutic dose and at least 24 hours before after the first antibiotic dose to avoid interference, and it has to be continued till the time you achieve your target neutrophil count, which is generally 1,000, right? So that is the target that you want to achieve. Minded, all febrile neutropenic patients, if they are taken care in the intensive care unit, has to be in the isolation room. And what kind of isolation? Is it a positive or a negative pressure? I hope you understand the physiology. Positive pressure means the room inside where the patient has a positive pressure as compared to the outside, which means air from in is going out. Negative means it is sucking in. So for tuberculosis, you want a negative pressure. For neutropenic patients, you want a positive pressure. So all these patients have to be taken care in a positive pressure room. So that was one emergency that as an intensivist we encounter a lot, right? Because patients on chemotherapy at some stage would become neutropenic, and if they become sick, they do land up to the intensive care unit. The other emergency is hypercalcemia of malignancy, and this is almost 20 to 30% of cancer patients are affected by this particular presentation, and this is most common cause in hospitalized patients. The clinical impact is, if it is not identified and treated at timely, it has a significant morbidity and mortality, and there is a huge reduction in the quality of life. So what does the patient present with? Patients can present with altered sensorium, so they can have confusion, lethargy, psychosis, and if the calcium levels are too high, they could even be into coma state. Patients can have nephrolithiasis, nephrocalcinosis, and acute kidney injury, arrhythmia, shortened QT interval, and risk of cardiac arrest. So they're all non-specific presentations, and these patients can actually come to first time with these presentations with no background history of malignancy. And this is where a very high level of suspicion has to be there. So patients can have nausea, vomiting, constipation leading to renal failure. So we may feel this is dehydration leading to renal failure, but actually the background disease is something else. So if you look at etiologies, the most common etiology is PTH, RP, mediator hypercalcemia, and then you have other causes like hypercalcemia secondary to overproduction of vitamin D and so on and so forth. So the parathyroid hormone related peptide is the central driver when we look at the hypercalcemia of malignancy, which is there in almost 80% of cases. There could be, it activates osteoclast, which releases stored calcium into circulation, and it mimics the PTH to increase the calcium reabsorption in the renal tubules. So patients can have prior malignancy, patients can have prior hypercalcemic episodes. Patients also have to be looked at, are there any current medications which can create hypercalcemia? They have to be looked at. Always look at your corrected calcium level, so you should be aware of the albumin level in that particular patient. The corrected calcium level is whatever is the patient's calcium plus 0.8 into 4 minus albumin. So let's say the patient's albumin is 2, so 4 minus 2 is 2, 2 into 0.8 is 1.6, and if patient's calcium is 13, so 13 plus 1.6, the actual calcium that the patient has is 14.6. So always look at corrected calcium levels when you suspect hypercalcemia, and the other clinical signs should be there. So once you know what is the etiology, look for the treatment, because that is very, very important, and it has to be very rapid in nature. So what is the treatment or the cornerstone? IV hydration. This is the first line therapy. You hydrate these patients with normal saline, and you give it almost like 3 to 5 ml per kg, almost to the tune of 250 to 300 to even 500 ml per hour for initial few hours to a 60 kg patient. So that is the amount of fluid these patients will require. Zolindronic acid or pamidronate, they inhibit osteoclast activity, but they are late onset effect, right? They will not act then and there. They have a almost 72-hour onset effect. So they are not the ones that you prefer as the first choice of drug. Denosumab can be given again if the patients have renal impairment, because when these patients have renal impairment, your biphosphonates, your dronates will not act. You don't give it. So this is where you give denosumab 120 mg is what you generally administer to these patients. And then when you are looking at a rapid correction, apart from the hydration, calcitonin, this almond calcitonin is where you start with. So this rapidly lowers calcium in 4 to 6 hours. So you can give up to 600 units, 200 units thrice daily, or 300 units twice daily, depending on how you want to do it. The problem is tachyphylaxis. So within 48 to 72 hours, this drug achieves tachyphylaxis. So this can't continue for days together. You generally give it for 2 to 3 days, beyond which the effect of salmon calcitonin is not there. If all these measures are failing, then the choice of therapy is hemodialysis, where you will be able to rapidly correct your calcium levels. So first is hydration. Look at denosumab. Along with it, you start your calcitonin. Once you have achieved good hydration, you can look at diuretic therapy as well. But the principle is you want your calcium levels to fall rapidly. Dialysis indication is calcium of more than 14 despite all these medical therapies and patient deteriorating consciousness wise, renal failure wise, acidosis wise. You do dialysis in these patients, and these are the various drugs which are available, right? So it is an oncological emergency because it has a multi-system impact, and the therapy is very simple. You start with very good hydration. Don't be lenient, don't be very I would say miser in giving fluids. Give lot of fluids to these patients. They do tolerate these fluids. Hemodialysis will be there at the end if all these therapies are failing. The another important issue is tumor lysis syndrome. Right now, this is because of rapid massive lysis of tumor cells, either spontaneously or following a cancer directed therapy. And what happens is there is a sudden release of intracellular contents, which overwhelms the body's hemostatic mechanism, and this leads to cascade of metabolic derangements. Eventually your patients land up to multi-organ failure. So there is a rapid deterioration. From within hours the patient will land up into multi-organ failure, and these deaths are preventable if you are intervening them very early. So how do patients present? Patients present with hyperuricemia, eventually leading to acute kidney injury. Hyperkalemia, so patients can have life-threatening cardiac arrhythmias. Hyperphosphatemias, and along with that hypocalcemia, and obviously with hypocalcemia patients can have neuromuscular irritability, seizures, and certain cardiac dysfunctions. So which patients are more susceptible to have TLS? What is the tumor type? So high grade lymphomas, acute leukemias, small cell lung cancer, these patients are at a higher risk of tumor lysis syndrome. What was the tumor burden and other associated comorbidities? Patients already having some element of acute kidney injury, dehydrated, or pre-existing electrolyte disturbances. There are certain criteria like the Cairo-Bishop criteria, where we say the TLS of more than 2 electrolyte abnormalities within 3 days is a risk factor. So your patients can have an elevated LDH, a high WBC count, and certain electrolyte abnormalities. So these are red flags. If your patients with these kind of malignancies, high grade lymphomas, and having these investigations, they are red flags that they can land up into tumor lysis very fast. A uric acid of more than 8, potassium of more than 6, phosphorus of more than 5, and a calcium of less than 7. If these are there, then this is definition of tumor lysis syndrome for adults. How do you treat it? Again, hydration plays a very important role. 2 to 3 liters per meter square per day. You can start allopurinol, which is a xanthine oxidase inhibitor, and then raspuricase is very important because it converts existing uric acid to allantoin. You take care of your other electrolyte abnormalities, hyperkalemia. You know how to do it. Insulin dextrose, nebulizations, Kexilate, loop diuretics. Hyperphosphatemia, there are phosphate binders. Hypocalcemia, you give intravenous calcium. And acute kidney injury, if all this is not settling, then a renal replacement therapy is there. So it is an interdisciplinary collaboration is very important when you have to look at this. The last 2 or 3 slides I will just talk about is superior vena cava, which is again a very problematic subset which we encounter in the ICU because it is a potential life-threatening medical emergency which is arising from the obstruction of the superior vena cava, which is the principal vessel returning the deoxygenated blood from the upper body to the atrium. The problem is there is massive congestion and edema throughout the upper body, neck, drain. So patients can have difficult ventilation, patient can have difficult intubation, patient do not have vascular access availability. And basically the lung cancer, the leading cause of superior vena cava syndrome, which is there. And the problem is all these intravascular devices have to be taken care of. There are another risk factors which is there. Benign mediastinal tumors are risk factors, and certain vascular infections like aortic aneurysms and fibrosing mediastinitis are again causes of superior vena cava syndrome apart from malignancy. So patients can present with shortness of breath, cough, and facial swelling. There could be headache, venous distension, and in worst cases, patients can have stridor. So there will be an airway compromise, and cerebral and hemodynamic crisis could be there. You do your imaging, PET scan, CT scan, contrast, echocardiography, which will help you in diagnosing the issue. How do you do it? If the patient is able to tolerate radiotherapy very well, because this will shrink that part, you have to give anticoagulation to these patients. If possible, an endovascular intervention can be done where you do the thrombectomy and try to release this therapy, and glucocorticoids could be there. So when you talk about these emergencies, the intensivist literacy about various oncological emergencies is very important, because all these patients will land up to the intensive care unit and they have varied presentations. They are all immunocompromised, so they may not present with classical signs and symptoms, and that is where the high degree of suspicion is required. Febrile neutropenia is a very, very difficult subset, because a very good infection control practice scenario has to be there. Hypercalcemia of malignancy and tumor lysis, fluid therapy, and SVC obstruction is a life-threatening emergency where timely intervention is required. Thank you so much.
That was a very insightful presentation, and I congratulate you for that. You'd said that tumor lysis syndrome, most common period is 3 days before chemotherapy to 7 days after chemotherapy. So before the chemotherapy, is it more common, or afterwards it's more common, and why so? I mean, is it the tumor burden so high that just precisely 3 days, beginning 3 days before chemotherapy?
See, I don't work in an typical cancer oncological institute, but what comes to me is always post chemotherapy.
This is more common.
What we have seen most is what comes to us is mostly post chemotherapy. I don't know whether pre is more common or not, but what we have seen is always post chemotherapy. We have seen the tumor lysis which comes to us.
I think Dr. Ilash Batra can answer this.
That is what I was about to say, let him answer.
I think post chemotherapy is definitely more logical to have tumor lysis, unless or until you are dealing with a Burkitt's lymphoma or a ALL or something. So I'll say 97% post chemotherapy, 3% pre chemotherapy
Yeah.
because of the intrinsic tumor biology.
Hematological malignancies, they have this,
Yes.
more chances of having this.
And then I think the lab diagnosis values, they seem so daunting. So I'd like to share a small mnemonic with the students here. The 5, 6, 7, 8 rule. 5 stands for phosphorus. Phosphorus levels above 5 milligram%. 6 is potassium. Potassium above 6. Pill equivalence per letter. C, calcium. 7 is calcium. Calcium less than 7. And uric acid more than 8. So 5, 6, 7, 8, and you know your TLS, 2 or more of these. Dr. Ullas would like to add something.
A fantastic 5, 6, 7, 8 rule. That is why most of the medical oncologists get a 0.
Oh my God.
I've never heard of that actually. Thank you for that.
Dr.
Make
Praveen,
myself, you know.
Dr.
help
Praveen,
myself.
you have something to add? Our experience in RGCI, Dr. Sachin, other chairpersons, please.
Regarding this, it's always mostly chemotherapy, after chemotherapy that we get these patients, TLS. And respiratory, I think use is very, very critical. And when do you use respiratory versus allopurinol? So that is what I like to know, sir. Is there any particular set of, yeah. No, at any particular level of uric acid, would you like to add respiratory or?
So see, when you think this is TLS, allopurinol is generally started as the first line apart from IV hydration. What we have experienced is that if within next 24 hours only, if the uric acid levels are not coming despite your IV hydration, your allopurinol, we tend to give respiratory. This is what, because the intention is to avoid renal replacement therapy. That's the only intention what I feel is there, that you want to avoid these patients heading towards renal replacement therapy. That's an added morbidity for these patients. It's not a simple RRT for any subset. So if 24 hours is the timeline you have given allopurinol IV hydration, your uric acid is not coming down, start respiratory.
And as Dr. Sachin is repeatedly mentioning, suspecting and then hydration, that makes it very, very important. And respiratory case, we are using very frequently.
First line we're using.
Yeah.
Thank you.
How frequently we see superior vena cava syndrome? Dr. Ullas, you manage cancer patients, CL.
Lot of patients, Dr. Ullas.
So it again depends upon what kind of specialty you're dealing with. Let's say you're dealing with breast cancer, you hardly see a SVCO. If you see a lung cancer, if you see a lymphoma, I think 20% of our patients will have SVCO. Again, the management of SVCO is two. One is suspect, that is very important. And one is to then to treat. Previously, it was all about radiotherapy. But right now, the IR people doing a stenting procedure
Stenting.
over there is actually taken over radiotherapy.
Chalo, thank you. Any questions from the audience? And if you permit, we call it the now.
Thank you.
We have the next session to start.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you. I think we must have a group photo of the chairperson and the. चलो 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 चलो
Good morning, everyone. For the next session discussing sepsis in 2026, what's new? We now have the honor to invite Dr. Rajiv Goel sir, Head of Interventional Pulmonology at RGCI, Dr. Ulas Batra sir, Director Medical Oncology RGCI, Dr. Vivek Gupta, Senior Consultant Department of Anesthesiology RGCI, and Dr. Varun Arora, Senior Consultant Critical Care Medicine, BLK Max Hospital. Due to some unforeseen circumstances, Dr. Prashant Saxena is running late. So, Dr. Nitin Bansal would be the speaker.
Good morning, everyone. And it's fantastic to see a full house, almost a full house at 9 in the morning, and that too on Saturday. Speaks volumes about the content of the meeting. So I congratulate the organizers. And you are not Nitin Bansal?
I'm not Nitin Bansal,
Okay, you're
sir.
not Nitin.
Just to make an announcement.
Please.
Yeah. I'm very sure about it. I'm not
Yeah,
Nitin Bansal.
I'm sure that none of the medical oncologists want to be Nitin Bansal. Trust me on that.
Sure, sir. Take your word on that. Yeah, hi, I'm Dr. Prashant. Just a small announcement. We have to prepone one session. Dr. Prashant Saxena was supposed to be the speaker of this session, but he has got stuck in traffic. So we just swapped one session. So I invite Dr. Nitin Bansal to take over the stage. Thank you. Thanks a lot.
So till the time Nitin comes over here, sepsis is bad. And if you think sepsis is bad, fungal sepsis is one step ahead. And if you think fungal sepsis is bad, Nitin Bansal talking to about fungal sepsis or managing fungal sepsis and talking to a medical oncologist is even worse. But whatever said and done, when it is fungal sepsis, there's one person whom I will trust with my life on. That is going to be Nitin Bansal. So with this, stage is all yours, Nitin.
Sir, I will answer this little later. Can I have my slides? So by the time they pull up my slides, I would just like to ask you, how many of you think, like when we say, I think sir was speaking, when we say sepsis, how many of you think that we should start empirical antifungals to all the patients in oncological emergencies? Say, raise your hands who want empirical antifungals to all the patients with sepsis in oncology. Oncology, ICU. We are talking about ICU only. So any of them, none of you want. But all of us give. Yeah. Thank you. So fungal infection, I have been asked to speak on fungal infections in oncology settings. I don't have any conflicts of interest, and I would like to thank Dr. Bikram sir and Prashant sir for asking me to speak on this forum. I know most of you must be aware of all this, but just to keep everybody on the same page, fungal infections or mycosis is another word which is used to speak about fungal infections, can be divided into two parts: superficial mycosis and deep mycosis. Superficial mycosis, when we say that there is an infection of the skin or skin appendages like nail and hairs and subcutaneous tissue. Deep mycosis, as the word says, that it is the infection of the deeper organs like lungs, abdominal viscera, bones, and central nervous system. These are the common funguses which can cause superficial and cutaneous mycosis. Most of these presentations are in OPD basis and which are generally dealt by dermatologists and generally not life-threatening, although exceptions are there. And in severe neutropenic patients, some of these funguses can also invade and cause serious problems. Then subcutaneous mycosis is a more of a mycosis of people who are farmers or involved in farm activities where subcutaneous nodules can happen, like chromoblastомycosis, mycostoma, sporotrichosis. Again, not very commonly seen in oncology patients. Now, deep mycosis can be divided into two parts: endemic mycosis and opportunistic mycosis. Endemic mycosis are those mycosis where the fungal pathogen is not the part of our human microbiota, but it is acquired from the environmental sources. Whereas opportunistic mycosis is those mycosis, as evident from the word itself, the pathogen is there in it's a part of normal human flora, and because of various risk factors, which I will describe in the subsequent slides, they cause invasive fungal infections, more common being Candida and Aspergillus. This is again like just the same thing. Now, endemic mycosis also we don't see commonly in oncology patients, but what I wanted to emphasize from this slide was that sometimes these endemic mycosis are cancer mimics. Like patients will come to us with a high grade suspicion of malignancy, but the biopsy is not susceptible or suggestive of malignancy. Then at least you should think that these funguses, particularly histoplasmosis or penicillinosis or sporotrichosis, these are quite common in some parts of our country. If you take a good travel history, good endemic from where are they, what sort of activity they do, and if the biopsy is not suggestive of malignancy, you should look into these like pathologies. Opportunistic mycosis is the bread and butter of the fungal infections in oncology setting, where funguses like Candida, Aspergillus, Pneumocystis, all these things come into picture. Now, coming to epidemiology from India, in oncology setting is very limited. I found one paper which spoke about epidemiology of fungal infections in India, serious fungal infections in India. And if you look into the middle column, which speaks about cancer and immunocompromised patients, the top 4 pathogens or top 5 pathogens include candidemia, that is the most common, followed by mucormycosis, and then invasive aspergillosis, and then pneumocystis. These are, and at least it's a very, in itself is a comprehensive list. This is because that is what we see also in our setting as well. Most commonly Candida, then followed by mold infections like mucor or aspergillus, and then pneumocystis. Now in my talk, I will just concentrate on these 2 pathogens only, that is Candida and Aspergillus, because that is the most common and that should be suspected, treated early, and diagnosed correctly. So opportunistic fungi basically means that they take an opportunity while we discuss about whether cancer treatment is required or not, cancer treatment can be withheld. All these discussions are going on between an oncologist and the patients. The opportunity is taken by the fungus, and the fungus basically invades the patients and cause a lot of problems. Now, candidiasis and its variants, basically candidiasis is a normal human flora, part of normal human flora. So it is a colonizer. So Candida can grow from respiratory secretions or from urine. It can cause mucosal diseases like oral candidiasis, which is very common. Typically, everybody has seen it. It can cause vulvovaginal candidiasis. It can cause invasive candidiasis, and it can cause candidemia, that is blood culture is positive or a typical presentation of a sepsis. Now, what are the risk factors? In short, risk factors are any hospitalization for any cause is a risk factor for candidiasis. Then because of the hospitalization, there is alteration in the normal flora by use of some or the other antibiotics. And antibiotics does not mean just giving, antibiotics means not only antibacterial agents. A lot of these patients receive chemotherapeutic agents. Chemotherapies are actually much more harmful for the normal flora of our body, because they are targeted to treat cancer cells, which are much larger than the bacterial cells. And the cancer chemotherapies, unfortunately, are not very selective, so they kill the bacterial or the normal microbiome of the human body also. So even if you see that the patient has come with has been hospitalized and given cancer chemotherapy, no antibiotics have been given, still he or she may be a risk factor for developing fungal infection. And then we do interventions like putting a central line, Foley's catheter on. And then as discussed in the first talk, most of these patients are inherently immunodeficient. So all this becomes a big like cycle, vicious cycle, and this leads to predisposes one to develop candidemia. And most of these, as you could picked up from the four circles, they are mostly iatrogenic. Now, this by the book, these are the risk factors of the for disseminated candidiasis, that is exposure to broad spectrum antibiotics, which most of the patients are already on. Most of our patients are on indwelling intravenous catheters, either in the form of central line, like from the neck, or from the peripherally inserted central line, or they have a chemo port. So these first two points are mostly ticked up. Then some of these patients are on hyperalimentation fluid. Some of them undergone a GI surgery, thoracic surgery. Some of them are neutropenic, and so most of these risk factors are already present in oncology patients most of the times. Candidemia can present as a thrush, vaginitis, esophagitis, balanitis, gastrointestinal candidiasis, and they can also present with cutaneous manifestations like diaper rash, folliculitis, and sometimes these skin nodules which are shown in the picture are a manifestation of a disseminated candidiasis-like picture. So this diagnosis of all these cutaneous or superficial candidiasis is generally by clinical examination itself. You don't need invasive testing. Very rarely do you need a culture also. Most of the times they also get treated very easily by topical antifungals or sometimes short course of systemic antifungals as well. So we are not worried too much about it. In very exceptional cases, we may be required to do some invasive testing in this scenario. But what we are more worried, and particularly in ICU, is the deep organ candidiasis, which can present with CNS manifestations, very rarely pneumonia, endocarditis, hepatosplenic candidiasis, peritoneal candidiasis, bone and joint infection, pyelonephritis, ocular candidiasis. And all these complications can happen when you see a blood culture report which shows candida in that. So basically it means that candida can disseminate and can cause all these syndromes. And diagnosis of this requires invasive sampling. So when to think like your patient may be having candidemia, prolonged hospital stay, exposure to broad spectrum antibiotic, he or she has lines, recent surgery, neutropenia, and high colonization index. So what is the meaning of high colonization index? Is your like samples from the non-sterile sites like ET secretions, sputum samples, urine samples, or some swabs which has been taken are coming consistently high positive with candidemia, okay, or with candida. So it does not mean that they are having candida, but it means if the other risk factors are present and the patient is having some problem, which makes you suspect that the patient may be having invasive candidiasis, and plus he or she has candida from the urine or candida from the ET secretion, then definitely you need to take this into consideration. That means high colonization index is there. Candidemia generally present with fever with no localization, or it can present with septic shock with any of the above risk factors, like we see in any bacterial sepsis. They can present with septic shock, in which particularly PCT may be negative or in the borderline state with negative cultures and not improving on antibacterial cover. This is when you should definitely think that patient may be having candidemia. Now, traditionally, candidemia is diagnosed by doing blood cultures. Fortunately or unfortunately, still we are dependent on blood cultures only. But the problem is that the yield of the blood culture is quite low. Even if you send the blood in the fungal culture bottles, which are specifically made to pick up funguses, but the difference in the yield or the extra benefit is very marginal. So routine blood culture generally pick up candidemia. But the important point to note is there that you have to send this bloods in adequate volume. If you don't send blood in adequate volume, then the sensitivity decreases down further. So at least a 40 ml of blood should be sent in 4 bottles if you're suspecting invasive candidiasis. Now, there are various non-culture based methods which are available for diagnosis of invasive candidiasis. They are not perfect. Some of them are not available, like Menin antibody test is not freely available in India. Beta-D-glucan is available and most of us have. We also have in RGCI. Then there is a PCR panel for candidemia, and there is a T2 candida panel, which again is quite expensive. And currently, as of now, what I know is it's not available in India. So there are culture-based method, which I spoke about, the gold standard, which identifies the species, gives you a sensitivity report with the perfect, this is what you want. But the problem is they have a slow turnaround time and they are of low yield. Non-culture based methods are rapid. The results come out in few hours. Problem is they are not accurate. The data is still in the making. Like we still are, a lot of new papers each year come up, and the level of recommendations also keep changing. They does not identify the candida to the species level, and they are quite expensive as well. One of these markers is beta-D-glucan. Beta-D-glucan is a very good rule-out test. Like it's a serum, you can do this beta-D-glucan from a serum sample. It is approved for serum sample only, although research is going on to see if we can use it in CSF or even bronchoalveolar lavage sample also. But currently it's approved for only serum sample. It's a good rule-out test. It is not organ specific. It rises in any fungal infection except for mucor and crypto. And it has a lot of false positives, which include use of hemodialysis, albumin, blood products. And most of the patients, which you could have understood, most of these oncology patients are on these kinds of therapies, albumin, IVIG, blood products, and also false positive beta-D-glucan is quite common. And it's a very common problem that you're suspecting fungal infection, beta-D-glucan has come positive. Now you think that patient is having a fungal infection and you want to start antifungals. Starting antifungals is not an issue. Point is whether we conclude that this patient is having this current problem is only because of fungus only. That is very difficult to say. That's where the challenge arises. This is one of the first papers from India, which we published, and we established the following point that the sensitivity and negative predictive value of beta-D-glucan is quite high, 97% and around 88% respectively. And the use of beta-D-glucan can be used as an antifungal stewardship marker where we can stop the antifungals if the beta-D-glucan is negative. Now, management of candidemia, basically, whether it is neutropenic, non-neutropenic, principles of management of all these fungal infections remain largely similar. Echinocandins are the drug of choice. If the patient is improved and if the fungal isolate is susceptible to the azoles, then the echinocandin can be switched to a lower, or can be basically de-escalated to fluconazole or even voriconazole, depending on the susceptibility report, and if provided the patient has improved. Recommended duration is generally around 2 weeks from the last negative blood culture report, and the recommendation is to remove the central venous catheter as early as possible, and whenever it is presumed to be safely removed. Now, for 2 weeks is a general recommendation for candidemia, but if the patient is having metastatic complications, like the patient has developed endocarditis, CNS infection, ocular infection, bone and joint infections, or renal parenchymal infections, then the duration of the therapy may increase, and the drug of choice may also move from echinocandins to liposomal amphotericin B. The problem with echinocandins is that there are a lot of century sites. Echinocandins don't penetrate into CSF, like they do not pass the blood-brain barrier, and also they don't attain good concentration in the ocular tissue as well as in the sometimes in the renal like urinary tract also. So echinocandins can be not a good therapy for these three syndromes. So culture positive for candidemia, which may be ignored. So again, a very common problem in ICU. Patient got intubated, ET secretion was sent for culture, and it has come out to be candida. So what to do? So most of the time, any secretions from the sputum, TT secretions, ET secretions are generally suggestive of colonization. Even urine cultures are generally suggestive of colonization, need not be treated unless and until you have a very great suspicion or very high suspicion of invasive candidiasis, in which you want to start antifungals empirically. Now, what should never be ignored? You should never ignore a candida from the blood and other sterile sites like CSF, ascitic fluid, pleural fluid, or sometimes even a sample which has been taken through an invasive sampling like pus and all. So this is where we need to treat. But common scenario is where we see a candida from the non-sterile sites like urine or sputum samples. Now coming to mold infection. Now, this is a very common scenario in hematological settings. Febrile neutropenia after ALL induction, first block, fever not responding to antibacterial agents for past 5 days, and cultures are negative. HRCT is done, which shows a nodule with a halo sign, and serum galactomannan is 2.1. So this is a very a common, very classical case of invasive mold infection in a hematological setting. Just to ask, how many of you classify this as what do you classify this fungal infection as? Whether this is probable, possible, or proven? Proven? Possible? Okay. So in order to classify, this is basically a probable infection only, probable IFI. In order to classify this, there is a classification criteria which is well established, and it is there. So I will discuss that. Now, when should we think, or how should we go about diagnosing invasive fungal infections in these kinds of patients or invasive mold infections? You have to start with history. History means taking all the risk factors into account, whether it is oncology or non-oncology. Mind you, a lot of non-oncology patients also have comorbidities like rheumatological diseases. They are taking steroids for other reasons. And nowadays, a lot of advancements had happened in oncology setting, which is very difficult for anyone to keep up to date. And a lot of these patients receive other other monoclonal antibodies, bispecific therapies, CAR-T and all, which predispose these patients to various fungal infections also. So a good history of what the patients have taken earlier for the management of not only oncological conditions, but also non-oncological conditions is mandatory, as well as history of diabetes and drugs used to manage diabetes is also very common, very important. So all these factors which are mentioned in the list are risk factors for developing invasive candidiasis, which includes neutropenia, hematological malignancy, stem cell transplant, solid organ transplant, use of steroids, which is very, very common throughout practice, not only in oncology, but in non-oncological setting, whether it is rational or irrational. A lot of patients are on steroids for various reasons. Then other T-cell immunosuppressions like calcineurin inhibitors, TNF-alpha inhibitors, and other monoclonal antibodies. Then newer drugs like ibrutinib, eclabrutinib, all these things. And recent diagnosis of acute GVHD for which steroids were used. All these are the primary risk factors for developing invasive mold infections. Now, these are the classical radiological features which you will see or described in books. Halo sign, where you see a nodule with a halo or the ground glassing opacity surrounding that nodule. Then there is a air crescent sign where you clearly see a crescent and then the consolidation around it. Then the reverse halo sign where there is in the center there is a hypotensity surrounded by a hyperdense shadow. Now, all these radiological features are suggestive of invasive mold infections, not classical of invasive mold infections. Now, second criteria is mycological evidence. Mycological evidence basically arises from a culture sample or from a biomarker like galactomannan, which I showed in the case. So we had a radiology picture. First, we had a history that the suspicion is there. Then we have a radiology. Then we have the biomarker or the secretions or the sample which prove that there is a fungal infection is there. Now, drug of choice for invasive aspergillosis is clear that it is voriconazole, and for which TDMs are mandatory and need to check about the interactions of these drugs. So as I said, we start with history. Will we take all the what treatment the patient has taken, what treatment he is going to take. Also, it is important what is the plan from the oncology team. That also is important. Then you, based on the radiology, you decide whether the patient is having suspicion of fungal infection or not. Then you do either a bronchoscopic alveolar lavage if the IFI or IMI is suspected in the lung, or you send a serum biomarker like serum galactomannan and all. Or if the suspicion is in the CNS like brain fungal infection, then you can even send a galactomannan in the CSF as well. There are various cutoffs which are ready-made available on the internet, which you can look into it. So in order to diagnose a probable IFI, you need a history. You need a compatible clinical, radiological, nasal endoscopy, bronchoscopic findings, and you need some mycological evidence. For this, if this is fulfilled, then it is probable IFI, like I showed in the case. For a proven IFI, you need a culture positive fluid from a sterile sites like blood, CSF, or pleural fluid, or you need a biopsy sample that is a histological evidence of fungal organism which is demonstrating invasion. So the case which I showed was a probable IFI, not a proven IFI. But in hematological setting, because doing a biopsy is very difficult, or sometimes even doing bronchoscopic biopsies are also difficult. So most of the cases are actually probable IFIs only. My slides are not moving. So, yeah. So diagnosis of IFI, I just wanted to emphasize repeatedly. My emphasis was that you should definitely look into the background conditions and clinical presentations. Looking into the biomarker or a CT picture in isolation will not be the complete, which will basically fool you sometimes. So all this depends on your clinical suspicion. If the suspicion is quite high, so this is a classical setting: high risk hem-onc patient, AML, LOHCT, prolonged febrile neutropenia despite antibiotics with radiological abnormality and a positive fungal biomarker. These are classical settings. If that settings is fulfilled, then the biomarker report becomes quite important. If that setting is not fulfilled, then please take your biomarker report with a pinch of salt. Now, in order to demonstrate this further, I will discuss two more cases, which will emphasize this point more. Case vignette 1 is 26-year-old male with AML, 2 months into LOHCT, who has been developed gut GVHD, for which he has received steroids, MMF, and cyclosporin, and seroposaconazole prophylaxis. Now he has come with fever for 1 week and mild cough, nothing much on exam, and he is not neutropenic. Case 2 is a 16-year-old male who had aplastic anemia, had LOHCT 2 years back. Currently he is not on any immunosuppression, but he has come with history of fever for 3 weeks, cough, weight loss, and loss of appetite. Nothing much on exam, non-neutropenic. He has taken amoxicillin for around 7 days, and basic labs are basically normal apart from raised ESR. And LFT shows reversal of AG ratio. This is both the case vignette 1 and case vignette 2 X-rays. Case vignette 1 X-ray remains largely in okay. Case vignette 2 X-ray showed some nodular opacity which are distributed all around the both the lung fields. Now CTs of both the patients are done, which shows multifocal consolidation with halos in the first case, and there are again multinodules with cavitation in the second case. Discussing with the radiologist without giving them the history, that's an important problem which we do, common mistake which we do. We just ask the radiologist, what do you think? Without giving them the clinical scenario. For both of them, their answer was, it looks like fungal. So for case vignette 1, we did a serum galactomannan, which was 2.9. We didn't go for bronchoscopy. We shift from syrup posaconazole to tablet poriconazole. Immunosuppression was decreased and chest symptoms improved and fever responded within 2 weeks. For case number 2, his serum galactomannan was negative. Bal galactomannan was 1.3. Fungal filaments not seen. Culture was negative, gram stain negative, AFB stain negative, and he was started on empirical voriconazole because the radiological finding was more in favor of fungal infection, and Bal galactomannan was 1.3. But patient did not improve. Later on, gene expert MTB was detected, AFB culture was asked for, and was started on ATT. Later on, AFB culture was also positive. So our first patient was classical case of high risk patient who had developed GVHD with steroids and developed fungal infection, whereas case number 2 did not have any risk factor for developing invasive mold infections. He has come from the community, although he has received central transplant, but he's currently not on any immunosuppression. So classical case of tuberculosis, basically. Now, there is a lot of emphasis on radiological findings. Halo sign is a CT finding, and I mean, this is quite clear from the picture which is there. Reverse halo sign is again just total ulta of the halo sign, where the hypodensity is in the center and there is hyperdensity surrounding it. Halo sign is classically represented with aspergillosis, but again can be seen in many infections, including fungal, viral, bacterial also, not a very specific sign. But if the patient is fulfilling all these criteria, then it is quite specific for aspergillosis. Again, reverse halo sign, more classically like named as signs of mucormycosis, but again can be seen in many infections, including non-infectious conditions like Wegener sarcoidosis also. But it indicates mucormycosis if the risk factors are present. Now, sometimes we are forced to differentiate between mucormycosis and aspergillosis, particularly in those times when isavuconazole was not available. So mucormycosis is more classically associated with reverse halo sign, more than 10 pulmonary nodules, pleural-based nodules, and wedge-shaped opacities, whereas aspergillosis is more common or more likely if it is halo, central lobular nodules, peribronchial consolidation, or bronchial wall thickening. Now, there have been some change where they have increased the radiological pictures because the radiological pictures were quite insensitive. So interpretation of radiology is highly dependent on pretest probability. Only radiological scenarios are generally misleading and can be problematic for the patient. This is again a very small scenario. 57-year-old male with multiple myeloma, post autologous stem cell transplant, and after that he has relapsed and received a lot of anti-myeloma therapy, including daratumumab, lenangio, and dexamethasone. Now he has come with fever, cough, and all, and with CT picture suggestive of some nodules. Now, if you go back into the history, there is history of cough, breathlessness for last 7 days. Wife also has a history of cough and sore throat for last 2 days. And patient has bilateral wheeze or rhonchi. They are conducted, basically there are bronchial airway sounds. And we do a flu panel which shows RSV. So radiology would have pointed you out into this, that it could be a fungal infection. Patient had some risk factors also, but a careful history and a good vigilant test has actually saved the patient from misdiagnosis of fungal infection. It's a simple viral infection which settled down in few days. So a strong clinical suspicion, radiology of fungal biomarkers, you can do this simultaneously or sequentially, ruling out the other causes of radiological changes, and sometimes, if possible, do an invasive sampling to complete your diagnosis of invasive fungal infection. But again, wanted to emphasize the same thing, do a good history exam, look into the immune defect of the patient, duration of neutropenia and all, estimate a pretest probability in your mind, then look into the, then order your fungal biomarkers, interpret them with this thing into picture, not like, assess whole in isolation, and then make a diagnosis. Then basically you can decide on choice of antifungal, which you want to treat, whatever the biomarkers are suggestive of. Thank you.
Propofol is usually used for ICU sedation. Propofol is usually used for ICU sedation. So, and on the marking, there's a marking on the label for propofol that beware of infections, especially fungal infections. So, how common is it? Have you encountered any fungal infections associated with the mishandling of propofol or prolonged use, or it's been left outside for more than 8 hours and you've encountered a fungal infection directly due to propofol?
So propofol, what I understand from a general medicine background, basically is quite lipid. There is
It's
a lot
a
of
lipid emulsion.
lipid emulsion.
Yes.
So any lipid emulsion molecule are prone to get fungal contamination. So one is propofol infusion because of the contamination of the vial itself can happen. So that is there. But although we have not encountered, I have personally no encounter.
Just wanted to know practically, is it really common?
No,
You
very
see it?
I have not seen. In fact, I only read in books. I have not encountered it, or I have not seen someone
If
describe
he
it.
is not seen, then it is not common.
Thank you, sir. A great seeing is believing.
When we suspect a fungal infection, I'll give an example. 75-year-old male, a diabetic, hypertensive, prior history of CAG, asthma, has been visiting Dr. Rajiv Goel, so that means on and off steroids. Got some chemotherapy. Is on day 7 comes to you with neutropenia, not responding to fever. The chemo is moderately, so we have given, so it is moderate to highly neutropenic. So when would you suspect that?
No, I mean, sir, in this case scenario, also first diagnosis would be either a viral or a fungal or bacterial infection only. Fungal infection will be third or fourth priority only, because this is not a common scenario for fungal infection. Common scenarios which I described in the slides was hematological malignancies, prolonged neutropenia and all, or a recent surgery in like GI surgery and all. Generally, solid organ tumors are not known to cause, but unless and until there is a risk factor, specific risk factor, which includes use of steroids or uncontrolled diabetes, that is also quite common and misdiagnosed, like not picked up. Sir.
Because the culture takes time and we cannot rely on the biomarkers. So is there any PCR-based test available and can we rely on it?
PCR-based tests are available, sir. PCR-based tests are being marketed also, but unfortunately they are not well studied and not validated. So my personal, evidence-based answer is that you should not be using them upfront for every case. For exceptional cases, like if you are really stuck up, you are not able to diagnose, then you can use them. But for routine use, for day in, day out, like garden variety cases, you should not be using, because they are prone to be oversensitive because of the very nature of the PCR itself.
So in a lighter vein, good morning to all of you. I was told that I have to chair a session on surviving sepsis guidelines 26. So last 1 week I have been, revising my own guidelines. यहाँ पे आके कुछ और बता दिया. तो so I think I suspect this is what has happened with the other 3 also. So, but I think that listening to Nitin is always a pleasure, and the crux of the problem remains the same. The fungal infections, it basically, if you enlarge this whole scenario, the basic principles remain the same. When a patient comes to you, you think, is it a definite sepsis? Is it a probable sepsis? Is it a possible sepsis? Or is it an unlikely sepsis? Same thing holds with fungal infection also. So you will put everything in place. You will always have the clinical scenario in mind. If you ignore this clinical scenario, you are at the risk of over-treating or under-treating. On the other hand, if you keep the clinical scenario in mind, then all the other factors like biomarkers, the radiological signs, all these start making more sense. So I think he has shown very nicely in all his cases that, how different 2 cases can be depending on the clinical setup with very similar radiological pictures. And I would reiterate the point that make it a point to, kind of converse with your fellow colleagues, the radiologists, the pathologists. They are the ones who need all the, clinical scenarios before they can give you accurate feedback. So I think well spoken, and I think all the points are very well made. Thank you very much.
ICUs, they have very, very high rates of, fungal infections. This is the common perception. Wherever we go, everybody is talking about since cancer patients. So Dr. Neelam is with us. I think she can tell something about the incidence of fungal infections in our hospital.
Is there?
Yeah, she's absolutely right. Whenever we go to an onco hospital, we always think that we'll have enough amount of fungal infections because all the patients are immunocompromised. But in contrast, when we go to microbiology department, we'll find that you don't isolate as much as is expected, because majority of the patients, when we talk about hematological, they'll be on fungal prophylaxis. So once you're on prophylaxis, you don't expect anything to grow. So by any means, we'll have to depend on biological markers like the serological biomarkers we have to depend upon, but then you have to rely on, if anything is like borderline, don't jump on to a conclusion that it is fungal only because it's giving little positive. So unless and until it is high, nothing is growing in culture, because patient is on prophylaxis, sometimes we can see, but nothing will grow. So, like KOH is another thing which we can always think about. And another is we have to rely on biomarkers also. But definitely if the values are high, not the borderline kind, because we normally don't see much. And even if they grow, majority of the time it is either Candida auris or non-albicans, which is usually resistant to majority of the antifungals.
And you have to rely on a person like Nitin Bansal to tell you, stop this, stop this, stop this, and stop this. So, basically.
Start something. He tells you
And-
that also.
And
Say
please,
anything.
please stop.
Stop
this.
everything.
Please stop.
He'll
I
tell you,
think
stop
his
antibiotics.
rounds in the hospital are more, he's more concerned with stopping, drugs rather than actually adding drugs.
The problem with the use of galactomannan and these markers, especially in a onco setup, is that you have already a patient on antifungals. And once you have a antifungal, a mold active agent, the sensitivity of the galactomannan test drops down drastically from 85% to maybe 40, 45%. And then you may have a low galactomannan value in your BAL. And that is a problem. By the time, I mean, both as an intensivist and a pulmonologist, when I get a reference and I take a lavage, and then everybody is debating about the galactomannan values, though you have all the features, the patient already is on a prophylaxis. They were empirically started in any immunosuppressed patients, hematological malignancies, you start antifungals, febrile neutropenics, all these patients are already on antifungals. So that is a big challenge for, in the treatment. I mean, that thing needs to be assessed, and, experience matters definitely in these cases. But yes, we have to see that limitation also when we are interpreting a galactomannan value.
Valid point, sir. I mean, that is.
Yeah,
a matter
I
of
think we
research.
can wind up the session. We are running short. And thank you, Dr. Nitin. Thank you, all the chairpersons. Can we just, for a group photo, can we have over here? Yeah.
अरे भाई फोटो लेने जरा दोबारा चलो
Sorry for the goof up. वो है
one
ना?
second, one more, one with me क्योंकि background अच्छा आप भी आ जाइए आप भी आइए
After such an insightful session, we will now move to our next session, which focuses on cytokine release syndrome in hematology settings. And to guide us through this scientific journey, it is my absolute pleasure to invite our chairpersons to the stage, Dr. Dinesh Bhurani, Director of Hematology Oncology and BMT Department, Dr. Shalini Mishra, Consultant, Pediatric Oncology at Rajiv Gandhi Cancer Institute and Research Center, Dr. Narinder Agarwal, Senior Consultant, Hemato-Oncology and Bone Marrow Transplant, and Dr. Sandeep Jain, Associate Director, Pediatric Hematology, Oncology and Bone Marrow Transplant. Please welcome them with a round of applause. I will like to request our chairperson to please introduce the speaker. Thank you.
So you had a sepsis, now you have a cytokine release syndrome. So I think the CAR T cell use and bispecific use is going to go up. So wherever there is a hematology, you will have a more of a cytokine. So it's not unrelated to the ICU. The majority of the patients, many of the patients may land up into the ICU. So I think we may not have learned before, we may not have seen the patients with the severe CRS before. Rohan is going to talk about it. He's part of our team here in Rajiv Gandhi. He's been here for 8 years and has a significant experience dealing with the cytokine release syndrome. Rohan, yeah.
So thank you for the kind introduction, sir. So I think Dr. Nitin has given you a good overview of what we end up doing with our patients, and I'll be telling you why do the patients end up with such bad infections, and that is because a lot of us we deal with cytokine release syndrome day in and day out. I'll be just taking you through the various scenarios that we come across in our day-to-day practice. As far as I can remember, cytokine release syndrome has been recognized for quite some time now. A lot of you would have seen it in your practice as well, but probably you wouldn't have known that it's a cytokine syndrome that you're dealing with. So give you an historical perspective, it was previously referred to as an influenza-like syndrome that occurred following systemic infections like sepsis or after immunotherapies like Coley's toxins. So this is Dr. William B. Coley, and he actually found that these patients who had this basically lymph nodes, after an attack of erysipelas or a repeated attack of erysipelas, these lymph nodes used to disappear. These lymph nodes were basically on biopsy were termed as round cell sarcomas. That was somewhere in the end of 19th century. It was obviously a misnomer. But what he thought is probably he could inoculate this erysipelas. Erysipelas is caused by Streptococcus pyogenes. And by inoculation of these erysipelas, these lymph nodes would disappear. And he was sort of the founding father of immunotherapy, which we know and which we use nowadays in most of our malignancy patients. More recently, if a few of our senior colleagues would have encountered infections with pneumonic plague, which is caused by Yersinia pestis infection, where the pathogen leads to release of lot of cytokines in the alveolar macrophages, which leads to a ARDS-like syndrome. In and outside the ICU, you will see very commonly influenza infection causing an ARDS-like syndrome and cytokine release syndrome. And more recently, let us not forget COVID-19, which was associated with cytokine release syndrome, usually by the end of the first week, where we had to use a lot of immunosuppressive therapies and steroids. So to define cytokine release syndrome or cytokine storm would be a life-threatening systemic inflammatory syndrome, which involves elevated levels of cytokines in the blood, and there's an immune cell hyperactivation, which can be due to either therapies, pathogens, cancers, autoimmune disorders, or any monogenic disorders. Three features are principal in cytokine release syndrome. That is, there is elevated levels of circulating cytokines, there's an acute systemic inflammatory symptoms, and there may or may not be, if left untreated, there will be secondary organ dysfunction, which may be attributed as a normal response to pathogen, but in cases of therapies, there is no pathogen that is identified. So when you look at the clinical presentation, initially the presentation is very non-specific. There will be fevers in almost all cases. There may be a rash, there may be rigors, malaise, fatigue, anorexia. There can be neurologic symptoms, which we sometimes, when used in the setting of CAR T cell therapy, we term it as ICANS, that is immune cell associated neurotoxicity syndrome. There can be liver toxicities. There can be change in the blood parameters. That can be pancytopenia and anemia, neutropenia, thrombocytopenia. There can be coagulopathy and DIC, disseminated intravascular coagulation like state, and hypofibrinogenemia. There can be increase in the blood pressure. There can be fall in the blood pressure, widened blood pressure, pulse pressure, sorry. and there can be arrhythmias, and sometimes the patient can develop a stress-induced cardiomyopathy known as, which we know as the Takotsubo like cardiomyopathy. Patients can also develop tachypnea, hypoxia, and can land up in ARDS. There can be fall in urine output and then development of AKI. Now let us understand what happens what happens in a normal immune in a normal inflammatory or an immune response. So when you have a pathogen here, which is a pathogen here that is identified by the antigen presenting cells in the body. These antigen presenting cells are restricted for major histocompatibility complex, and they usually, in this case, as you can see, this LCMV is a lymphochoriomeningococcal meningoencephalitis virus. It presents to the healthy CD8 cytotoxic T cells. In response to this antigen presenting cells, these T cells undergo clonal expansion, which is aided by cytokines like interleukin-2, interferon gamma, and TNF alpha. As a response to the cytokines, the cells undergo clonal expansion. They also, act as signaling molecules for other allied and other inflammatory cells. And once these cytotoxic T cells are able to, kill the pathogen by the granzyme perforin pathway, there are negative regulators of the immune response, following which there is viral clearance and the number of T cells go back to being normal. So there's a positive feedback loop by the cytokines, and there's a negative feedback loop as well. Now, what happens in a cytokine release syndrome? There can be multiple factors involved. For example, the cytokine release syndrome can be due to iatrogenic causes like falling CAR T cells or bispecific T cells, bispecific T cell engagers, or falling immunotherapies. There can be either pathogen triggered, like as a response to bacterial sepsis, or following an EBV related HLH, or can be due to any primary HLH or any autoinflammatory conditions. So you have the cells of the adaptive immune system and the innate immune system, as I had previously mentioned in the previous slide. And the crux of the pathophysiology involves immune hyperactivation, which can be an inappropriate triggering of the immune system, where the immune system is hyperactive in the absence of a pathogen, or there can be inappropriate amplitude in the immune hyperactivation, where the CAR T cells are identifying the tumor, and they are able to multiply in large numbers and releasing a lot of cytokines. Or there can be ineffective amplitude of immune response, which is seen in bacterial sepsis, or there can be failure in the inflammation and return to homeostasis, which is usually seen in the setting of HLH, where there is a genetic disorder and there is a absence of the negative feedback regulators. So what happens is, you can see there are various cytokines that are involved in the cytokine storm. And here you can, if you can identify, you can appreciate that a lot of therapies are directed against the specific cytokines. All these cytokines are pathological and in higher numbers, which lead to prolonged activation of the signaling pathways and lead to acute systemic inflammatory effects, and can lead to secondary organ dysfunction and ultimately death of the patient. These are the various cells that are involved in the cytokine storm, and depending on what condition or what setting we are dealing with, these cells and their respective cytokines are involved. I'll be giving you what are the settings that we see. Most of the cases here are iatrogenic or following therapies. So the first setting is following CAR T cell therapy. This is a normal T cell. We have a T cell receptor here. And most of these T cell receptors are class restricted for major histocompatibility complex. And since a lot of tumors express these major histocompatibility complex, the T cells cannot really control or kill the malignant cells. Chimeric antigen T cell is genetically modified T cells. The word chimeric comes from the Greek mythological creature chimera, which is a three-headed creature, which includes a serpent, a goat, and a lion. So here, basically, that T cell receptor has been modified to have a signaling domain, an antigen recognition domain, and a target domain. The target here what we commonly which we use is CD19, which is directed against CD19 positive leukemia or the lymphomas, or the B cell maturation antigen in myeloma. And since these, and the process basically involves that we collect the T cells first, and in the lab, these T cells are genetically modified to produce this chimeric antigen T cells in the lab, and these cells are then multiplied, and following a small schedule of chemotherapy, the cells are then infused back into the body, where the CAR T cells, look for the cancer cells and they go on to kill them. So what happens is, after the chemotherapy, once the CAR T cells are infused, at a median of about 2 to 7 days, the CAR Ts multiply in large numbers. They release because of multiplication, and since these CAR T cells are not MHC restricted, they do not need any cells of the innate immunity for activation. They get activated just on exposure to any of the CD19 positive or BCMA directed cells, and they increase in large numbers, and because of which we see fever and whatever the fever, rash, hypoxia, hypotension, as had mentioned in the clinical features of cytokine release syndrome. The second setting is following biallelic T cell engagers. These are monoclonal antibodies which are directed against one, that is the normal T cell, and the tumor cells. So this is an example for teclistamab, which is a bispecific T cell engager directed against CD3 and B cell maturation antigen on multiple myeloma cells. What these antibodies, monoclonal antibodies, do is they bring the T cells in close contact with the myeloma cell to create an immunological synapse, which leads to T cell activation and then tumor cell kill. The third setting is following allogeneic stem cell transplant, where basically we remove the stem cells from the donor. The patient receives a chemotherapy regimen to deplete the residual, the host hematopoiesis, and then we infuse the donor cells which you have taken into the patient. Prior to a transplant, we usually do what we always do is a HLA matching for the patient and for any of the siblings. If you are lucky, you might find an HLA identical sibling, where you can see that both the HLAs on both the alleles are matching with this sibling. But if you don't have an HLA identical sibling, as we move toward more nuclear families, you may have to depend on haploidentical sibling, where you can see that the HLA here is matching with this, or you can see the HLA here is matching with this sibling. So in this setting, as we have started doing a lot of more haploidentical donor transplants, so after conditioning chemotherapy on day 0, when we infuse the T cells, because of the haploidentical match, because there's a haplotype match, the donor T cells multiply, and since we use a lot of peripheral blood grafts, the peripheral blood has a lot of CD T cells. There's multiplication of these T cells in the blood, which leads to a cytokine release syndrome, which after administration of, say, post-transplant cyclophosphamide and on day 3 and 4, usually it gets ameliorated. But if untreated, can lead to life-threatening graft versus host disease. The fourth setting after the transplant is again quite common in our setting, when the donor cells start to engraft and we see the rise in the blood counts. There can be appearance of non-infectious fever, rash, and fluid overload symptoms. This is another setting where we see a lot of cytokine release syndrome. Then the next setting is in the setting of graft versus host disease, again, which develops when these stem cells, which we have infused after the transplant, they go on to develop new blood cells, and also they form the new cells of they go on to form the cells of the immune system. And since these immune cells that are there in the graft, they recognize the host antigen presenting cells as foreign. Because of that, there can be again, cytokine release syndrome. There can be fevers, rash, and which can manifest as graft versus host disease in the form of loose motion, skin rashes, and jaundice. Another setting is in hemophagocytic lymphohistiocytosis. I've shown you the normal host immune response, but what happens in HLH is that, again, if you have a patient with primary HLH, there is a clonal expansion. There's a response to the antigen, but then because these T cells are defective, there's a problem with either the granules in the tissue or in the granzyme pathway, granzyme perforin pathway, which is an apoptotic pathway to get a control on the virus infected cells. This is defective, and this leads to just sustained T cell activation, which can lead to just viral persistence, T cell expansion, and cytokine production. And this is a less common setting, I would say, not a very common setting, but maybe once in 6 months, we might get a patient on HLH. More common, probably, I must say, in the pediatric setting. And sometimes we might see HLH as a result of malignancy as well. On the left of this table, you can see these are the primary, the genetic causes of HLH, which are seen most commonly in children. And you can find some secondary causes. Again, it can be due to infections, malignancies, or in rheumatological disorders. This is the HLH criteria, which is again used more commonly in the pediatric setting. You have either you identify a molecular diagnosis of HLH where you can find a gene that is defective and is associated with HLH, or if the patient has come to you de novo, you can have either five of this 8 criteria, and then you can give a diagnosis of HLH. In adults, we use the H score to usually the grade and to identify HLH. Again, there's a score that is given based on the number of parameters that we can identify. So if I have to say what are the common causes of cytokine release syndrome that we come across, very rarely we will see EBV-associated HLH, HHV, or idiopathic multicentric Castleman disease. I think I've seen just one case in the last 5 years. Primary HLH or secondary HLH will be probably, you would say, you could see once in 3 months, 3 to 6 months, you might see 1 or 2 cases. We are seeing more and more cytokine release syndrome due to CAR T cell therapy and blinatumomab or other bispecific T cell engagers. And of course, most commonly in the ICU would be bacterial sepsis. And then there are other honorable mentions, like previously we used to see a lot of cytokine release syndrome with monoclonal antibodies, ATG, differentiation syndrome when the patients are treated with all-trans retinoic acid and arsenic trioxide, and also with gene therapies. So as I said, the onset and duration of cytokine release syndrome is very variable, and it depends on the underlying cause. It is important to identify that there's a lot of constitutional symptoms in the beginning. There'll be a lot of systemic inflammation. There will be multi-organ dysfunction and immune cell dysregulation. In later stages, all of these manifestations will overlap and converge, and it's actually very difficult and impossible to differentiate from sepsis per se. And if all of this, if it is not identified in time and if it is not treated, it can lead to multi-organ failure. Coming to the lab abnormalities, rise in CRP is almost universal, especially in the setting of CAR T cell related CRS. It usually correlates with the severity. With HLH, there will be raised triglycerides and ferritin. In sepsis, you might find leukocytosis or leukopenia. For following CAR T cell, you could also find anemia, thrombocytopenia as a result of previous chemotherapy. There can be some coagulopathy with raised D-dimer. In the CAR T setting, again, there will be raised IL-6, and there are other cytokines like soluble IL-2, CXCL9, 10. All of these are not available to us, but they are all found to be raised in the setting of CAR T related CRS. So what is the approach to any potential patient? We'd always try to identify the underlying disorder. What are we dealing with? Is it a cytokine storm following a CAR T cell? If the patient has received any bispecific, or if the patient has come de novo to you and you are probably trying to look for sepsis, and if you're not able to find one. It's important that it's to keep infection high probability, because it is always sometimes you may start on therapy initially, but the patient can always can develop an infection while the patient is in the hospital. It is important to establish the severity of cytokine release syndrome depending on the setting and to determine the clinical trajectory. The workup includes usually we do a CBC to look for any abnormalities, liver function including coagulation profile, kidney function, and a metabolic profile. Always work up for any of infection, may be it bacterial, fungal, viral, because infection is always high on cards. In the setting of post-CAR T related CRS, we do an CRP, ferritin, and IL-6, and procalcitonin if there's a high possibility of a bacterial infection, and it's important to look at the trends of these markers rather than one single value, and the ABG, ECG, and other tests depending on the clinical status of the patient. But most importantly, it is impossible to distinguish CRS from infection. You have time? Yeah. So cytokine profiling is one option that we have. But this is not available to us, and we usually rely on these scores like H score, and this MS score for rheumatological disorders, and AST-CT scores. These are the differential diagnosis for CRS, and usually the principles of management is mainly supportive, and it is important to identify the underlying disease and eliminate any of the triggers which are linked to the abnormal immune system hyperactivation. We try to introduce targeted immunomodulation and non-specific immunosuppression, including steroids, and the aim is to limit collateral damage. So in the setting of CRS following CAR T cells, for grade 1 CRS is when there is only fever, there's no hypotension, no hypoxia. What we do is we send blood cultures, start on a broad-spectrum antibiotic, and give antipyretics and liberal fluids, monitor CRP, ferritin, LDH, and coagulation parameters, and monitor the oxygen saturation. More often than not, we are happy to give tocilizumab to prevent this CRS from progressing to say grade 2 or grade 3. In grade 2 or grade 3, we do all of the above, give tocilizumab, and if the patient is deteriorating, start steroids as well. If the patient is going to grade 4 CRS, it's a very ominous sign, and we have to increase the dose of steroids and go on to maybe use other therapies like siltuximab and anakinra and so forth. In the setting of HLH, again, if the patient is stable, we can wait pending evaluation, but if the patient is deteriorating, we start with steroids. So you can see that steroids is used left, right, and center with IVIG. And sometimes we have to, do the evaluation side by side. So often give supportive treatment, give steroids, check for any infections, and identify any trigger that is leading to HLH, and always keep reassessing the need for immunosuppression. Try to cut down on the immunosuppression because it is very difficult to identify what is the trigger for HLH depending on what we are dealing with. It could be either infection or a malignancy or an autoimmune disorder. So in HLH, we end up giving a lot of steroids, etoposide, cyclosporin, and so on and so forth. And again, in Castleman disease, we can see we use a lot of steroids and a lot of immunosuppressive agents. So I'll just end with the case if there's time. Yeah. So I'll be showing this case that where this patient had a lot of CRS in different settings. So this is a 43-year-old male, a resident of Nepal. He was diagnosed with BALL. He had this high-risk fusion, that is CRLF2 fusion. Post-induction, he was just MRD negative. The plan was the transplant. He wanted to take blinatumomab. So you started blinatumomab. Day 4, he had fever, headache, fatigue. Cultures were sent. IL-6 came high. He was given tocilizumab. The fever persisted and started on dexamethasone. The antibiotics were stopped. He completed rest of the blinatumomab, and the bone marrow came MRD negative. So this was CRS due to bispecific T cell engagers. The patient underwent transplant. He was discharged following transplant. On day 20, he came back with fever, rash, and a sore throat. Skin biopsy showed grade 2 GVHD. He was started on steroids. Within 48 hours, the fever was gone, and then the steroids were tapered. So again, we can see that this was a cytokine release syndrome, which was associated with GVHD and not an infection. He got again admitted after a month with fever and cough. Respiratory panel showed coronavirus infection. He was given IVIG, but the fever persisted. There was some pseudomonas in the urine, but obviously he had no urinary symptoms. It was treated for the same. We were not sure what we are dealing with. We consulted our ID physician, so we got a rectal biopsy, but there was a grade 2 GVHD as well. started on steroids, but the fever persisted. The ferritin came very high. There was onset of pancytopenia and also an appearance of a faint maculopapular rash and increase in urine frequency. Urine routine showed 15 to 30 RBCs. This was an HLS plus probably CRS associated. We don't know, maybe related with GVHD, but since there was a rash, we sent a post-transplant viral panel, which was positive for adenovirus. So we tapered the steroids, though we had a diagnosis of GVHD. We started on cidofovir and gradually the ferritin and the counts improved. So this was cytokine storm due to adenovirus infection. So the same patient at different time points had a cytokine release syndrome or a cytokine storm due to different etiology. So to summarize that this is a common cytokine release syndrome is a common in our practice. It can be mild and sometimes can lead to life-threatening situations. Most of the causes are iatrogenic, sometimes pathogen related or due to cancers or due to autoimmunity. Treatment is generally depending on the underlying cause and the pathology that is driving the disease. It is very difficult to distinguish between the protective and the pathologic causes of cytokine storm. And infections still remain a very important differential in practice while dealing with CRS. So it's important to keep looking for one. Thank you.
Thank you, Dr. Rohan, for a very exhaustive presentation on cytokine release syndrome. Are there any questions from the audience?
So Rohan, may I ask one question? So definitely now we have better understanding of cytokine release syndrome in last 5 to 10 years. Before that, our understanding about this phenomena was not that great. So the most common scenario where we are seeing CRS in our practice is post-haplo BMT, and when we infuse stem cells on day 1 or 2, the patient have high-grade fever. So in this scenario, when the patient had high-grade fever, chills, and rigors, we know that CRS is definitely a possibility, and it is the most common. But in your clinical practice, how do you decide when to use antibiotic in these patients? Because we know biomarkers may be misleading, patient may be sick, and we know it may be CRS, patient is neutropenic, but at the same time, we know that now if we start antibiotic, that we have a long way to go. When in your clinical practice you start antibiotic, and when do you start?
Usually in this setting, it is the patients when he has started conditioning therapy, he is relatively stable. The patients are relatively stable, afebrile. So we avoid starting any antibiotics, but always we make sure we send cultures. Very rarely the practice has rather changed that we don't start antibiotics for when we know that it is due to the fever is due to CRS. And though the conventional teaching has been that to start antibiotics for, when the patient is just neutropenic, comes with fever. But there has been a change in our practice in the sense that when we know that the patient has been stable previously, the fever has started after the infusion of stem cells, it has been a conscious effort to withhold any antibiotics. If the patient spikes fever maybe on day 5, 6, where we are still not able to find an cause for the fever, then probably we are inclined to start the antibiotics.
Just one more question. What are the biological factors that determine the severity of cytokine release syndrome? Like some patients get moderate CRS and some get high CRS within the same setting. So what are the biological features that determine
So that
CRS?
can depend on the number of T cells especially in the CAR T setting, that can be due to the number of T cells that are there, and also on the product that we are using. Because that is determined by the co-stimulatory domain that is being used in the CAR T product, and also by the tumor load that is present, because that serves as an antigenic stimulus for the CAR T cell expansion.
One small question. Could you tell us, sir, what is your opinion about the efficacy of the QSP predictive model for predicting the occurrence of CRS across different T cell therapies, like T cell activators?
I'm not really aware of that.
I think 25 or 26, it's been recently developed, and they tout it as a good predictor of predicting this.
Not very aware of this.
CRS.
I like to look at it, what it is. exactly.
Cytokine release syndrome. Okay, I think we shouldn't go into it.
Rohan, any prophylactic strategy you prefer to use for prevention?
Again, we have tried using prophylactic tocilizumab again, but I think again, it depends on the tumor load, whether you are dealing with in the setting of CAR T cells. Again, it depends on whether you are what kind of patient you are dealing with, whether the patient has active disease or not, or what kind of product that you are using. If you are using fractionated product, so again, fractionation of the product can lead to lower grades of cytokine release syndrome. So this is one setting where where using tocilizumab may be unnecessary and rather a wasteful exercise. So our practice has been more or less regarding using tocilizumab when for lower grades of CRS to prevent progression to a higher grade of CRS.
Thank you, Rohan. Thank you very much for the very exhaustive and very informative talk on CRS, which is nowadays very commonly seen in hematology practice, especially after uses of CAR T and bispecific antibodies where T cells are engaged. Thank you very much.
I think we'll take another 2 minutes to set the stage for the inauguration. Chandan.
He was ready for command. He was ready for your command.
Yes, yes. May I request Dr. Anuba to kindly start the inauguration proceedings.
Respected dignitaries, seniors, faculty, delegates, participants, and my dear fellow colleagues. A very good morning to all of you. On behalf of Rajiv Gandhi Cancer Institute and Research Center, myself, Dr. Anubha, extend a very warm welcome to each and every one of you gathered here today. We are here to inaugurate a landmark event, the Sep Onco Summit, held under the aegis of RGCIRC Code Program 2026, the Comprehensive Onco-Anesthesia Training Program. This summit carries a theme of immense clinical significance, recognizing sepsis in oncology. As we all know, sepsis remains one of the most life-threatening complications faced by cancer patients, a silent storm that strikes when our patients are already at their most vulnerable. Today's summit brings together brilliant minds in oncosurgical critical care and anesthesiology to sharpen our collective ability to recognize, respond to, and combat sepsis in the oncology setting. This is just not a conference, it's a commitment to better vigilance, better care, and better outcome for our patients. That is at least what we look for. So as we begin this journey of learning and collaboration, I would invite our distinguished guests to kindly come forward and illuminate the ceremonial lamp, a timeless symbol of knowledge dispelling darkness, of awareness triumphing over ignorance. May this flame remind us why we are here and inspire everything that follows today. I would now request our CEO, sir, Dr. D.S. Gangwar, Dr. Gauri ma'am, MD Niti Bagh, Dr. Rajiv Chawla, Dr. Prashant, Dr. Bikram, Dr. Talwar, sir, Dr. Nitin Bansal, and all seniors to please come forward for the lamp lighting. Chandan. Dr. Divan, sir. Dr. Talwar, sir, is there. Dr. Nitin Bansal, please come. Dr. Bikram, Dr. Prashant. Thank you, everyone. I would now request our CEO, sir, Dr. Dharmendra Singh Gangwar, MD Niti Bagh, Dr. Gauri Kapoor, to kindly take a seat on stage. Would also request our Director Anesthesia Department, Dr. Rajiv Chawla, our critical care heads at RGCI, Dr. Bikram Jyoti, Dr. Prashant, our very own ID specialist, physician, Dr. Nitin Bansal, to kindly join on stage. May I request Dr. Rajiv Chawla to kindly felicitate CEO, sir? I would now request sir to felicitate Dr. Gauri Kapoor, ma'am. Now, without any further ado, to set the stage right, I would request Dr. Rajiv Chawla for the welcome address.
Thank you, Dr. Anuba. Dear Dr. Gangwar, Dr. Gauri Kapoor, on behalf of the organizing committee, I welcome you all to this Comprehensive Onco-Anesthesia Training Program 2026. दोबारा बोलना पड़ेगा. When technology is the master, you have to repeat. Thank you, Dr. Anuba. Dr. Gangwar sir, Dr. Gauri ma'am, on behalf of the organizing committee, I take this opportunity to welcome you to the RGCI code program. The code we mean Comprehensive Onco-Anesthesia Training Program. So that is an acronym, abbreviation, code program. And this theme for this seminar today is recognizing sepsis in oncology. It is a conceptualization of these three young people, Prashant, Bikram, and Nitin. They put me forward to lead and execute the program. So if you find everything wonderful, they get the credit, but if there are lacunae, blame me because the execution is not proper. Why did we have this theme? You see, infection are the common cause of morbidity and mortality in cancer patients. The incidence of infection is found to be 9 times higher in cancer patients than the general population. And it is the second leading cause of death in cancer. So it is time we act now, we act fast, we act correctly. And that is exactly the purpose of our meeting today. The word coat, if you see, coat is primarily to protect. अगर मुझको ठंड लग रही है मैं कोट पहन लेता हूँ, it protects me. If my furniture or this painting goes bad, I put in a coat, it protects the furniture. So coat is a very important thing, it protects. And when we have this coat program, it improves upon your clinical skills and knowledge, and it tends to protect the patients from some disaster consequences. So that is the reason we have used the word coat as an acronym also. It provides a layer of new knowledge and skills which provide better patient care. Human being is a bundle of needs and expectations. And as organizers, we have seen that the need to prevent infection is very high. Be Dr. Talwar, Dr. Devan, Dr. Gauri, and all those sessions we have had, irrespective of what type of cancer they treat, each one of them is facing the challenge of infection. The challenge of infection always haunts them. So the code program today is unique. It has provided an opportunity where all the specialists taking care of cancer have come together to discuss about infection, be it hematologist, pulmonologist, oncosurgeon, oncophysician, neurosurgeon, and all. So it has provided a common platform with a shared goal to fight the risk of infection and sepsis. Medical treatment of cancer is only a part of care. It is the family which plays a very important part also, because it is a very long journey which can at times run for years together. So the medical team is only a part. It is the healthcare workers in the form of family and relatives which play a very important role. So if the healthcare workers, be it the medical team in the institutions or the family at home, are ignorant about infection prevention, we are likely to create a disaster. But if they are educated, they are well informed, they become a barrier. So, Manish, can I have some water, please? So an ignorant healthcare worker can be a carrier of infection, but a well-informed healthcare worker is a barrier of infection. And that is what is our attempt, to convert the ignorant, likely carriers to become well-educated barriers against infection. And as a part of this, as I've been circulating all along, we are also having a public awareness session in the afternoon today, where the aim is to inform how to get rid of infection even when you are at home. Because a patient, if he's to be discharged and is to go home, he should know, his relatives should know what precautions are to be taken. And that is exactly the purpose of the today afternoon panel discussion on role of healthcare workers in prevention of infection. Dr. Gangwar sir, Dr. Gauri Kapoor, on behalf of the organizing committee, I welcome you to this RGCI Code Program 2026. Dr. Gangwar, you have a distinction of being a bureaucrat, a able administrator for over 30 years, and now you are heading this institution, which is again a well-established tertiary care center in cancer. You have made a commitment of making it a happier place, and it can be happy only when you have a healthier environment. If our patient get rid of infection, I'm sure it will become much more happy. Our patients will be happy, our physicians would be happy. Today, as while we are undertaking this meeting, ये गोष्ठी चल रही है, हमारा सम्मेलन चल रहा है. Simultaneously, there is another meeting going on in Calcutta, where they are taking a pledge to make Bengal a wonderful place. Today, I think we must take in a pledge here to make this a safe environment. Rahul, can I have the pledge, please? Rahul, pledge. In the pledge that is being done over there in Calcutta, it is being done in the presence of the national leaders. In the pledge, what I plan to give here today to each one of you, it is being done in the presence of our institutional leaders. So with your due permission, I think we should take this pledge. And if it is required to stand up, I think we can all stand. And I think we can raise the hand. This is the Oncology Infection Prevention Pledge. I pledge to ensure my hand hygiene. I pledge to guard every invasive line as a lifeline. I pledge to wear my protective gears properly. I pledge to maintain a sterile environment. I pledge to stay vigilant and report. I pledge to educate and empower. I pledge to prioritize my staff wellness also. I make this pledge to ensure that my care brings healing and it does no harm. Thank you. So with this pledge, I am sure we'll become much more vigilant, much more careful. And I am sure we might not get infection free, but we will definitely contain the infection in RGCI. And I am sure we will be able to meet the dream of our CEO to make it a happier place. Because once the infection goes down, all the physicians would be happy, all the patients would be happy. So with this, I would request our CEO, sir, to kindly give his address on the occasion of the Code Program 2026. Thank you, sir.
A very good morning to all of you. It gives me immense pleasure to be here amongst all of you. The program title of court program reminds me of the white coat ceremony in our erstwhile medical school days. I was thinking philosophically, what does cancer care in essence means? We know different therapies, different modalities, different stages, more than 206 types of cancers. But in essence, cancer care is a race against time. Time to diagnosis, time to treatment initiation and after discharge, how to make the best use of time left with that particular person. So essentially, cancer care is race against time. Now you think of sepsis. It is an Olympic race against time. You have said, sir, it is 9 times more in all the biopsies, autopsies in cancer care says globally that 40% deaths in cancer happen because of sepsis. And out of balance 60%, 50% is undiagnosed sepsis. So, my first thesis statement, cancer is a race against time and sepsis management is an Olympic race against time. Why is it so? Because survival depends on early recognition within first hour, timely antibiotics, source control, hemodynamic precision, and strict adherence to evidence-based protocols such as surviving sepsis campaign protocol, etc. This we will learn in next entire day conversation. But I want to highlight an invisible aspect of sepsis control and management. Sepsis is more than a dysregulated immune response, what we heard in that case study of cytokine syndrome. It is fear, suffering, uncertainty, and vulnerability for both patients and his families. And this is where compassionate care becomes profoundly clinical in a center like Rajiv Gandhi Cancer Institute. Compassion is not a soft skill, as many of we tend to believe. It is part of excellent critical care. When we listen deeply, communicate clearly, and involve families with sensitivity, we build trust in moments of crisis. Patients and their families may forget the lactate values and vasopressor dosage, but they will never forget how we spoke to them during the most difficult moments of their lives. Evidence from critical care literature, particularly from JAMA, Lancet, and BMJ, shows that compassionate communication improves trust, compliances, reduces psychological trauma, and strengthens shared decision making. I will again go back to my thesis statement that sepsis management is an Olympian race against time. So I've invited the CIO and Deputy CIO especially for this conference. I'm wondering, that's why I invited both of them. I'm wondering, how can we integrate artificial intelligence into sepsis care management in our institute? Because sepsis is a disease where time-sensitive recognition and response determine outcomes. AI can strengthen multiple components of the surviving sepsis campaign protocols by improving early detection, decision support, workflow efficiency, and personalization of care. Artificial intelligence will be most effective when combined with clinical expertise, compassionate communication, multidisciplinary teamwork, and protocol-driven care. Let me conclude with the wisdom of Sir William Osler, father of modern medicine. The good physician treats the disease. The great physician treats the patient who has that disease. I hope that the end of the deliberations of this conference, with our collective minds, we will design a mission for AI augmented compassionate care of cancer patients in RGCI. I wish great success to the institution. Thank you.
Thank you so much, sir, for the wonderful and enlightening words. I would now request our MD Niti Bagh, Dr. Gauri Kapoor, ma'am, who's also Director of Pediatric Hemato-Oncology, ma'am, to please address the gathering.
Good morning, everyone. CEO, Sir Dr. Gangwar, distinguished faculty, colleagues, and guests. So it's a real privilege to welcome you to this symposium, and I congratulate Dr. Rajiv Chawla for the COAT program and Dr. Prashant and Dr. Bikram for the theme on Sep Onco for this summit. I think it's a topic right after my heart, a subject that is one of the greatest challenges. As a clinician, I will say it is one of the greatest challenges in cancer care today. And as you have heard already, 40% deaths in cancer would occur due to sepsis. So despite every day we know there are remarkable progresses in oncocare, new drugs, immunotherapy, targets. Despite all of this, infections and sepsis continue to threaten the survival of our patients. They interrupt treatment and definitely significantly impact the quality of life of our patients. Both in pediatric and adult oncology, our patients are immunocompromised due to the malignancy, but also because of the intensive treatment that we use. I would also like to reiterate what our CEO, sir, said, that oncosepsis is not just a medical emergency, as you have heard. It is a systems challenge. It demands immediate clinical care, but also demands vigilant nursing, timely lab support, antimicrobial stewardship, critical care preparedness, and above all, teamwork, where every minute matters and every member of the healthcare team plays a vital role. And therefore, if AI can make all this happen faster and more coordinated way, that would be brilliant. So we know today the symposium brings together experts committed to improving outcomes through science, collaboration, and shared experience. And I hope that today's discussions will generate practical insights and translate into safer and better cancer care for all our patients at RGCI RC. So thank you and congratulations once again to the organizing team, and best wishes for a scientific and rich experience. Thank you.
Thank you so much, ma'am. So as we proceed further, I would now request everybody to rise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा, विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा। तब शुभ नामे जागे, तब शुभ आशीष मांगे, गाहे तब जय गाथा। जन गण मंगल दायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे। जन गण मन अधिनायक जय हे भारत भाग्य विधाता।
Thank you, everyone. And Before we take the program further, I would request everybody to kindly join for a short break for a high tea. Thank you so much.
Good afternoon, one and all. For the next session on transfusion and coagulation management in critically ill cancer patients, please join me in welcoming Dr. Manoj Bhardwaj, Senior Consultant, Anesthesiology, Rajiv Gandhi Cancer Institute, Dr. Rohit Yadav, Senior Consultant, Critical Care Medicine, Bansal Hospital, Bhopal, Dr. Dev Shankar Patel, Additional Director, Critical Care Medicine, Fortis Vasant Kunj, Dr. Anjali Mishra, Consultant, Critical Care Medicine, Holy Family Hospital. Humble request to one of the chairpersons to please invite the speaker for the session onto the stage.
Good morning, everyone. As we all know, anemia and coagulation disorders are very common in ICU settings. To address this topic, I invite Dr. Nitin Jain. He is Director and Head of the Department of Critical Care in Pars Hospital, Gurgaon. He has many achievements against his name. He is a trainer of ECMO. Has got his training from Canada. He is also examiner for DRNB and IDCCM. He is founder of CLUE courses, and his area of interest are hemodynamic monitoring, focus, and ventilation. May I request Dr. Nitin Jain to deliver this talk?
Thank you, sir, for a generous introduction. So, next few minutes, we'll be discussing transfusion and coagulation management in critically ill cancer patients. I'll discuss my topic in these broad headings. So we'll first discuss specifics of blood products, where we need to transfuse what, and then we move on to monitoring part, which includes TEG and ROTEM, and then the massive hemorrhagic protocol, transfusion protocol. So 40% of onco patients, cancer patients, they receive at least one RBC transfusion during their ICU stay. And 60 to 70% incidence of thrombocytopenia in hematology ICU admissions. And 20% of active cancer in all patients, they do have venous thromboembolism. And 3 to 4 times higher risk of major bleeding in cancer patients on anticoagulation. So the problem is tremendous. And I think majority of cancer patients, they face this during their whole course of illness, either transfusion or anticoagulation. So there is a dual hemostatic risk. Patients may have simultaneous bleeding and thrombosis. There may be chemotherapy-induced myelosuppression. There may be DIC, especially in hematological malignancies, or there may be transfusion-related immunomodulation in these patients. So as per the physiology, it may be prothrombotic or it may be pro-hemorrhagic, depending on the disease process. And there may be bone marrow infiltration causing thrombocytopenia. There may be a chemotherapy-induced myelosuppression. There may be DIC with factor consumption. So a lot of things which they contribute to either prothrombotic or a bleeding state in these patients. Now, these were the broad trials which were meant to decide at what goal you should transfuse the PRBC. So in 1999 came the TRIX trial. It said hemoglobin of 7 is the threshold, which is non-inferior to 10 grams per deciliter. So they said at hemoglobin of 7, there is no inferiority and there is no target to keep a hemoglobin of 10. Then in 2014 came the TRIST trial, which said hemoglobin 7 versus 9. They said no mortality difference, especially in septic shock. Then in 2020 came this TOPIC trial, and they said liberal versus restrictive in oncology. They said no benefit of liberal strategy in oncology patients. And then in 2023 came the AABB guidelines, which said that restrictive is recommended in most stable critical care patients. So general consensus is a target hemoglobin of 7 for PRBC transfusion. Obviously, if there is a cardiac issue, acute coronary or a hemodynamic instability, then you target 8 to 9. And if there is a massive bleeding, then it's a clinical judgment. Now, these are the targets for platelet transfusions. So prophylactic, always transfuse at less than 10,000. If there is a fever or you need to do a minor procedures, then 20,000 target. If there is an invasive procedure like a central line, target is 50,000. And if it's a neurosurgery or ophthalmic surgery, target is usually 1 lakh. And there may be certain special oncology scenarios like in APL, platelet target more than 30 to 50 during the chemotherapy, which is being given. And then there are certain chemotherapies which itself cause platelet dysfunction. And usually in those, when the patient is on these chemotherapies, we try to target a higher threshold. Now, a word about the plasma. Normally, indication of FFP is multiple factor deficiencies or a DIC with active bleeding or INR of more than 2.5 with hemorrhage. Normally, trivial increases in INR usually do not need a FFP transfusion. And if there is no need for transfusing FFP for procedure prophylaxis, which we do if it's an INR of 1.9 and there is a procedure we sometimes tend to transfuse, that is actually, as per the literature, not indicated. Then comes the role of cryo. So fibrinogen less than 1.5 to 2 with bleeding, an indication for cryo, or hypofibrinogenemia in a DIC, or L-asparginase coagulopathy, and usually we target a fibrinogen more than 2. Then comes the 4-factor PCC, which has now come up recently, and it has been indicated for majorly for warfarin reversal, but they recommend now some for oral anticoagulant-induced bleeding also. So usually factor 2, 7, 9, 10 deficiency or an emergency surgery, 4-factor PCC can be considered. Then fibrinogen concentrates can be used in coagulopathic bleeding where they may be preferred over cryo where they are available. Now, this is about the DIC score, I think, which we all know about it. In general, if there is a situation of DIC in a onco scenario, normally what we try to do is treat the underlying cause. There may be a chemotherapy which may be causing a DIC, or it may be sepsis induced. And usually we try to replace the consumed products. Platelet, fibrinogen, we give a cryo, and active bleeding plus INR, we give a FFP. And if it's a thrombotic DIC, then yes, there is a role of anticoagulation even in a DIC. And we usually monitor the response every 4 to 6 hours with a TEG or a ROTEM. So this modality is now not only restricted to liver ICUs. Normally, a lot of onco centers are also using it because it is very, very specific. PT, APTT will miss the platelet contribution and fibrinolysis, while this is a whole blood real-time kinetics. And it even detects the hypercoagulability as well. So in DIC scenarios, it is very, very helpful. Usually results come in 10 to 20 minutes, much faster than PT, APTT. And it detects fibrinolysis. And it is one of the important, I will say, parameter to monitor in APML. So usually we measure the R time alpha angle, and accordingly we decide what is the basic abnormality. And based on that, we base our decisions for transfusions. Word about massive hemorrhage protocol. Normally, massive transfusion hemorrhage protocol is triggered when there is a hemorrhagic shock, which requires more than 4 units of PRBC in 1 hour, or it's an uncontrolled bleeding with a hemodynamic instability, and there is a predicted need for a massive transfusion, maybe a tumor bleed. So usually blood products are given in 1:1:1 ratio. And it's normally all major hospitals have this massive transfusion protocol, because once this is activated, then blood bank and lot of systems are involved once it comes into picture. So tranexamic acid, calcium gluconate, TEG, ROTEM, and if you find the site of bleed, then obviously surgery, endoscopy, or hemostasis, whatever is appropriate. Now, there may be situations where there is a thrombocytopenia along with a need for anticoagulation. So a lot of situations we come across where there is a thrombosis with bleeding, and usually this is always a difficult state to encounter. Now in this, various trials have come starting from EHA 2022 guidelines, which they preferred LMWH over oral anticoagulants. Then came NCCN 2024, which said grade-based evidence platelet count more than 50,000 give full anticoagulation, 25 to 50 you lower the dose to half. Then came this caveat trial 2023, which said hematological malignancy plus thrombocytopenia plus a DVT, always give the full dose. And then in 2024 came this Trove trial, which said that if the platelet count is less than 50,000, reduce the dose of LMWH to half. So invariably, most of the studies recommend giving a anticoagulant prophylaxis even if there is a thrombocytopenia, especially above 50,000 platelets. Now, there are certain chemotherapies which they tend to produce coagulopathy. So, L-asparginase, VEGF inhibitors like bevacizumab, ATRA or ATO, platinum compounds, thalidomide, all these drugs, they tend to cause coagulopathy by itself. So normally, if any of these drugs are being given in chemotherapy, we try to find out the cause, and then accordingly, we have to treat it. Like L-asparginase will decrease the fibrinogen, so we have to replace it with fibrinogen. And similarly for others, we have to treat the root cause whenever we are managing these coagulopathies. Coming to complications of transfusion, so these are the most common complications which we come across: TRALI, TACO, and then oncology-specific transfusion-related immunomodulation, transfusion-associated graft versus host disease, and then metabolic complications of massive transfusion, which includes hyperkalemia and hypocalcemia. TRALI, TACO is something which we commonly come across, and usual treatment is to stop the transfusion, give supportive treatment. In TACO, we give diuretics, restrict the rate, and consider single unit strategy in a cancer patients. Now, there are certain hematological malignancies which itself cause coagulopathy. So, in this, the treatment of coagulopathy is chemotherapy itself. So, like if a patient of APL, it comes with coagulopathy, it comes in DIC with a hyperfibrinolysis, the treatment is to give a chemotherapy and try to treat the cause. Similarly, in L-asparginase and in multiple myeloma, you have to give a VTE prophylaxis, which is in fact mandatory because it's a prothrombotic state. And so similarly, in lymphomas, there may be autoimmune thrombocytopenia. So we have to treat it with steroids or IVIG or rituximab. So based on the type of cancer, lot of treatment modalities may change. Now, this is some of the practical bleeding management algorithm in an onco ICU, where obviously in any bleeding patient, we'll always have a large bore IV access. And then we try to identify the source with a endoscopy, bronchoscopy, or a CT angio. And then we do monitoring with a TEG or a ROTEM. And then as per the labs, we try to infuse the specific blood products. Tranexamic acid indicated only in traumatic or surgical bleed within 3 hours of onset. Normally in trauma, they say it has to be given within 2 to 3 hours. And then serial TEG monitoring is something which is indicated. So in general, usually they say TEG or ROTEM based monitoring, but in case even if it is not available, then obviously we look for platelet, PT-INR, APTT, fibrinogen, and then accordingly transfusions are being given. Now, these are the special population and emerging considerations, and normally CAR T cell therapy, tumor lysis syndrome, usually we try, like in tumor lysis, we try to treat the electrolytes accordingly, and then you have to give good hydration. So there may be disease specific indications like in liver mets. They say avoid empirical FFP for elevated INR without active bleeds. And in febrile neutropenia plus sepsis, sepsis DIC mechanism, usually there is an endotoxin driven mechanisms. Now, these are some of the evidences for transfusing blood products, very, very specific to disease specific states or these parameters. So just to summarize, normally cancer patients have a dual hemostatic paradox, and restrictive RBC strategy is something which is a standard. Platelet count more than 10,000, need to transfuse. Avoid empirical FFPs for mildly elevated INRs. If it's a APML with DIC, start with ATRA chemotherapy immediately. TEG and ROTEM based monitoring, and then massive hemorrhage protocol where indicated. And then LMWH are safer at platelet counts above 50,000 in full dose, below 50,000, half the dose. Drug-specific coagulopathies need to be identified, and always prefer to use irradiated products for all immunocompromised cancer patients normally. So I'll just briefly discuss anticoagulation in cancer patients as well. So normally I'll discuss it in few broad headings. What is the scale and mortality burden? What usually do we use in prophylaxis in ICUs? What are the oral anticoagulant trials? Oral versus LMWH debates, and then heparin-induced thrombocytopenia, pulmonary embolism, what to give in renal and hepatic failures, and some common drug interactions, and an anticoagulation reversal. So this is the scale of burden in onco patients. Normally higher VT risk, one of the major causes of deaths in cancer patients. 20% of all new thromboembolism events have active cancer, and 10 to 20% VT recurrence occur despite anticoagulation in cancer patients. Now, this is the virtuous triad: hypercoagulability, stasis, endothelial injury. All these three parameters are aggravated in a cancer patients for various multiple reasons. And in fact, that is why it is one of the more hypercoagulable state. This is some of the risk stratification scores. And on these risk stratification scores, we categorize the patients as high risk or medium risk or a low risk for giving an anticoagulant therapy. And now these are the commonly prescribed ones. Normally enoxaparin 40 milligram, one of the preferred drugs, first line, predictable, once daily dosing. Usually you can do an anti-10M factor monitoring if indicated, especially if creatinine clearance is less than 30. And normally in renal impairment, not very much preferred, but one of the most commonly used ones. Then in low platelets, fondaparinux, and then mechanical or IPC, especially if platelet count is less than 25,000, or active hemorrhage. Normally we tend to combine mechanical with a pharmacological, but in case the platelet count is very low, below 25, then there is an indication to give only mechanical. Normally knee high versus thigh high evidence is usually similar. So there is no difference between a below knee pump versus a thigh high pump in the mechanical prophylaxis. Now, as regards treating cancer-associated thrombosis was concerned, there were few landmark trials which happened. One of them was the CLOT trial, 2003, dalteparin versus warfarin. And they said that dalteparin reduced the risk of thromboembolism by 52% at 6 months. And it said there is no difference in bleeding. So it was the first proof that LMWH are better than oral anticoagulants in DVT prophylaxis. Then came this 2006 trial, Cantanox trial, which again compared enoxaparin versus warfarin. It said LMWH better for VTE, and there is a higher bleeding risks with warfarin. Then 2015, there came the CATCH trial, which said there is no significant reduction in VTE and clinically relevant non-major bleeding with LMWH. Then came, so in 2003 to 2018, LMWH gradually became the standard of care. And they said that LMWH has been established as a gold standard for cancer-associated VTE treatment now for 15 plus years until these oral anticoagulant trials which came up. So these are the ones which we commonly use in ICU. Now come the oral anticoagulant. So 2018, this trial which came, edoxaban versus dalteparin, it said it was the first oral anticoagulant in thrombocytopenia, and it said edoxaban is inferior in GI tumor. So they said don't use edoxaban in a GI tumor. Then came this 2018 Select D trial, compared rivaroxaban with dalteparin. It said caution in GI cancers with rivaroxaban. All oral anticoagulants had a higher risk of GI bleeds, and all of them, they were relatively not indicated in GI cancers. Then 2020, apixaban versus dalteparin, it said apixaban has superior efficacy and less bleeding and no GI cancer signal. But this is it had the patient number was very small in this. Then 2020, again, one more trial, and it said it was one of the larger apixaban trial, and it said apixaban is non-inferior with no increase in GI bleed. And then 2025, this apixaban dosing trial came, which said step-down strategy with apixaban has been validated, and that said after 6 months, you can switch to apixaban 2.5 milligram BD in a DVT patient, and it has been proven to be non-inferior with less bleeding complications. So normally in this debate, LMWH is one of the preferred drugs, especially if there is a GI cancer, as there is reduced risk of GI bleed with LMWH as compared to oral. However, apixaban as an oral anticoagulant has been proven to be safer, even in GI tumors. Then CNS tumors, again, LMWH, better safety. Then renal impairment, LMWH, better safety as compared to oral. Then drug interactions, LMWH, better safety profile. Thrombocytopenia, you can give LMWH in reduced dose as compared to oral apixaban. So a lot of clinical indications where LMWH has been proven to be superior over oral anticoagulation. So in duration of anticoagulation, normally minimum is 3 to 6 months for all cancer-associated DVT. And standard benchmark is at least 6 months. And most guidelines, they recommend continuing while cancer is active or under treatment. Now, this is a word about heparin-induced thrombocytopenia. Normally, usually happens, the timing is after day 10, normally after day 10. Sometimes it can happen early, even after 4 days. And usually day 5 to day 10 or beyond is one of the common time when it can occur. And normally we stop all heparin and you use alternatives like bivalirudin or argatroban if you have to absolutely give some anticoagulation. Usually you avoid warfarin in these scenarios. So a word about massive and submassive PE treatment is thrombolysis, and usually there is an indication for catheter-directed thrombolysis as well in submassive PE. Low risk standard anticoagulation is one of the treatment standards. So these are one of the few drugs which we use, especially anticoagulation in renal failure and CRRT. Heparin is one of the most safest drugs which can be easily used. LMWH can be used in reduced dosage. Apixaban, least renally cleared oral anticoagulant. And argatroban, usually it's a drug of choice in heparin-induced thrombocytopenia plus renal failure. Now, in situations where there is a DVT along with a thrombocytopenia, which anticoagulant to give? So they say more than 1 lakh platelets, give full dose. More than 50,000, give full dose LMWH. 25 to 50,000, reduce LMWH dose by half, and less than 25,000, always hold the anticoagulation. Then there are certain drugs which have interactions with our anticoagulants, and there may be some chemotherapy drugs, ATTs, azole antifungals. All of them, they interact with the anticoagulants. And then obviously, we have discussed this, that there may be indications for anticoagulation as per the malignancies. So these are the common anticoagulants which we tend to use and as per the indications. Now, what about perioperative anticoagulation and bridging in cancer? Normally, they say if it's a apixaban, if the patient is on apixaban or a rivaroxaban and it's a low bleed procedure, stop for 24 hours. If it's a high risk bleed procedure, stop for 48 hours. LMWH 12 hours and 24 hours. And post procedure, when to restart? Low risk patient 12 to 24 hours. High risk patient 72 to 96 hours. So wait for 3 days if it's a high risk surgery. So these are some of the landmark trials. And to summarize, oral anticoagulants can be used for DVTs versus LMWH. However, LMWH remains the drug of choice, especially for GI tumors, thrombocytopenia, renal failure, and ICU settings. So after 6 months, you can step it down to oral anticoagulants, which is apixaban 2.5 milligram BD. Heparin-induced thrombocytopenia should be looked into. And then drug interaction with azoles should be looked into. Platelets, we have discussed how to give anticoagulation. And then based on the disease process, we tend to. Let me end with a small case discussion. So a patient who has been on rivaroxaban, if he comes to you for colonoscopy, so what will you do? Will you bridge this patient to LMWH or you would stop oral anticoagulation immediately? What will be your thought process? Okay, so recommendations say you can in a procedure like colonoscopy, you can just stop the oral anticoagulation. There is no need to bridge in procedures like colonoscopy. Thank you. Thank you.
For covering this vast topic, and you covered the practicalness topic. Can I declare house open for the discussion? Dr. Vikram, we do have time for discussion? Yeah. Yes. Any questions, please? Dr. Nitin, can we continue Trenexa after surgery in ICU?
Trenexa, sir, usually they say it has got role only in traumatic or a post-surgical bleed, especially within the first 2-3 hours.
Okay, we do give Trenexa during surgery, but can we continue in the ICU in some selected patients?
Yes, sir. So, sir, we tend to use, but what the literature says is not of any major benefit in controlling the bleed.
Thank you, Dr. Nitin. Just one question. Is there any role of vitamin K? Is it not at all indicated in any patient of...
Vitamin K is definitely indicated, especially in a oral anticoagulant bleed, where they say oral anticoagulant, you give vitamin K plus 4-factor PCC. If you do not know what is the antidote for it.
Okay, so in bleeding patients, it's indicated if on oral anticoagulant maybe.
Absolutely.
But if just INR is raised, patient is not bleeding, is there any role of vitamin K in any subset of patients?
Normally, they say if it's factor 2, 7, 9, 10, you want to just give it as a, if you are looking for these. So all of us, I think, tend to write if there is a deranged INR as vitamin K. So far, in fact, I have not searched the literature specifically for vitamin K, so I'm not too sure about it.
Thank you.
Any questions from the house? If there are no questions, then we declare the session closed. Thank you.
Thank you. Thank you.
इसको चालू करना
It was indeed a very informative talk. So now moving on to next session, which will explore vaccination in cancer patients. And to chair this important discussion, I now cordially invite Dr. Anurag Mehta, Principal Director, Medical Diagnosis and Transfusion Services at Rajiv Gandhi Cancer Institute and Research Center, Dr. Amit Mittal, Senior Consultant, Rajiv Gandhi Cancer Institute and Research Center, and Dr. Ashish Khanna, Consultant, Uro-Oncology, Robotic Surgery and Focal Therapy at Rajiv Gandhi Cancer Institute and Research Center. Please welcome them with a round of applause. I would like to request the chairperson to please introduce the speaker. Thank you.
Good afternoon to everybody. I would now request Dr. Nitin Bansal, who is our very own infectious disease specialist at Rajiv Gandhi Cancer Institute, to please take over the proceedings.
So, good morning, everyone. I am coming to speak to the stage for second time since morning. So, if you are bored with me, please bear with me. One of you may be wondering why we are speaking on vaccination in cancer patient in a talk, in a conference which is themed on sepsis in oncology setting. In the inaugural session, Dr. Chawla sir also made us pledge on prevention of infections. So prevention of infection is equally important, and treatment of, we all discuss about treatment with a lot of enthusiasm, but prevention is equally important. So what I will do is, over the course of few slides, I will discuss on immunization in cancer patients. It's a very wide topic, very difficult and very non-evidence based topic, because of the very principle that most of the vaccine trials which are done in adult settings, they exclude oncology patients. So that is a scenario. So, but I will try to give you a bird's eye view on how to go about with vaccination in oncology patients. So in the era of T20, where everybody is using powerful bats and using their muscle power to blast everyone for sixes, there is still there are still batsmen who depend on timing. So vaccination in oncology basically dependent on timing, not on the what vaccine you give. So timing is the most crucial here. So I'll discuss few cases and I will come back to these cases after the end of the slides. 57-year-old male, recently diagnosed, have come to treatment for myeloma to our hospital. What vaccine advice will you give him and when? Flu, pneumococcus, or recombinant zoster vaccine? Flu, recombinant zoster vaccine, only pneumococcus. Any other, please specify, or let me control myeloma first. So I'll come back to these questions. Most of the time, people will think that just controlling myeloma will be enough, and we generally concentrate on the myeloma aspect only. Case number 2, same patient, before getting vaccination, let's say you have advised some vaccination, ask what is the benefit of vaccination. Would you claim and say that you won't get seriously sick due to flu and pneumonia, you have given the vaccination? You won't get flu and pneumonia totally. We are just giving a vaccine because we don't want you to blame us later on. We recently listened to a vaccination class like this today. So that's why we are more aware. So we are giving vaccine today, or some other explanation. Case 3 is a 32-year-old female who has undergone splenectomy as a part of CRS for CA endometrium. Dr. Ashish is there, who does a lot of abdominal surgeries. So he will realize the importance of this. So what is your vaccination advice to this patient? Give relevant vaccine after splenectomy. Must have asked me before the surgery. Now it's too late. Or no need for vaccination, as vaccine prophylaxis is good enough. Or before or after, how does it matter? I'll just give the vaccine at all. Now, a simplified cost-effective analysis. Many people say vaccines are costly. Why should I take a vaccine when I am totally fine? So again, a simple case scenario of patient, 51-year-old male from Kanpur. He has a hypertension. He has multiple myeloma and is used for multiple myeloma. Multiple lines of therapy has been given. So his both B and T cell lines are suppressed. He gets admitted with fever, cough, respiratory distress for 5 days. Got treatment in a local hospital before coming to us, and here we diagnosed that he is having H3N2 pneumonia, that is influenza A. Now, just simplified cost-effective analysis, it is oversimplistic, I understand, but just for sake of the discussion, without vaccination, is 2 days stay in a local hospital along with expensive antibiotics. Mind you, once you get admitted with the fever, at least in today's day and age, it is very difficult for a physician or anyone to stop and not give antibiotic on day 1. So he has to receive an antibiotic. I mean, that is the sad scenario. 4 days stay in our hospital in a private room. These are very conservative costs. 50,000 rupees per, almost for a 4 days stay. With vaccination, his cost of vaccine, flu vaccine would have cost him 900 to 1,200 rupees, or sometimes even 1,500 rupees, depending upon the brand and where you buy from. Cost of vaccination of the nearby, like you would have vaccinated everybody, would have cost 5 times this, so around 5,000 rupees. And a single visit to a patient, he would have still got flu, but he would not have got sick enough to get admitted to the hospital, would have cost him some 1,500 rupees, depending on the fee of the physician which he or she charges. So as you can see, it is quite crystal clear that the cost of vaccination is always less than the cost of not giving vaccination. If the patient gets sick, the cost multiplies by manifold. So what I will cover is vaccination in cancer patients, what vaccine to give, and what is the best possible time. I won't cover in this talk post-HSCT vaccine because that's a different science altogether and that's a separate guideline. Pediatric cancer vaccine is again a very, very difficult topic to handle because there are a lot of difficulties, guideline-based issues, which also I will not cover. I'll just stick to adult vaccinations, non-stem cell transplant recipients. Now, why do adults need vaccination? We have all received vaccines during our childhood as a part of universal immunization program. But as we all understand, immunity wanes over time. There is immunosenescence. As we grow old, immunity wanes. As we age, we become more susceptible to common infections like flu, shingles, and pneumonia, which increases morbidity and mortality. And all this leads to excessive hospitalization, diminished quality of life, missed work, and medical complications. And not only patient-related factors, sometimes pathogen-related factors like the virus or the bacteria also changes. So you need to be up to date with the latest vaccination strains. So that is also one of the reasons why adults need vaccine. Now, there are different types of vaccine. Most of you may be aware of this, but it is better to revise. Some are the live vaccines like varicella vaccine, oral polio vaccine, MMR, that is measles, mumps, rubella, then live attenuated influenza vaccine, BCG, and herpes zoster vaccine, the older vaccine, that is Zostavax. Now, killed vaccines are inactivated polio vaccine, influenza vaccine, pneumococcal vaccine, tetanus toxoid, diphtheria, tetanus, and pertussis, that is Tdap, then hepatitis B and A, and then recombinant herpes zoster vaccine, which is latest into the market. Now, As a general principle, you don't give a live vaccine to any immunocompromised patient, but you can give a killed or inactivated vaccine. So this is a very important demarcation, which which as a physician, all of us should be aware what are live vaccines and what are not live vaccines. So this I have already spoken, so I will skip these two slides. Coming to vaccination for adults with cancer. So these are the 4-5 vaccines which are like currently recommended: influenza vaccine, pneumococcal vaccine, Tdap, recombinant zoster vaccine, hepatitis B, human papilloma virus, which everybody knows, and now the government of India has launched a public health initiative to vaccinate all these girls with HPV for prevention of CA cervix. And then in coming future, we are going to have a RSV, that is respiratory syncytial virus vaccine also. It is already available in the Western market or Western world. Other vaccines which may be required in some special scenarios like hepatitis A, polio vaccine, meningococcus vaccine, influenza B vaccine, and varicella vaccine can also be given to cancer patients. Now, when should we? That's a very important question which everybody asks. Like commonly, patients are on cyclical chemotherapy. So when should I give the therapy? So ideally, vaccination should precede any planned cancer treatment by 2 to 4 weeks. But this is very easy to say and very easy to preach in front of the audience. But once imagine yourself being a cancer patient, you are having cancer and you are come to the cancer hospital to get treatment for cancer. But the cancer doctor is saying, no, first you get vaccine, then come after 2 weeks, and then I will give you cancer treatment. So that is practically very difficult to happen. At least I don't see it happening in recent future unless until there is a very drastic shift in the practice or mindset. However, non-live vaccines can be administered during or after chemotherapy or immunotherapy, hormonal treatment, radiation, or surgery. They are generally safe. Now, what is the best time to give vaccines who are on chemotherapy? So this is again a non-evidence-based answer. This is only single randomized control trial which I could identify, in which they divided these patients into 2 groups. It's a very small trial, 43 patients in each arm. Arm A, in which vaccination 2 weeks before chemotherapy, and arm B, in which vaccination was given on the first day of chemotherapy was initiated. And they analyzed the antibody response and all, and the patients included with gastric cancer and colorectal cancer. And they did not find any significant difference between these 2 arms. So for me, it is not possible to give a very good evidence-based answer on what is the best time to give vaccines to patients who are undergoing chemotherapy. But the best logical answer from the pathophysiology or the recovery of cell count, which we know, or an oncologist will be able to tell you better, is that administer vaccine at least 7 days into a chemotherapy cycle. Let's say the chemotherapy cycle is 21 days, then better to administer the vaccine on the 7th day or between 7th day to the 14th day from the starting of the chemotherapy. What about patients who are on monoclonal antibodies, particularly drugs which act on CD20, like rituximab or obinutuzumab, which act on CD20? The simple answer, which guidelines also say, is that adults who receive B-cell depleting agent should be vaccinated no sooner than 6 months after completion of therapy. So you have to wait for treatment to stop, and then 6 months, and then you have to initiate them on vaccination. But again, this is a very simplistic answer. Most of the patients who are on maintenance rituximab, like patients on follicular lymphoma, mantle cell lymphoma, it is very difficult to say when will the therapy get stopped. So they are essentially left at risk, saying that we can't give vaccine because you are on rituximab. So this again, another patients like long-term survivors which have hypogammaglobulinemia secondary to therapy or because of their intrinsic problems, they also have the same issues. So whether we should keep on waiting for them. So recommendation is that you go ahead and give the non-live vaccine, even though the response may be attenuated. Again, giving an evidence-based answer, this is a latest evidence which basically looked into influenza vaccine in these kinds of patients like CLL or patients who have received rituximab, and they found that although B-cell, that is antibody response, was very poor, but T-cell response is good enough. So these patients can also be vaccinated while they are on therapy for anti-CD20 molecule. Now we have a new way of treatment of giving vaccination to patients like for multiple myeloma and lymphoma. Bispecific monoclonal antibody, very commonly used nowadays, is teclistamab. So ideally 2 weeks before initiation of therapy, or when the teclistamab infusion frequency has come down, that is the de-escalation of the bite therapy has come down, then you should initiate vaccination in these patients. Now I will just concentrate on 2 vaccines for the sake of simplicity. One is flu vaccine, which is commonly used, and one is pneumococcal vaccine. Flu vaccines of various types. Quadrivalent vaccines has 2 strains of influenza A and 2 strains of influenza B, and trivalent has 2 strains of influenza A and 1 strain of influenza B. then it can be inactivated or live attenuated. We generally not use live attenuated. It is not freely available and it is not approved for cancer patients also. So that is out. The other one is whole Viron or split Viron. Then there is standard dose versus double hemagglutinin dose. There's a lot of literature on that double hemagglutinin dose is better than standard dose. But again, in India, we don't have double hemagglutinin dose vaccine available. We just have standard dose. Then there are egg-based vaccines and egg-free vaccines. This is important for those patients who have egg allergies. So when to give a flu vaccine? Offer vaccine year round. The problem, although again, literature coming from the Western is quite clear. If you are living in Northern Hemisphere, then you should take an vaccine up from October onwards. If you're living in Southern Hemisphere, you can take the vaccine on May onwards. Problem is we are living in somewhere in between. We are not neither here, neither there. So bottom line is vaccinate the patient whenever you see them first. And they also have vaccination hesitancy and advice for annual boosters. So this is some of the researchers have done what is the best time to initiate in India. They have taken various states also, and they have listed New Delhi, which we are standing here, as July to September as the best time or peak time of influenza. But this again is not 100% right. We ourselves have been living in this part of the world for so many years. It is not that influenza only peaks in July to September. It depends on sometimes it peaks in winters also. So according to this paper, they say that vaccination for influenza in Delhi NCR should be given in months of April and May, just before the monsoon season. But sometimes if the winters are around, and sometimes because of winter, there is chances of then you can give it in the month of near Diwali, October, November also. Coming to pneumococcus, pneumococcal disease is quite varied and it is quite devastating. It can be non-invasive disease, simple URTI, or like serous otitis media or sinusitis. It can be LRTI like pneumonia or tracheobronchitis. Then it can lead to very serious illnesses like bacteremia, meningitis, and other diseases. Now, invasive pneumococcal disease, IPD, the cancer patients are at very, very high risk of developing IPD. That's why we all stress upon giving pneumococcal vaccine. So as you can see from the flowchart, the odds ratio of developing IPD in patients with lung cancer, multiple myeloma, CLL, AML, lymphomas and all is quite higher than the general population. Now, there are two types of pneumococcal vaccine. One is conjugated vaccine and polysaccharide vaccine. Polysaccharide vaccine is PPSV 23. 23 denotes the serotypes, and conjugated vaccines are PCV 13, 15, and 20. Here again, the number denotes the serotypes. Now we have the latest PCV 20 also available for the use. Key difference between the two is that the conjugated vaccine has a carrier protein which incites T cell immunity and builds a long-lasting immunity. So repeated boosters are not needed. So these are the key differences which I spoke about. PPSV 23 is of long experience, cheap, higher serotype coverage, but it has no cocoon effect, weak immunogenicity, and immunity wanes off because it is T cell independent, whereas PCV is much superior to it. It has cocoon effect and it has T cell dependent response as well, and it is highly immunogenic. This is the older recommendation. Now with the introduction of PCV 20, we can we can almost forget this now. We just need one dose of PCV 20, that is enough. But if the patients have earlier received, then you can this is quite complicated at first look. But if you Google, there are various apps also, flowcharts also available, which will guide you how to give pneumococcal vaccine in these kinds of patients. So summarizing, influenza is supposed to be given annually. Pneumococcal vaccine, if you have PCV 20, which is available now, one dose is enough. If you don't have, you're living in some part of the world where PCV 20 is not there, then one dose of PCV 13 followed by PPSV 23 8 weeks later. Then recombinant zoster vaccine, that is Shingrix, 2 doses at least 4 weeks apart. HPV vaccine, I think everybody knows more than me. Tdap or TD, one dose should be given after 18 or once you have attained adulthood. Now, there are some special situations which arise, like splenectomy. So ideally, splenectomy is done quite commonly in cancer patients as a part of cytoreductive surgeries, or for whatever reason, they may be knowing better. But splenectomy is done. So ideally, if you're doing a planned procedure, then you should vaccinate the patient 2 weeks prior to splenectomy, which unfortunately is not a very common practice here. So you should be giving pneumococcus vaccine, that is PCV 20, meningococcal vaccine, 2 doses of meningococcal vaccine, and have H influenza vaccine, a single dose. And other thing is that once cancer patients, we see a lot of patients from outside Delhi. Patients have come from other parts of the country and as well as from other countries as well. So they also travel, and sometimes they travel for leisure purpose also. So they also need a lot of vaccination advice. So traveling to a polio endemic country, like recently we had a patient who is coming from Afghanistan. Now Afghanistan is still not a polio eradicated or polio free country. So now he or she needs a vaccination advice. So he needs to be getting one dose of IPV, that is inactivated polio vaccine. patient is traveling, we see a lot of patients from African continent also. Africa is endemic to yellow fever. Yellow fever is a live attenuated vaccine, so ideally contraindicated. But yellow fever can cause lot of like it can cause devastating illness. Secondly, it's a visa requirement also for some of these patients. So the risk can be assessed from case to base. Like say someone is on maintenance dasatinib for CML or some other molecule like this, so that patient can receive yellow fever vaccine. Sometimes exposure to or outbreak settings can happen, like varicella, rubella, measles. We all remember what happened during COVID. Vaccination to all these are most of the vaccines are live attenuated, so they are contraindicated. But let's say someone is a cancer patient, but he is a survivor and he's just on maintenance therapy, which is not going to immunosuppress him or her for it's not too intensive. Then this vaccination advice can be given. Another very common scenario is pediatric patient who was a 17-year-old male who is a survivor of Hodgkin's lymphoma. He finished his chemotherapy 19 months back. Now he's been selected for some IT course. He's going to a distant engineering college, going to stay in hostel and going to live his life. He has been not vaccinated apart from his routine childhood vaccine, which he got long time back. Now, what vaccine advice will you give him? Influenza, PCV, MCV, Tdap, influenza, PCV, MCV, Tdap, or HPV, HPV, Tdap, influenza vaccine, or no need for such vaccines. So this patient needs influenza and PCV as we discussed. But another peculiar scenario is that he's going to go away from home, going to stay in a hostel, enjoy his college life. So he is at very high risk of developing typhoid, enteric fever. So since enteric is not a problem for the Western world, so they don't talk about vaccination for typhoid in their guidelines. So we have to incorporate, or we have to modify our guidelines to incorporate the typhoid vaccine in these kinds of patients. So we have 3 types of typhoid vaccine available, which should be given. Again, they are killed vaccine, conjugated killed vaccine, which should be given. Vaccination in bleeding or coagulation issues, these are like common injection scenarios. INR is less than 3 and antiplatelet is vaccinate as normal. If the patient is on orally active oral anticoagulant or therapeutic LMWH to hold the dose on the vaccination day. If the INR is very high, then a firm pressure needs to be applied after giving vaccination. Let's say you didn't check and after that you have given that. Those scenarios can happen. You should know, but the point is that you should be, these all vaccinations are done for, are basically studied for intramuscular purposes. For whatever reason, we should not give them subcutaneously because there is no efficacy data. There's just waste of resources. Another point is ring vaccination or cocooning effect. Sometimes this vaccination is not possible in oncology patients because they are too immunosuppressed. We are not able to give them at all. There is no window. But the point is that you should stress on vaccination of the close household members, and this leads to protection of the patient himself. Another point is the efficacy of this vaccine is is limited in this scenario. So you should avoid false sense of security. Like you are driving with a seat belt on does not mean that you will not crash. Crashing depends on how you drive. So you should avoid the false sense of security. You should always keep on counseling the patients on use of mask, hand hygiene, and avoiding crowded places. One of the most crowded places which a cancer patient sees is the hospital itself. That's the contradictory, very difficult point to avoid. So most of the live vaccine can also be given to context of the immunosuppressed patient. There is no contraindication. Like there are very few exceptions, and other vaccines which I discussed, like killed vaccine, can obviously be safely given to the context of these patients. So take home messages is think about vaccination during your OP follow-up. Like for medical colleagues, the patient is just on maintenance therapy. At that time, medical oncologists can think of vaccination. For surgical colleagues, surgical oncologists, when the patient has come back after the successful surgery, he's now going to just for a follow-up, he has come. At that time, you should think of vaccinating these patients. And these 3 vaccinations should be emphasized on: influenza, pneumococcal, recombinant zoster, which are safe and effective, and vaccinate caretakers. Now, if you want, I can come back to the questions which I discussed earlier. Otherwise, I'll stop.
Sure, I think you can answer the questions that you had raised.
Okay, sir. So case 1 was 57-year-old myeloma, which was recently diagnosed. What vaccination advice will you give him? So correct answer is that he should be vaccinated for flu, pneumococcus, and RZV, that is recombinant zoster vaccine. Case 2 was that same patient is asking, why are you giving me vaccination? So correct answer is that you should vaccinate. We are vaccinating because you won't get seriously sick due to flu and pneumonia. We should not claim that if you get flu vaccine, you will not get flu. That is a false claim, because later on the patient will also come that I have given flu. Why am I developing flu? So the vaccines have been studied to prevent you from getting into the ICU because of this particular illness. So that is the purpose of giving vaccination, not to prevent you from getting infection at all. For splenectomy patient, the ideal time would be that the patient should be ideally be vaccinated prior to a planned procedure. But if the procedure has happened, then you can give the vaccine after splenectomy also. That is also quite understandable. But ideally, it should be done before, because a lot of immune cells are there in the spleen which are taken off after the splenectomy. Lymphoma survivor, which I discussed, going away for higher studies, the ideal doses should be HPV vaccine, Tdap, influenza, and typhoid conjugated vaccine. Thank you.
That has been a very engaging talk, and I'm sure there will be questions. So I'll throw open the floor for questions so that you can answer others' questions as well. Questions from the house? Well, there's none, but I will ask you.
Sure.
In non-hematologic malignancies and transplant context, what are the other solid organs where we recommend prophylactic vaccinations?
Sir, one of the major scenarios which we see is patients with thoracic oncology malignancies like CA lung. They are anyway at high risk of developing lung infections because of the changes in anatomy because of the cancer. So this is one scenario which will definitely be targeted for influenza vaccine and pneumococcal vaccines. Otherwise, guidelines say that all solid organ malignancies patients should be vaccinated. But definitely, if you want to target, like you want to have a cost-effective approach or the prioritization approach, then definitely patients with suffering from CA lung definitely should be targeted.
So one is CA lung. So do we have any institutional policy?
Sir, we have Dr. Ulas Batra sir unit has a institutional policy of vaccinating pneumococcus and giving vaccines for pneumococcus and flu in all his patients. In fact, that is part of their pre-chemotherapy checklist also, sir.
And do we have the similar policies for hemato-oncologies and transplant?
Transplant, there is a policy, sir. Post-transplant vaccination, there is a strict policy. For hemato-oncology, we are vaccinating patients currently for multiple myeloma and those patients who are coming for CLL.
Is there any written SOP?
Yes, sir, written SOP is there. For other leukemias and all, there is no guide.
Wonderful. I think all the institutes which are actually practicing hemato-oncology and managing other cancer shall have a vaccination policy in writing. And the last question from me is, Dr. Chawla, me, Dr. Pandey, what kind of an adult vaccination we shall have?
Sir, I don't want to reveal the age.
The geriatric population.
Okay. Sir, I think three vaccines should be definitely given. One of them is flu, second is pneumococcus, and third is recombinant zoster vaccines.
Do they come in a combo?
No, sir. You have to take 3 injections, sir. Sorry.
What particular age we should take?
65.
60, 65 onwards, you should take blindly above 50. But if you have any other comorbidity, then definitely diabetes and all, which is quite common, sir.
So thank you so much.
Thank you, sir.
So just a wonderful talk, sir, highlighting all the practical points. For zoster, we have Amitabh Bachchan promoting the Shingrix vaccine, GSK's vaccine for adults who are more than 50. So following that, we have had a few patients who have started asking prostate cancer specifically that whether it should be taken, not taken. So few of our patients who are on hormone therapy, definitely. For those on chemo, as you said, I think this is a dead vaccine.
See, it's a recombinant, it's safe. It is actually studied for these kinds of patients.
And so routinely we do promote them to take these vaccines. And one comment that not only infections for urogynecological malignancies, the importance of an HPV vaccination for both boys and girls needs to be emphasized here. So this vaccine is not only going to help for genital warts and all, but also for malignancies of the oral cavity as well as penile cancers, even in boys. Is there a policy for HPV vaccination in boys in India?
From Government of India point of view, they recommend only for girls, because of the reason being that it is cost effectiveness. Because once you launch a vaccination for pan India, it's a very huge burden. But yes, guidelines do recommend for giving vaccine to boys also. Yes, sir. It is recommended, sir. It is recommended. Ideally, all boys should get vaccinated for HPV before their sexual debut. So during their teenage, definitely they should be. After the sexual debut, it depends on the case-to-case scenario. The effectiveness comes down, but it is still recommended. No, it is recommended, sir. Government of India has not launched as a part of the program because there is a cost-effective analysis too. I mean, you can understand, government can't just give you all boys come because the burden is huge enough. We are a populous country, sir. Yes, sir. Yes, sir. It's already done in many places. Yes, sir. Yes.
Thank you so much.
Thank you, sir.
अबे कहाँ चला गया ये?
Thank you for enlightening us with that discussion. Empirical use of higher antibiotics is often debatable in the ICU setting. And for our next discussion, role of empirical colistin poly B, we have the absolute honor to invite Dr. Vishwak Chandar, Chief of Breast Surgical Oncology Unit, RGCI, Dr. Nitin Jain, Head and Director, Critical Care Medicine, Paras Hospital, Gurgaon, Dr. Manish, Consultant, Critical Care Medicine, RGCI, Dr. Mamta Dubey, Senior Consultant, Anesthesiology, RGCI. Please give them a round of applause. I humbly request one of the chairs to please invite the speaker for the session onto the stage.
Good afternoon, everyone. This is a pro-con session that we are having today. And I would like to invite Dr. Rajesh Pandey, who's the Principal Director and Head, BLK Max Center for Critical Care. And he's an expert in, he's associated with National Medical Commission, the Medical Education Commission, National Board of Medical Specialties in Nepal. And he's been awarded as an inspiring intensivist several times at various forums. He's got more than 56 publications, several book chapters. So he's a very well-read and I should say, pioneer sort of person in this. So, and his areas of interest are sepsis, ARDS, end-of-life care. So you'll be talking for the motion, right?
For the motion.
Yeah, so we have Dr. Rajesh Pandey, who will be speaking for the motion.
Thank you, madam, for the kind words. And at the outset, I would like to thank Dr. Rajiv Chawla, Prashant, and their team for inviting me here. And me and Devashish, our association goes a long way, so we are friends. There are no adversaries here. So that is one disclaimer. And second thing is I have not used AI in my presentation. I've just used the design template of PowerPoint. So it seems to be a very simple, straightforward issue to many of us, but it is highly complicated. Polymyxin is one of the old antibiotics, which was discovered in 1940s, and then it was gradually banned from the practice because of neurotoxicity and nephrotoxicity. It is only re-emergence came in 1990s after pioneering work from Greece and other areas. Greece in Europe behaves like India. It's a gram-negative country. So we found there were a lot of MDRO bugs which were resistant to the conventional and the modern antibiotics, but they were sensitive to colistin, polymyxins. So B and E, I'll just make a differentiation. E is for the renal infections, UTIs, and B is for non-UTI, all related infections, broadly speaking. So currently, we use them very much. They are part of our armamentarium, despite having other advances, other newer agents. So let me share my thoughts on this topic. Now, Anand Kumar is a pioneer Indian Canadian who said that we have to give empiric antibiotics early on in difficult situations like septic shock. He gave this, concept that there is a microbial load. If the load is high, then the septic shock is severe. And if the toxic burden, endotoxin, exotoxin burden is high, then also there is a problem. And every individual based on the host factors will have a certain shock threshold. So by giving antibiotic early, he said we can bring it down. So we can reduce the toxin burden, inflammatory response, and the tissue injury as such. So the early is better. There's no doubt about it. Whether colistin or any other agent, that will come later. So when we talk about empiric antibiotic, it's based on our belief that this antibiotic would be effective against the supposed organism that we think is causing the infection, and it will have good penetration in that site where we think the infection is before the bug is identified. And we know if it is initial choice is inappropriate, particularly in difficult conditions like septic shock, there could be 5-fold reduction in survival. It can drop from 50% to 10%. And the drugs that we are using initially, the therapeutic concentration should reach the target tissue or site. And if the patient has MDR risk factors, when we are initiating empiric antimicrobial therapy, we need to consider them because then the choice differs. You have a chronic kidney disease, CLD patient who is diabetic, who is hypertensive, who has other problems. Obviously, the choice would be difficult. Choice will be advanced antibiotics because the risk for MDRO is high. And also, it is very important for us to know what is our local organism, what is our local flora, and what is our antibiogram. Whether in RCGI or in my hospital, BLK Max Hospital, this particular antibiotic is effective or not. So it's very important. Then you can make a choice. Early administration is important. That's what Kumar said. So 80% survival if antibiotic is given in septic shock within 1 hour. Each hour delay reduces survival by 7.6%. And if there is a 6-hour delay, survival would be only 42%. And also look the concept of loading dose, because of late after 2000, the new class of antibiotics were very, very few. So we went back to our basics, PK and PD profile. So loading dose is mandatory for colistin. That is very important for many other antibiotics, but for colistin and poly-B it is important. Now, in a hospital, we encounter two common situations. Patient presents with septic shock, may have come from home setting or from another hospital. Now, the context is different. Another hospital means he is exposed to antibiotics, he is exposed to the MDR bugs there, so our choice would be different. If he has come purely from home and the condition they did not bring in time and condition has deteriorated, maybe the bugs are not as complex or not the MDR bugs. Second scenario, patient does not improve within a week's time and he continues to be sick. We suspect that there could be MDROs now, hospital acquired infection could be there. If he has a lot of lines, pipes, tubes, etc. And then also we have to evaluate for risk factors for MDRO and also look at the host profile. This is very important. If he fits into that host profile, that yes, the risk factors are there and the patient profile is poor, he is diabetic, hypertensive, CKD, so and is on dialysis, so that means he's likely to have severe kind of infections. And how to choose? I need to know the source of infection, most likely pathogen, patient comorbidities, allergy history, recent antibiotic use, concurrent medication, organ function, risk factors, and my local flora. So this is what we know. This is what we all do, that besides this, we have to do source control. Now, these are the major MDROs in your hospital as well as my hospital in India, which is a gram-negative country. You have CRAB, you have DTR Pseudomonas. Now, MDR Pseudomonas is when Pseudomonas is resistant to one class of anti-pseudomonal antibiotics. When it is resistant to all known classes of antibiotics, you call it difficult to treat resistant Pseudomonas. And enterobacterials, we have ranging from simple ESBLs to carbapenem resistant to AMC producing enterobacterials. So this is the spectrum that we have for gram-negative bacteria. And whenever you think of MDRO, looking at the complexity of the patient who is presenting to you, the colistin will come to your mind. That is why I'm showing this. Now, there are different resistant mechanism. Bacteria, gram-negative bacteria is highly complex. So there could be different resistant mechanisms. We need to know that. we can identify only few. Your carbar gives you only ESBLs, nothing else. No efflux pumps, no loss of pouring channels, no PBP modifications. So this we have to know. So polymyxins are predominantly for gram-negative, particularly for MDR and XDR organisms or pan-DR organisms. Mechanism of action, they are positively charged, bind to negatively charged phosphate group of membrane lipids on the gram-negative bacteria. And the divalent cations, calcium, magnesium, they will destabilize the lipopolysaccharide and call the cell lysis, causing the cell death. And they also inhibit the respiratory enzyme type 2 NADH quinone, which is there in the bacterial cell membrane. Now, if you look at the colistin spectrum of or polymyxin spectrum of activity, they are effective against Enterobacteriaceae. Now, look at the bugs, Salmonella, Shigella, non-fermenter like Acinetto, Pseudomonas, and most strains of Strenotrophomonas maltophilia. Now, most of my colleagues who work in intensive care unit or who see a lot of transfers or complicated patients coming to them, these are the bugs that we find there. They are not effective against most anaerobes and gram-positive and other gram-negative cocci. So that means I need to know what is my flora. If I say with conviction that yes, colistin is to be used as empiric, must be considered, not used, considered. So I need to know my flora. Now this is my hospital data. So you can see my hospital has 82% gram-negative bugs and carbapenem resistance in the hospital is 40.6%. If I look at the colistin resistance, it is, we are doing good, 2.4%. If I look at my ICU on the right-hand side, total 30% of the isolates are there in the ICU. The gram-negative is about 80% again. And carbapenem resistant enterobacterials, if you look at E. coli, 30%. If you look at Klebsiella pneumoniae, almost 75%. Colistin resistance in my hospital is 0% for E. coli. It is about a little less than 5% for Klebsiella pneumoniae. So this illustrates the situation in my hospital. So you can see the carbapenem resistance in gram-negative organisms, and it's about 60% overall in the ICU. The blue bars are hospital, red bars are the orange bars are the ICU. Again, colistin resistance in ICU, you can say it is 4.5%. E. coli Klebsiella, Klebsiella is a problem bug. As you can see here, almost 75% is resistant to carbapenems. And colistin resistance is also high, 4.8% for Klebsiella pneumoniae. If you look at Pseudomonas and Acinetobacter, Pseudomonas almost 53% is resistant to carbapenem. My Acinetto is 96% resistant to carbapenems. So what is my choice? We were told, and we are still using it, that if you have to choose a gram-negative in septic shock, meropenem would be a very good antibiotic. It covers gram-positive as well as a lot of anaerobes. And you can, if you feel there is a gram-positive infection also, you can combine with glycopeptide. But I can't use it here. As you can see, there is significant problem of resistance. And if you look at the colistin resistance, my colistin resistance for Acinetobacter is less than 1%. For Pseudomonas, it is less than 2%. That means if I choose them empirically, they are very good choice here when I'm suspecting these two MDROs to be there, infecting the patient. And if you look at the burden of MDRO, again, MDRO CRE and the colistin resistance is much less in my hospital. And you can see the antibiogram. This is respiratory samples only. This is Klebsiella in the hospital. So you can see the colistin is very, very sensitive, but then the graph declines steeply. So if your choice is among those which are declining steeply, then you know the efficacy, effectiveness will not be there. Survival would be affected. And for Pseudomonas, again, you can see the difference. The first bar is colistin. And for Acinetto, you can see that it is still 100% sensitive to colistin. And if you look at the carbapenems, there's a dismal 1%, 2% for meropenem and imipenem. So how can I choose a carbapenem when my resistance to these bugs is very, very high? So that means I need to know my antibiogram, I need to know my flora, and then I can take a call what should be my empiric antibiotic choice. A lot of fancy new BLBLIs are available, but look at them.
none of them affects the class B metallo-beta lactamases. So that's where all of them are not effective. They may be the newer Avibactam may be effective against class D OXA48, it may be effective against AMC, but not against class B. That is where if you are doing carbar, most of your bugs, Pseudomonas or Klebsiella or Acinetto will have either NDM as the resistant mechanism or NDM and OXA combined. Very few will have OXA48 only. So that means these may not be effective. Anyway, we don't promote ceftazidime avibactam to be used as an empiric initial choice. So therefore, ladies and gentlemen, I think polymyxin are an important consideration as empiric antibiotics in my combination therapy. That means I'm not saying that I will use them mandatorily as empiric antibiotic choices in all patients. I'm saying I'll consider them very, very seriously. I will look at the patient profile, I will look at the severity of his presentation, and then I'll take a call. I'll repeat, for urinary tract infections, if I have to choose a polymyxin, my choice will be colistin, and for all other infection, polymyxin B would be my choice. So that means in current scenario, we cannot forget to think of carbapenem when we are initiating empiric antimicrobial therapy. Thank you very much for your attention. Thank you.
We have a session later on. Yeah, so we'll call Dr. Debashish Dar, who will talk about against the empirical therapy.
So, good afternoon to all of you, respected chairpersons, and Sir Dr. Rajiv Chawla, my teacher. He has invited me. Thanks to Prashant, and obviously thanks to Dr. Pandey for making my talk so easy. So whatever he has spoken till now is absolutely right. And that is the approach we all have for any infection. And that is how we all do it. But the question is that when you talk of pro and con, it's a two sides of the same coin. And ultimately you come out with a consensus and you decide what is to be done. What he has made a statement is a word blanket that we give cholesterol to everybody by and large, and that is a safeguard. I agree, that is the safest guard we have at present. But there are something more to it also, which actually he didn't say, so which I like to say. And it's nothing like that. And once both the things are there, that gives you the complete idea, the consensus you can decide. So when you come to the role empirical cholesterol, and I assume that you are discussing only the MDRs, XDRs, and the hospital acquired. With that disclaimer, I'm not talking about the community acquired patient who has come directly to us. Already this has been discussed by Sir Dr. Pandey already. So why not cholesterol? Because I am the cons, so I have to say that. So let's see the other aspects. What he has said is the microbiological aspect, the killing aspect. And I'm sure the way the data he has shown, his data shows that such a small cholesterol resistance in his ICU and in the hospital, that means he's not using cholesterol as a first line of drug. Otherwise, by now it would have increased a lot. So I'm sure of it. But that shows that is how it should be actually. So there's nothing wrong in it. So why not cholestins? The reasons are its pharmacological limitations, side effects, the macroscope, your macrobiologic challenge, its evidence-based and cholesterol sparing for the future. I'll try to discuss one of them, all of them. See the pharmacological limitations of the polymyxin. There are numbers of polymyxins are there, polymyxin A, B, C, D, E. When it comes to the treatment part, as I said, polymyxin B and E. E is the cholesterol, we say, but that is a prodrug which we give, which has to be converted. And polymyxin B is also available. That is not to be used for, except for the UTI and the urinary, other things it can be used. Now both these drugs, for the cholesterol, it has to be converted. It's a prodrug. So if you are giving cholesterol, we don't know exactly what the pharmacokinetics they will take. And it takes up to maybe 36 to 48 hours, maybe more, for the plasma level to reach. When it comes to the colistin, inherently, you find that it has a association, historically we know, both nephrotoxicity and neurotoxicity. And that is why the reason that they have been withdrawn earlier. So that is already there. And definitely the patients who are in our ICU, they already have a compromised renal function. They are also on so many other medicines, hypertension, they have high risk factors. So once I start this colistin polymyxin, I have to be very, very cautious, and usually incidence of your AKI increases in them, and this is a lot of literature, all of you know it. Now coming to the plasma level and your target, you call it MIC or breakpoint. So if you see that it has a very narrow spectrum. So your target is, as it is said, it should be 2 microgram per ml. That is the less that you should have, or 2 milligram per liter. So that target, how you achieve, whether you really achieve, and that to the site of infection, especially in the patients in your pneumonia and those, it has been found that colistin level is very, very low in the lower respiratory tract. So we fail to achieve the target at the site of infection, which is very, very common. So all these things makes it a pharmacological dilemma, and we may give the medicine, assuming that it will reach, but it may fail to reach and do the job that for which you have given the patient. Now, the biggest challenge is the diagnostic microbiological in vitro use. You know how it is, because colistin is a very heavy molecule, the polymyxin both. They don't diffuse through the disc. So as a result, the normal disc methods, the Vitek and that which is normally used, are of not much use, are not to be used for the polymyxin. For that your traditional old broad dilution technique is a technique of choice. It has to be done separately. This is what the UCAS, CLSI, all they recommend. And till date, getting MIC value or breakpoint value, it is not possible. If you see any sensitivity report anywhere for the ISO, this, they give you a I. It is intermediate. They never say sensitive resistance or this thing sensitive. They write I intermediate, and they in the report they write a disclaimer. As per the CLSI UCAS guidance, we can't give this because this is by the broad dilution, and that is what the challenge is. So what I am targeting? I am giving the medicine. It is a toxic supposedly. I am giving a doses like that. Suppose 4.5 million units BD or 9 minutes loading dose I am giving. But where exactly, how much should be the target that we should achieve to get your MIC? It is not there. It is missing. So that is the biggest challenge when you are using microbiological for the polymyxin. And this is what you can see, that this is the 2024 it's a guideline where you can see they have given for all the bugs that has now said Dr. Pandey. You find that when it comes to the colistin, it is silent. It can't say anything about the MICs and that. So we have no target to achieve. We don't know exactly. So we are as if we are shooting in the dark when you are using polymyxin. That is one of the biggest criticism about the drug. So this is the colistin timeline, as Sir has also shown a different slide. It is something similar. So if you see that colistin was withdrawn somewhere in the 1980s, 85s. Why it is so? Because that is the time when you see that new quinolones, your third generation, second generation cephalosporin, they started coming, then followed by their carbapenem came. So they are there, to all these beta lactams, to take care of your infection, and so the patients are improving. And this continued till maybe 2009, 2010, when the NDM came. NDM was discovered somewhere in 2009 or 10, and that changed the scenario. So we didn't have any antibiotic to take care of those beta-lactam, the NDM, the metallo-beta-lactam. And so again the resurgence of your colistin came. It was shelved, but again it was brought because that is the only thing which is available to us at that time to tide over that crisis. And there are no other alternatives available at that time in the market, except, so we are stopped at the carbapenems that time. And now it continued for that. This is a study which I know this is classical iconic 1 and iconic 2, so the same group is a consensus. This is 2019 and 2024. Now they write in the same, this is Indian class. This is, you can see the same verse in the both the years. But your recommendation changes. Now it is following, now it is said that you go for this avivectam and aztreonam. The reason is it is availability. So avivectam and all those things, they started coming from, they are initially in 2015, 16, 17, and then in India it started coming somewhere around 2021, 22. And now beta-lactam, that is the treatment of first line of drug when even if you are doing MDROs. Why it is? Because the safety profile, because of better macrobiological, you can say MIC, and it's a, you can treat them as per the need of the patients. You can see what exactly the beta-lactamase is, and that we have the BCID panels and everything which has grown over the time. And you can identify what type of your beta-lactamase is there, and accordingly you can titrate, you can individualize it. I may give avivectam only, I may give avivectam with aztreonam. Whether I give or don't give or decide, so this is how it can be decided. Not that I give a blanket cholesterol. It's not like that. So this is ICMR data, and this is the Indian scenario. All over India, the pan-India scenario, as you can see, the commonest bugs are your E. coli and Klebsiella all over India. In ICU, around 20-25% of the 25% of the patients, the Acinetobacter they have identified. But if you take overall, it is still the other GNVs, they are more. So Acinetobacter is the only thing where there is issues, where beta-lactam and beta-lactamase, they may fail. We'll discuss it. And when you talk of the resistance genes in the, you find that E. coli and Klebsiella, they are universally present. So beta-lactamases are all there in all our ICUs, in all over India. This is ICMR data. Not particular to our hospitals. Our hospital definitely are the tertiary hospitals. We have more of such patients. Any of these hospitals which are your high volume tertiary care hospitals, Gangaram, SARS, LK, Fortis, all these, even your Rajiv Gandhi, the referral hospitals, they always have a different portfolio. The antibiogram that can reflect what all is there. But this is the general Indian data which has been there. This is 2022 data. So for that to take care of, now we have got a combination of beta-lactamase and VLBI beta-lactamase inhibitors, and these are the hot all are there in the pipelines and there. Out of which in India we have this is available, definitely aspirin available, plasmamycin is available, and this is available in the grey markets. So these are regularly available. We are all using it. Lot of us are using it, and rest of them will sooner or later will be available. And if you can see that, if you combine them, so you have got all the three classes of that your this thing, beta-lactamase. So if I have got a metal beta-lactamase, in that condition, definitely this will not act. You have to use your monobacterium, that is your aztreonam. So metabacterium, that is the time when you have to use. Others, the same thing you can continue. The plasmamycin is aminoglycoside meant for only to be used for your resistant UTIs. And this is the latest your this thing. It's a guideline for 2024 where all the things for this they say that colistin is if it is unavailable, then you use colistin. So colistin is now as a second line. The first line of drugs that remain is the novel beta-lactamase, which is the colistin you use only if you don't have availability of those medicines. And when you compare, there are numerous your analysis and meta-analysis, everything available, which compare BLBI with the colistin polymyxin, and they found that effectivity is same or rather better. And one thing is universal, all the patients where polymyxins have been given, they have definitely increased in incidence of AKI. So these are the number of studies are available. I just quoted one of them. Now coming to the Acinetobacter, which is the classical reason why the colistin has been said to be the drug of choice always. If you go by the ITSA guideline again, the drug of choice, the first kind of medicine is your sulbactam, durlobactam. But that is not available in India. So otherwise, if sulbactam is available, up to 9 grams of sulbactam you can give, which you normally give, along with the combined with some drugs like your preferably minocycline, and that can be an effective drug. You can try. If you don't have the problem in that conditions, you are patient not relieved. In those conditions, definitely you can go for if the drug of choice remains is polymyxin. About that, there is no question. CRAB is one condition, that is your carbapenem resistant Acinetobacter. Drug of choice remains is the colistin. About that, there should not be any controversy. But sulbactam is the one, but suppose that is giving a 9 gram per day of sulbactam definitely causes a lot of AKI and this. Because whenever you are talking of this subset of patients, they are in the ICU maybe for 10 days, 7 days, already they have a lot of other organ compromises started happening. So carbapenem resistant Acinetobacter is one group. If you suspect, you must use polymyxin as maybe the first line drug. And if you use too much of polymyxin, this is the latest data all over the world. All these countries which are black, they have no data. All these countries, they are having increased amount of colistin resistance. And it goes up to 10% all over globally. And in India, this is the latest, which shows that 20 up to 15% is the your CRAB resistance, your this colistin resistance already reported. And average in Tamil Nadu, it has the maximum, which has gone up to 25%. It is because of a lot of use which is being done, not only in the medicine as well as in the agriculture and other things, the poultries and those things, leading right to resistance increase. So if this resistance increase happens, so this has to be stopped. So when you have a choose between the two, you have a UV vehicle now is the start, we are starting everybody. It is not that it is going to answer. UV vehicle not change the treatment scenario. It is something like beta-lactam you can say, but it is a safer option. It is less toxicity, it is not less fume release. So ultimately, but you can't drive EV with you can't think of flying with your planes with the electric. It's not possible in the near future. Or drive a heavy vehicle with EV. It is not possible. But we have to use it in the more justified way so that we can conserve it for the future. So time has come because of VLBI and other things. They have come. Such a number of drugs are coming, and which are equally effective. We again should shelve the colistin and keep it as a reserve so that we can use it maybe down the line to 20 years, 30 years, 40 years down the line. We don't know. Because this will be a continuous fight between the your bacteria and us. It will continue. The microbes will keep on changing. And they will going to develop the uniqueness of the polymyxin is that they destroy the cell wall. Rest all the BL everything, they fight with the enzymes, they try to inhibit the resistant enzymes. So it will definitely be effective later also. So that is why we have to be prudent and see that when to use which one. Thank you.
Yeah, we would like a rebuttal
Well, sir.
from both sides.
Nicely spoken, presenting some Indian data and largely depending on IDSA, which they say modify as per your need. So one thing where we share a common thought is it's an antibiotic developed in the 40s. So it did not undergo the usual developmental process, phase 1, phase 2, phase 3 trials. So a lot of people, when this drug was starting to be used for NDM, they said that we need to rediscover the drug and maybe subject it to the same process again. But then commercials were more important, so nobody did that. Now, second important thing is he mentioned that ceftazidime, avibactam, plus Estunam. Ceftazidime, avibactam, when it was launched in India, there was already 20% resistance in the US. Please remember, drugs come later to India. And when you combine with STO-NAM, you have to do synergy testing. In my hospital, the synergy positivity is not there in 20% of the isolates. So blindly, you do not know if your patient is that in that 20%, you have a problem. Because oftentimes you get a report where it is showing resistance to ceftazidime avibactam as well as to STO-NAM. So that is where you need to do the synergy testing. Synergy values are different for Pseudomonas and for Klebsiella and E. coli, it is less than equal to 4. For that, less than equal to 8 microgram per mil. So that is one more caveat here. It is not very, very simple. Cefiderocol has been proposed as an alternative. It may not be the panacea for the New Delhi metallo-beta-lactamases, NDM bugs. So that is still a problem. It is not, otherwise it would have come as #1 choice, single drug. Probably the future would lie with a drug that an Indian company is developing, cefepime zedibactam. We have used compassionately this drug, and it is effective against all classes A, B, C, D, but the real world data, once we start using it, they are waiting for the US FDA approval. So coming back to the point, colistin, still the resistance is very, very low. My friend highlighted that it has a better killing. It is a cidal drug as compared to the conventional antibiotics. So whenever you have, I never said that you use it. If you remember my words, I said I will consider it. Correct? That's what I said. So always consider this when you have your most difficult situations. Generally what we do, say for example, second time after 7 days, we add, let us add 1 polymix, and that's what or a colistin, depending on where the infection is. So I think these two presentations complement. I'm not saying that it is bad, but the usage has come down significantly. Plus your hospital has to monitor these usage as well as the resistant patterns.
No, what sir has said, actually we said the same thing. We are all in the same page. The only thing is that, see, the one thing more factor which sir has not said, we are not said the cost factors. Because for getting this, you have to put a BCID panel. Now, BCID panel might your hospital cost 25,000 straight away. To be very frank, I don't know your cost. Our cost hospital cost 25,000. So BCID panel you put, you get the result. Okay, you put the BCID panel result you get within 6 hours, 8 hours. But if you talk the total cost of beta-lactam and that, it is quite costly. That is definitely we have to consider. But you have to take the concern in the larger perspective, and we have to don't forget antibiotic stewardship. That is one of the big things. Though it is slightly industry generated, but antibiotic stewardship itself says that we try to be more specific as far as the carbapenems and whatever you are getting accordingly. So that way again it fits into it, the BLBI and that. It's slightly industry driven, I agree. That way colistin is one thing, it's a Ramban. No doubt about that. No.
But again, if you see, the safety profile is not great. So there is significant neuromuscular weakness, and the CLSI and UCAST were earlier labeling it as sensitive. Off late they said we are not sure about it because we don't know the values. So they say give intermediate.
That was wonderful. You see, seeing two of your close friends fight out academically on stage, that is a nice experience. And the other thing was Gangaram versus BLK. That was yet another experience.
It was never that. I still consider being part of Gangaram.
That was on the lighter note. But I think now with both the ICU experts having given their opinion, the best thing would be a neutral person. Let us have our microbiologist, Dr. Neelam, to say something. And please don't do something what that monkey did when they were fighting, and he had the best of it.
Yeah.
Like what we have observed over here is of late, like according to CLSI guidelines, colistin is not to be given. It has to be done either by microdilution method. Otherwise, being heavier particle, Vitek doesn't give you a result. So that was one story, like we were not even able to report. So that must be one reason when it is not reported like everywhere. This was the same situation. You can't do broth microdilution. This is going to take your life, even if you do it for one individual. So everybody has stopped it, and maybe that was the reason that it was sensitive in your this thing. If you say, like, we carried out a study in our institute and we found that 50% of the population, they carried carbapenem resistant bugs in their GIT tract when they came to our hospital for the first time in OPD. So, and majority we know it, either it is NDM or either it is NDM-OXA combination. OXA is very rare. KPC is not there. IMVIM also hardly we see anything. We were also doing by carbar, but then we saw that even if you're doing a carbar testing, even if you know that it is NDM or OXA and you start with ceftazidime, avibactam to begin with, people were doing it only monotherapy. And when they saw it is not responding, they started adding azithromycin. But you're absolutely right that 20% synergy is negative, irrespective of both the drugs are there, because majority it is NDM. So what we saw in our study was people who had carbapenem resistant bugs, and when we were carrying the colistin sensitivity, when CLSI never said that don't do it, we were doing a manual testing also, we saw that 50% population were resistant as well. So when obviously you'll go back, see the literature. So 1980s, they withdrew this drug basically because of the side effect one. And another, this was too much of it was being used in the poultry forms also. So we had already been consuming this drug and this is becoming sensitive. It's just that they have lost their R gene. We have not been using it. We have not been testing it. It is not being given to clinician for the usage. They have not been using it. So I think, like they can be reserved rather than using it as an empiric use. Clinically, we will know better. I can just tell you about the my subject part. We can always keep it as a reserve. And this colistin can be added with any drug. Basically, it is dealing with cell wall. Once it makes a hole, now you give any drug along with it, it's going to work. So we can keep it as a reserve rather than empiric when you have other choices available. So even if you start, if you have something else available, I think de-escalation is the best which you need to do it. Or maybe if we don't use it for years together, they'll be losing their argine, they'll become sensitive again. The way we have been seeing that cotramexazole, it has become sensitive for Klebsiella, that too sometimes in carbapenem resistant also. We don't have a heart to start with that. That is a different story. But then ultimately that has become sensitive. Aminoglycosides, if you check Amiga and Genta, that has become sensitive. They are more than that of imipenem and meropenem also. So I think we can leave it for a few years and then we can start again if we have some options available and it is sensitive. Because CLSI is also, you can't report and I can't do microdilution. So I think, like sometimes.
Safety profile also based
Yeah,
very, very important.
profile also
Based.
is there because renal failure is
If you
one
can
component.
overcome the infection, but the patient lands up with significant dialysis dependence, that's not good.
Yeah, he's come with.
And weaning is a problem
something
again
else.
with this.
Yeah, in fact, that was the reason. That was also one of the reason that in 1980s it was withdrawn because renal failure was more.
That's
This
why
was
neurotoxicity
yeah.
major reasons.
Okay.
But actually, ma'am, there is something the difference of bench to bedside. So when in the patient, we are in the bedside when you are practicing, what you are telling, absolutely right, theoretically, all these things. So you have to see from the other side. Suppose you are the patient or somebody, patient relatives and that, and you found that your patient is deteriorating and we are at a loss and that, then we have no choice but to start this medicine of cholesterol. We do it all. Let's accept that.
Yes, yes.
That's what I said. Available.
And see, see, ma'am, what you said is very right. When you are doing in vitro studies, there are more difference. In vivo, maybe something different.
That is always there because.
That is always there. So our albumin level, protein, we don't know all these things. There are so many nitty-gritties. And whether you are really getting at the site, the source, how much is the drug concentration? You have given MIC level, but if that MIC level is really effective at the site of the infection.
A lot of our patients have large, they are fluid overloaded, they are hypoalbuminemic, so everything changes. Everything changes.
CRT going on. I mean, so we have no choice. When we are pushed to the corner, we have to. And we have to be rational.
I have been.
No.
Be rational.
Be rational. Don't use it when you're pushed to the corner. Use it before that.
One second.
Macrobiological, we are irrational.
Actually, after my statement, both of you are together now. What do you say?
No, let me.
That is exactly what I wanted, that we end up in friendship and truce. You better shake hands before you fight again.
Dr. Chawla, we had one phone conversation. So both of us, yaar, kya bolna hai? Kaisa topic? We said we'll enjoy it there.
This is truly political.
So that's a very well presentation from both of you. Anyways, the decision will be on individualized based on the patient being hospitalized, as mentioned by both of them. It's a very good presentation.
तुम क्या चाहोगे क्या होगा अरे यार क्या more damage मैम ने इतना अच्छा बोला मैम तो मैम आओ मैम जाओ प्लीज मैम आओ अरे मैम नहीं मैम आओ
No, I just made you two together. You both are great teams. करना चाहिए that's all. Anyway,
I'm back.
thank you.
Sure.
ज़्यादा बड़ा हो गया
We'll take 2 minutes to set the stage for the next panel discussion. Give us just 2 minutes.
So, after thought-provoking lectures, we are now moving into panel discussion phase. And our first session addresses one of our biggest hurdles in oncology, that is infection, which is the leading cause of mortality in the onco setup. We will now discuss role of healthcare providers in preventing infection in cancer patients. And to moderate this session, it is my pleasure to invite on stage Dr. Rajiv Chawla, Director Anesthesiology, Rajiv Gandhi Cancer Institute and Research Center. Please welcome him with a round of applause.
I think you invite and introduce the panelists, then I will carry on further. मैं भी साथ में खड़ा हो जाऊँ.
This session is partnered by our associate BD.
You see, the session is on role of healthcare providers in preventing infection in cancer patients. For this, we have panelist Dr. Rajiv Kumar. He is the chief surgeon, breast surgeon of our institute. Dr. L.M. Darlong, he is head of the thoracic surgery. Dr. Payal Malhotra, she is a pediatric hemato-oncologist. Dr. Indu Agarwal, our preventive oncologist. Dr. Gaurav, a representative from the industry BD. Dr. Nitin Bansal, Madam Surya Sukumaran and Tanu Dhaya. And I'm not sure, but we have made the session live basically for the benefit of the patient. अरे चंदन भैया तुम ऐसे रख दिए तो मैं इनके कमर ही देखता रहूंगा। थोड़ा सा चेयर उधर था। और एक काम करो, नहीं तो मेरे को माइक दे दो, मैं आ गया। माइक दे। कर देते हैं, पोडियम घुमा दूं क्या? ऐसा घूमेगा भी तो नहीं ना ये। चलो ठीक है, दैट्स गुड। You see, this session is also having a live transmission basically for the benefit of the patient and their attendants. As I said in the morning in the inaugural session, some of you might not have been there. Medical treatment is only one part of treatment which is given in the hospital. Cancer is a long journey. It requires treatment at home also. So healthcare workers are not only in the hospital. Your family and friends also form a healthcare worker for that patient. And we will go on the assumption that every cancer patient is at increased risk of infection. Be Dr. Rajiv Kumar, Dr. Dorlang, Dr. Payal, and all the other medical fraternity who are directly involved in patient care, one thing that haunts them most is infection. अगर लंग इन्फेक्शन हो गया पोस्ट ऑप तो डॉक्टर डार्लंग परेशान हो जाते हैं। ब्रेस्ट सर्जरी के बाद अगर इन्फेक्शन हो गया तो डॉक्टर राजीव कुमार परेशान हो जाते हैं। पीडियाट्रिक्स में हो गया तो डॉक्टर पायल परेशान हो जाती हैं, और ये सारे मिलके डॉक्टर नीलम को परेशान करते हैं या डॉक्टर नितिन बंसल को परेशान करते हैं। So that is what a common shared goal had brought us on a common platform. Now, cancer is a disease in which the cells grow out of proportion uncontrollably, and we all know that. And this is primarily for benefit of those relatives and friends of the patient who are probably non-medicos. Some have called cancer as a war. Richard Nixon in the year 1971, on 23rd December, said, we have to fight a war against cancer. वो वार भी खत्म नहीं हुई और ईरान की वॉर भी खत्म नहीं हुई. Wars never end. Some say it is a long journey, and I am sure you would agree, because again, this journey is very long and it has a very uncertain course. And if it is a journey, it is a bumpy road. यार मेरी पानी की बोतल रह गई, देना जरा. It is a bumpy road. It could be long. It is not at all enjoyable. It can be tough. It can be painful. There is a lot of anxiety and fear. And it can be very distressing and disheartening. And if you see, it requires a multidisciplinary approach on this bumpy road. And you have a large number of team which takes care of you. How many of you knew that infection is the second leading cause of death? Not many, till I informed or the CEOs are informed in the morning. How many of us know that 60% of cancer-related mortality involves infections? How many of us know that it's the highest within the first 1 year of diagnosis? It is 9 times higher in the general population. And why is it? It is either because of the disease itself, or because of chemotherapy, immunotherapy, surgery, stem cell transplants, or the medical devices that we put in. Thanks to Gaurav, he gives us all sorts of medical devices. The mortality is 3 times higher than the general population, and 1.3% of the cancer patients are dying because of infection. The leading cause, as Dr. Nitin had said earlier, pneumonia, influenza, and septicemia. It could be gram negative, but gram negative positive, but gram negative is also known. And because thanks to the immunosuppression, even fungal infections are common. Drug-resistant infections are also known. The previous session showed us all that. So infection is a serious threat. It is better to prevent it. Important thing to know is the patient is not alone. He is assisted by the healthcare providers to meet the challenge of cancer. And this is a large group of healthcare providers which help the patient, right from medical oncologists to genetic counselors, radiologists, physiotherapists, radiation therapists, plastic surgeon, breast surgeon, and all. If I summarize it, it is the medical team and the non-medical team. Non-medical team, we have preventive oncologists like Dr. Indu, they say cancer, no cancer. We have doctors like Dr. Rajiv Kumar and Dr. Darlang and Dr. Payal who will diagnose and try to treat and cure it, either by surgical interventions or medical interventions. But it is the nurses who tend to implement it. Because the diagnosis and care does not require a direct interaction for hours together, but it is the nurses who implement in the ward for hours together, days together. That is the key role of the staff nurses, and that is the reason I have two representatives from the nursing. One is Surya and the other one is Tanu. Then we have the advice which is followed at home by the family and friends. Medical advice, being a long journey, they provide a social support. And if there is financial constraint, some of them even provide that. So infection is a scare, but it is not if you care. If you are ignorant, you are a carrier of infection. But the moment you get informed, you become a barrier against the infection, and that is what is important. Luckily, yesterday we had the nurses education, CME, where I told them, you better become a barrier and reduce your being a carrier. All the healthcare givers must know what the role of hand hygiene. They must know how to identify their high risk factors. They must know when to get alarmed and how to get alarmed. Only then you will identify at home कि हाँ भाई ये तो खतरे की घंटी बज गई. You must know well-defined prevention protocols. What precautions are to be taken if a PICC line is put in by Dr. Shalini or a chemo port has been put in by Dr. Rajiv Kumar and their team, and what are the various do's and don'ts. How to prevent infection if the patient is being discharged. What is a safe home? How good is the cleaning to be done? How it is to be done? If I have a garden at home and I am a cancer patient, is it good for me to have a garden or not to have a garden? If I am an animal lover, should I have the pets at home? If I am in the village, should my buffaloes and cows be cared for or leave them for others to care? What is the role of education of caregivers? What is return demonstration? खाने से भी इन्फेक्शन आती है क्या? डॉक्टर नीलम तो कहेंगी आती है अगर तुम ध्यान नहीं रखोगे, पर कब आती है क्या है? So these are some very important issues of importance. Amit. Then we talk of vaccination. Dr. Nitin talked about it, and I'm sure he will have to probably repeat some again. Dr. Indu always talks of vaccination against cancer. Madam, cancer से तो बच गए, पर कैंसर के बाद कैसे बचना है, ये भी वैक्सीनेशन का आप बता दीजिएगा. घर में रिश्तेदार आए तो क्या करना है, किससे बचना है, कैसे बचना है. मरीज को देख देख के मैं बहुत परेशान और थक गया हूँ. हाउ टू मैनेज दैट एग्जॉशन, विजिलेंस. If I find my colleagues not doing their hand hygiene properly, how to inform them कि मेरा झगड़ा नहीं हो जाए, but the message is conveyed properly. What are the patient's responsibility? आपका अपना ध्यान आपको खुद ही रखना पड़ता है. तो आपको क्या जिम्मेवारियां हैं, क्या समझनी है. बहुत मुद्दे हैं. अगर आप देखें ना, it is a never ending list. We will try to cover a large number of them, and I hope we will cover majority of them. To answer all these, we have our expert panelists, Dr. Rajiv Kumar, Dr. Darlong, Dr. Payal from Pediatrics, Dr. Nitin Bansal, Dr. Gaurav, Dr. Indu Agarwal, Madam Sukumaran from the nursing educator, and Tanu Daya, who is working in the surgical ICU. So welcome, let's give them a big hand. We will go on the basic assumption कि infection ज़्यादा होती है cancer patients में, and hand hygiene is one of the most important factors when it comes on to prevention of infection. Surya, you and Tanu are the one who spend maximum time with the patient, so I think let me start from the nursing staff itself first.
Yes, sir.
How well are your staff nurses acquainted with the WHO hand hygiene technique?
So good afternoon, everybody. And I would like to thank the entire organizing team for giving me this wonderful opportunity to talk about nurses and hand hygiene. Since sir already has been highlighted.
आवाज ठीक आ रही है मैडम की? Good.
So the maximum time a care worker who spends with the patients directly is fortunately or unfortunately are nurses. So I truly believe we do play a very important role in preventing infection because we directly care patients and when patients are within the hospital, we nurses are the primary care providers for them. So when we practice appropriate hand hygiene, then definitely we make a very big difference. So nurses has to be abreasted, and I proudly say our RGCA nurses are abreasted with the hand hygiene knowledge, and they are practicing the same as well. That is what the number of infection or rate of infection is so less in our hospital. So I would proudly say our nurses are well equipped with the.
Nurses are well acquainted.
Yes, sir.
Tanu, there are some WHO 5 moments of hand wash.
Yes,
hand
sir.
hand hygiene.
Yes, sir.
For the benefit of the audience, can you inform? अरे तुम उधर देखे पूछो कहाँ मुझे देखे जा रही?
Yes, sir.
What are those 5 moments?
There are 5 movements of hand hygiene that are provided by the WHO. They are very critical and evidence-based scenario that are at these time hand hygiene must be performed. First is before touching the patient, before we go to the bedside, before measuring vital signs or just helping the patient to sit comfortably in the bed, hand hygiene must be performed. Second is before clean and aseptic procedure. For example, we are going at the bedside to administer medication or just to handle IV lines. At that time also hand hygiene plays a crucial role. After exposure to body fluids, when there is a risk for body fluid exposure, then also hand hygiene must be performed, such as when we are collecting samples or when we are just finished with ET suctioning or TT suctioning. At that time also, after touching the patient, we just finished with helping the patient with the beddings and making him sit comfortably in the bed. So at that time also we have to perform hand hygiene. And lastly, after touching patient surrounding, when we leave at the bedside, just example, we have touched the bedside rails or just the bedside equipments, at that time it is very crucial that we perform hand hygiene.
So before touching the patient, you do hand hygiene. After touching the patient, you do hand hygiene. If you have been in that environment where there is patient, you do hand hygiene.
Yes,
if
sir.
you have touched the fluid, you do hand hygiene.
Yes, sir.
Are you sure this much hand hygiene is being done in our institution?
Yes, sir. I'm pretty sure this much hand hygiene has been done in our institute.
अरे Dr. Neelam would probably had वो जो हमारी infection control committee है. Does it look into all these issues? How well is the protocol being followed? They do. No. Obviously. So the important thing is your hand hygiene techniques are being observed and you are always under observation. Dr. Nitin, what would you like to say?
So I just wanted to emphasize one point here. The fifth moment which he enumerated, that if you are going into the patient environment, that is the moment for hand hygiene. Most of us, like many senior consultants, they come on rounds. Sometimes they don't even touch a patient, but they don't perform hand hygiene. They will touch the bed railing, they will touch the cardiac table, they will touch the file, obviously. And then they will say, मैंने तो patient छुआ ही नहीं, मेरे को क्यों बोल रहे हो?
Dr. Payal, you agree with what? You agree with what Dr. Nitin says? आप पेशेंट के पास जाते हैं, छूते नहीं हैं और उसके बाद भी हाथ नहीं धोते?
He said very senior doctors.
जितना इन्होंने हाथ धोना बताया है ना, उतना अगर ये हाथ धोएंगे तो पूरा दिन हाथ ही धोती रह जाएंगी. It's nearly impossible to do what she has said. So we should find out some middle path.
कि किसमें करना है, किसमें जरूरी है, कहाँ कितना जरूरी है। जो टेक्निकली आप लिख दीजिए किताब में, कुछ भी होता नहीं है। चाहे चाहे आप 100% कहिए, होता कभी नहीं कि आप जाने से पहले हाथ धोइए, फ्लूइड छूने से पहले हाथ धोइए, फ्लूइड हटाने से पहले हाथ धोइए। इट्स जस्ट इम्पॉसिबल प्रैक्टिकली।
I think I would agree what Dr. Rajiv Kumar has said, but then we need to identify patients where we ought to be very, very cautious in terms
Yes,
of
we have to
hand hygiene.
choose and specify किसमें जरूरी है, किसमें एक्चुअली जरूरी नहीं है.
That is exactly the patient who actually need to be critically isolated. We ought to do that. जैसे हमने सुबह न्यूट्रोपिनिया की बात की, उसमें ज्यादा जरूरी है बजाय इसके कि रूटीन। सो
Sir, infection control में ना there are horizontal interventions. So hand hygiene is a horizontal intervention which has to be done for every patient. I understand with what sir is saying. If everybody follows, then पूरे दिन हाथ ही धोते रह जाएंगे. वो सही बात कह रहे हैं. So that is why 100% hand hygiene compliance is nowhere, sir. But you have to accept that it is not there. So we can have improvement in that. One of the major reasons why it is not 100% is availability of hand rub. It is not there at bedside at all places. So that as an administrative, I mean, if any administrator is seeing, or if a patient is also seeing, then they should demand from the administration that hand rub should be placed at every bedside.
Prashant, note this point that Dr. Nitin has brought out. We should try and ensure that hand rub or hand hygiene solutions are available at bedside on every patient.
No, I'm not talking about ICU, sir.
No, not ICU.
We're not
Outside the
sticking to only
ICU.
ICU, outside.
In the ward also.
Even in OT, sir, have you seen how fast now these young doctors wash up? 30 seconds, 15 seconds. You have a check on that.
No.
बार टोका नहीं कह सकता, but we are seeing.
You see, while I was in GB Pant, hand hygiene is relatively being my area of interest. I will not call it passion because passion creates threat to me. There, what I did was I requested one of the staff nurses in the morning to observe who all wash their hands on entering the OT, because the most important, the last thing that we do is remove our shoes and chappals, and then we come to the OT. And it was observed that quite a large majority of them were not washing hands. And that is more so what she said as a senior person, because he would be the last one to come in and in a hurry. So without washing hands, he would probably come and say, हाँ भाई ठीक हो, touch the patient, अच्छा हम तुम्हारा operation कर देंगे, चिंता नहीं करो and all, without wash of hands. But the best person in terms of hand washing was the staff nurses. Not as a matter of praise or something, but it was a matter of practice. They used to start early from home. हॉस्पिटल आने के बाद पहली चीज जो वो करते थे, नाश्ता करते थे, तो उससे पहले हाथ धोते थे. And once you have washed your hands for breakfast and after breakfast, your again hands get soiled. So obviously parantha khaya to. So not in terms of interest of patient care, but as a matter of routine that they had, hand hygiene was probably the best in the staff nurses in the operation theater, and least among the senior most of the treating consultants. Anyway, now let's move beyond hand hygiene. Tanu, there is something known as a PPE.
Yes, sir.
Everyone now, I think, following COVID, everyone is aware of it. But what is the relevance of PPE when it comes on to infection control?
So PPE, just as hand hygiene, also plays a very crucial role in infection prevention. PPE are the equipments that are used to minimize or reduce the exposure to biological hazards such as viruses, bacteria, and other microorganisms. So components of the PPE are gloves, gowns, masks, and aprons. So these are, we use this to prevent infection. We wear gloves to prevent contamination of hands. We wear gowns and aprons to prevent when there is a risk for blood and body fluids exposure. And we wear masks to prevent inhalation of aerosols and droplets of infectious diseases.
So the components of PPAU has informed us.
Yes, sir.
Dr. Payal and Dr. Nitin, quite often when the patients are discharged from the hospital, are the patient attendants well informed about the hand hygiene procedures that they are supposed to follow and other safety precautions, especially in pediatrics following the bone marrow transplant or stem cells and all?
So I can take this question first. So in pediatrics, we have a protocol for every new patient, sir. It is called as a yellow sheet, which is also called as a welcome sheet. We have called it welcome so that patients don't feel that we are kind of smothering them with so many instructions as they come. So the welcome sheet includes basic hygiene, personal, patient, environmental, food. It contains all of that. They are counseled on the day of admission, new patient. Then when this new patient is getting discharged, the patient is counseled by a nurse who's a senior nurse. And she also has a structured format, which is called as discharge counseling. Again, which has a separate paragraph for hygiene. Then this new patient is also counseled by the doctor. That is primarily by one of our fellows. Again, it's a structured counseling where there is a little Q&A in case they have any questions because of the yellow sheet and the nurse. And in addition, the fellow consolidates or reinforces the hygiene that the patient will have to take care at home. So at least I think in our department, we are trying to counsel our patient on admission and discharge both.
Is it black and white? Is it a printed format?
It is a printed format.
And
sir.
is it patient specific or it is a common format for every patient?
It is patient specific.
Patient
Yes.
specific.
Sir, there are patient education feedback forms, patient education forms which nurses educate the patients, get their signature done, and it is well documented.
This is the protocol that we have in our hospital.
Yes, sir.
So that is what is very important. I knew this information, but I wanted to spread it. That we do take care of patients not only in the hospital, but we also inform them that when they are being discharged, so that they take appropriate precautions when they have to, what they are supposed to take when they are at home. Dr. Payal, are the presentation of pediatric patients different from the adult patients?
Yes, sir. I think in a way, yes, because children, I would say the continuum is from an infant to an adolescent. So definitely the presentations are different. If it is an infant or a child, sometimes they are not able to tell. They may just come with irritability, not eating, not feeding. And then in adolescent, and the type of infections also in an infant and adolescents may actually be different. So definitely, I think children are not mini adults. So the presentation, the expression, both are different.
Dr. Indu, when it comes on to preventive oncology and home care, the patient who are discharged and who have gone home, does the home care team also follow at home and see as to what all precautions they are actually following or not following? Does it follow up the patient for infection purposes also? Or is it only cancer prevention, cancer prevention, cancer prevention?
No, we have a home care team and caregivers counseling is done by them and definitely they are told about all these factors, hand hygiene and all the precautions. If they're febrile, they don't need to go near the patient or they have cough and cold, don't and maintain proper food and hand hygiene. Then vaccination also is very important for the patient as well as the caregivers. So, because in our country, people do understand childhood vaccination, but when it comes to adult vaccination, then it's often like ignored, delayed, or misunderstood also, like HPV vaccination. There are lots of myths associated with it. So, definitely, because when we vaccinate caregivers, we protect the patient also. We like form a protective coat around the like
In the previous lecture, Dr. Nitin has already informed us.
this is all about definitely home care team needs to be needs to go and educate, reinforce the education. Every visit, should be associated with counseling of the caregivers and they should be told about the precautions.
Surya and Tanu, you see, there are always some early signs which the pediatrician and the medical oncologist say are the early signs for infection detection. Are your nursing staff aware? Because patient तो ज़्यादा time तुम्हारे पास रहता है.
Definitely, sir. So since we are long time with the patients, other than any healthcare workers, we should be knowing better about the early warning signs of infection. And everybody must know, and everybody is already knowing it. And that is what when we will be able to recognize it in the early phase, so that we will be able to manage it effectively. If we ignore those signs and symptoms, which is early shown by in case of any type of infection, then that can become a life-threatening situation to the patient. So that is what it has to be early understood. We know the significance of understanding the early signs and symptoms of infection. So we always ensure our nurses are abreasted with the knowledge what is there to be within their daily practice.
To say that your nurses are vigilant enough.
They are vigilant enough also, and I think they are also good enough to understand the signs and symptoms at the early phase.
Okay. And Dr. Payal, does every patient with underlying infection have fever?
No, sir, not necessarily. Eventually, they may have fever, but every presentation may not come with fever. So, infection has to be anticipated depending upon whether patient has a metallurgical malignancy or a solid tumor, what phase the patient is, what kind of therapy the patient has received. So, if the patient is post steroids and comes with loose stools, I will not wait for fever to come, or has a pustule or has cellulitis and fever is yet to come. I think I will not wait for fever to come.
Is the staff in your wards and the ICU is well trained that they will not wait for fever but try to identify the early signs of infection?
Absolutely, sir.
Okay. Now, the other important thing is large majority of the patients have invasive devices. Some have PICC line, some have chemoport, Dr. Darlong, some patients have chest tube, some patients have tracheostomy and all. And these devices again form a very important source of infection. And most often they lie in the ICU or the ward. Surya, I just want to know, are your staff nurses trained about handling of these devices?
So as oncology nurses, we truly believe oncology IV lines specifically because most of our patients will be with onco lines like chemoport or maybe peripherally inserted central catheter. They will be there with the patient for a long period of time, not within the hospital, but fortunately or unfortunately, when they are getting discharged out of the hospital, also they carry the same lines along with them and they come back to us for continuing the treatment. So it is very much important to understand the safe handling of this line. We call it as care and maintenance, except the insertion, because the insertion process is being done by some experts. Most of time it is doctors. So they will be well practicing the insertion guidelines, but that is not good enough to have a infection-free or maybe a safe IV line for any patient. So that is what we play an important role in care and maintenance of the lines at any point of use. And we are abreasted with it. And that is the reason why our patients are been with the onco lines for a long period of time in a safer manner.
Okay, Dr. Darlong. Your patients have a chest tube in situ for long. First of all, I would like to know, do you discharge the patient with chest tube or only discharge them only after removing the chest tube?
We usually, routine cases don't discharge with chest tube, but if we see, it's going to take time, we discharge them with chest tube. It's well informed. We have a special device where the chest tube need not be kept below the heart. It can be kept in the bedside, any level. It's a dry system, which we have present moment. Not like the previous times, like it has to be below the chest. All those factors are taken care. If it is with those system, like you have to keep it below the chest, it's more difficult. But with the dry system we have, we can keep it basically above the chest in the bed, flat, whatever it is. So we do routinely send them, depending on the size. Just one point I need to make in this is that there can be some soakage around it. So what we find is that people start putting bandage after bandage around that soakage site. And they come back with the tube coming out because the weight of that bandage. This is very, very common.
Okay. So you prefer an open dressing or an open wound healing rather than...
We prefer putting a dressing as light as possible.
Okay.
Because if there's soakage, it needs to be changed. It need not be hidden. There will be a nidus for infection.
I think this is a very important message for those who are viewing the discussion online, that please do not be over enthusiastic in putting dressing in and around the chest tube. They can be disastrous. Gaurav, you see, every day I find your people come and trouble us. ये वाला line better है, ये वाला line better है, ये कर लो, वो कर लो. Can you tell us some of the newer devices which your industry has brought in, which will reduce the risk of infection, especially the central line associated bacterial infections?
Sure, sir. there are certain new innovations in this field as well. So we have antibiotic impregnated central lines. We have silver-based catheters which are there. So they are basically intended to have reduction in the early formation of the colonization of the microorganism. So this is one which is a part which comes with the antibiotic impregnated and the silver-based technology of catheters. But if we deep dive onto the clinical evidence and what the panel is also mentioning is there, we have to identify the contributing factor of the infections. And one of the major contributing factor of the infection related to the device associated one is the biofilm formation. That biofilm formation leads to the colonization of the microorganism, which substantially lead to the formation of these kind of infections, could be COTY and CRBSI. There are certain latest innovations in the field which are termed as the novel coating catheters. They are central lines and the Foley's catheter as well, which comes with the novel coating technologies. The novel coating technologies predominantly have biofilm formation technology. They have anti-thrombogenic technologies, which reduce the formation of the fibrin, which leads to clot formation and then subsequently gave the breeding place for the microorganism. And the one which is very much into adoption in the Western part of the world is the surface-bound antimicrobial resistance technology. In this,
at cost to the patient. Na? How costly are they?
so that's what comes. I will refer to the PPT of Dr. Nitin sir only. Their
Okay,
cost.
I agree. Vaccination is better than treatment. I agree that. Okay. And what about the needleless adapters?
So the needleless connectors are basically for the maintenance part. What Dr. Payal and other were mentioning, that maintenance is one thing which we have to be predominantly and the pivotal part of the care of the patient. So for oncology patient and the high risk patient where we have hematological malignancies, where we have myelodysplastic syndromes, so the patient is already in a very high risk of a state. And for them, the closed system is one thing which is very much essential for, and that these needleless connectors plays a very pivotal role onto it, where they restrict to the migration of the microorganism. Because in stopcock, and if we are using an open port, they are an open source. The microorganism could easily migrate and leads to these systemic infections. So when
I think we should now discourage the use of stopcock in the extension
correct,
line.
sir. Because
We quite often find blood over there, we become the nidus for
correct, sir.
infection.
Not only blood, as you already mentioned, when we are going with the extension and the stopcock, कई बार पेशेंट का आपको पता चल जाता है कि लंच में उसने राजमा चावल खाया था कि क्या खाया था. So stabilization of the extension is also one thing
Dr.
which comes into
Payal,
play.
sorry to interrupt you, and Dr. Rajiv Kumar, quite often you have patient जिसमें पिकलाइन डाली जाती है, कीमोपोड डाला जाता है. Do we have specific SOPs available in our institution? उसकी ड्रेसिंग कब करनी है, कैसे करनी है?
Yes, they are available. But unfortunately, सबसे ज़्यादा infection की problem कीमोपोड्स में आती है हमारे यहाँ. Most of the times. And एक time आता है कि इन 2-3 महीनों में बहुत ज़्यादा infection हो रहा है. Then it's probably the handling of the ports and handling of these devices which matters. So during surgery, everything is fine. And after 1 or 2 cycles of chemotherapy, it gets infected. कभी block हो गया, कभी back flow नहीं आ रहा, कभी forward flow नहीं आ रहा है. And to the extent, one of the patient developed infective endocarditis because of this. I think Nitin remembers that.
So PIC line, all central line associated infections can have disastrous consequences also. We ought to take them seriously. आपके उसमें भी ऐसा होता है, Dr. Payal?
Sir, I think lesser in pediatrics. Although in children we expect, like, because children may throw something or they may pull it out, but I think we don't see so many class B, particularly by the definition, as sir specified. It is always there, but not as much. I think our staff does a great job in the ward, in the daycare and downstairs also.
I think the parents are much more careful for the child rather than they are careful. An adult is careful about himself. That is probably one of the reasons the infection goes less in the children. Does every PIC line or an invasive device like an intercostal drain or a tracheostomy need a prophylactic antibiotic? Nitin?
No, sir, definitely not. No, there is no indication where a prophylactic antibiotic is required for any device which is in, like in situ for whatever reason.
ओके, आई थिंक घंटी कई बार बज गई है, तो लेट मी have the last word from the experts, and then I will conclude before Prashant decides to throw me out. डॉक्टर डारलोंग, डॉक्टर राजीव कुमार, कुछ आखिरी संदेश जनता के लिए
हाँ,
इन्फेक्शन के बारे में.
yeah, infection, hand wash is basically the first thing. The first and last cheapest भी है, and it's easily possible.
Dr. Payal, you agree with Dr.
Yes, sir. I think
Hand
very
hygiene.
important is, sir, reinforcement of whatever guidelines, SOPs we are making. I think one time is not important, whether it is for the staff, doctors, or patients, it has to be reinforced at every contact. That's all.
Okay. Anything else, Dr. Indu, Dr. Nitin?
Because generally on colleges, they're more concerned about the patients, but we deal with the attendants. So patients को साथ साथ attendants को भी हमें कि आपको भी अपने infections prevent करने हैं, so that you don't carry infections at home, you don't transmit them to the patients. So attendants की health should be taken care of also.
So
वो
that
भी
means the
consult
moment
करना
the
चाहिए.
attendant gets infection, there should be another attendant to take over. है ना?
So like मतलब they should be consulted properly, they should take care of their own health as far as हर चीज के लिए vaccination है तो febrile है, they should not go near the patient, hand hygiene कैसे करना है, सब कुछ मतलब a proper counseling of the attendants is required.
Actually, what happens? Cleanliness is a संस्कार. अगर आपने बचपन से सीखा है साफ रहना और साफ रखना, you will remain clean. It's the duty of the parents. और सर वो आता जब तक शुरू से आपने बता
सर आज के टाइम में प्रॉब्लम ये है, लोगों के पास समय का अभाव है.
संस्कार देने की तो परेशानी है
People
सर.
prefer to hire a staff nurse or a private nurse rather than be able to attend. So it is we are passing through a very critical phase when it comes on to healthcare providers. Now let me conclude. Cancer patients are prone to infections, we all agree. They are preventable with all the steps suggested by the experts. Healthcare providers have a very crucial role to play by ensuring safe practices, identifying early signs, initiate quick interventions. Hand hygiene, hand hygiene, hand hygiene, bath, protective gloves, take care of your mouth, oral. Brush, don't share your towels, brush, spoons, glass, etc. Device care, we have already discussed. We already have insertion bundle and maintenance bundle protocols which are available. Thanks to Gaurav, we have the needleless connectors who are available, and you are seeing the various devices. Hand hygiene, we have all talked. We have also discussed about the 5 moments of hand hygiene and also the impractical suggestions made by the WHO. I only wish if Gabbar or near relative had a cancer, he would not have said, मुझे हाथ दे दे, वो कहता मुझे हाथ की मैल दे दे.
पैसा हाथ का मैल होता है.
पैसा भी होता है. पैसा भी चलेगा, हैंड हाइजीन की मैल भी चलेगी, मरीज ठीक होना चाहिए. And the important thing is, you have a patient has a very important responsibility because he shifts from a passive recipient to a vigilant observer. अपना ख्याल आपको खुद ही रखना पड़ता है. You have to observe every point of insertion, central lines and all. And so ये देखना बेटा ये लाल तो नहीं लग रही, मेरे को गरम गरम लग रही है, ऐसा तो नहीं है. Patient is the first informant rather than the staff nurse and the doctor. Avoid large crowds. भीड़ में नहीं जाना. Prefer to wear a mask, wear it properly, stay away from dust, avoid pets and domestic animals. खाने में wash the fruit well, cook it well, avoid buffets. ये नहीं कि लंगर में चले गए. धार्मिक हमारे यहाँ काफी वो है. We ought to be careful. Have proper refrigeration during summers. Don't eat expired food products. If you have any of these early signs, seek medical help. Do a daily body check, self check, strict oral hygiene, isolation, be device awareness, because my life is my priority. That is the figure that is important, and it is my responsibility. So when it comes on to infection prevention, hand hygiene, risk identification, device management, hospital protocols, home care, caregiver challenges, which we ought to look into. We ought to break the chain of infection before it breaks the patient. This is a conclusion slide which sums up everything. And in the morning, we had this pledge, and I am sure we will again pledge that we will do proper care of our patients, make RGCI a happier place with minimal infections, and do no harm. I think thank you very much for your patient hearing. And we should have a group photo and proceed, na? आओ भाई आओ. हाँ भाई प्रशांत, फोटो जल्दी आ जा. लेट हो गया, भाई ले लेगा यार मेरे को. Yeah.
That was a very informative talk. Thank you so much. Let us thank our moderators and our panelists with a round of applause. For our next panel discussion, let perioperative antibiotics and its role in oncology settings. Let us welcome Dr. Neeraj Tyagi. Dr. Neeraj Tyagi. Dr. Neeraj Tyagi, Senior Consultant, Critical Care Medicine, Ganga Ram Hospital. I request Dr. Tyagi to invite panelists for the session onto the stage.
Yeah, I would do that honors. First, I would like to invite Dr. Amitabh Singh. He's our uro-onco surgeon at RGCI. Dr. Praveen. Dr. Praveen is a consultant at Critical Care Medicine and Surgical ICU at Rajiv Gandhi. Dr. Saurabh is on the way. He has just started the lift. Dr. Saurabh, please, sorry. Dr. Saurabh Taneja, another wonderful good friend and colleague of ours. He's a senior consultant at Sir Gangaram Hospital, Institute of Critical Care Medicine. Neeraj sir, take over.
Thank you. So I think we had a fantabulous panel discussion, and it was really the way you guys were connecting to each other was really remarkable. But this one is I can say more of philosophical discussion. What we know, what we do, what we ought to be doing, and why we are not able to do that. This is something we're going to discuss in next probably 20 minutes. So what we understand by perioperative antibiotics, I will restrict that to antibiotic prophylaxis, because the concept as such about perioperative antibiotics is a misnomer. Either we give a prophylactic antibiotic, or once that prophylactic period is over, we need to treat if a new infection has come up. So in next probably few minutes, that's what we'll try to do. So probably what we understand that surgical site infections are the leading cause. We heard all the panelists, and we can see the data usually comes from US when we talk about, and you can see the humongous number there, almost 1.5 lakh patients annually, and they end up spending 3.5 billion. So there is a cost angle to this as well. What we're going to have is going to structure the entire 20 minutes like first the general principles of perioperative care, and we'll try to see how we are able to replicate them in oncology patient. sort of a 5 minutes debate and then targeted questions. So when we talk about surgical site infections, we understand the answer is pre-operative antibiotic dose or prophylaxis. And when we talk about AMR nowadays, if you look at the hospital consumption of antibiotics, almost 15% of all antibiotics are given in this setting. Surgical antibiotic prophylaxis is probably the best way to prevent it. And we know what if we do not have it, what can happen. But there is a duality. So when we talk about it's a standard of care for surgical site infection prevention, but when the AMR is going up, this 15% needs to be probably organism-based and patient-based. So it cannot be a substantial therapy. And what we need to understand here is the problem in India. We have lots and lots of CRE. So if we start to give prophylaxis, which is too broad spectrum, probably you're going to increase. We have very clearly laid guidelines and we talk about the recommendations. They are there since 2013 and probably we are all aware of that. So first thing, my first question is, when we talk about evidence for perioperative prophylaxis, what are the pitfalls? The evidence for it and what's the pitfall?
Hello. First of all, thank you for inviting me here. I just reached in time. And the first question, evidence of perioperative prophylaxis. So we have to be very careful. Now we are talking about oncology patients. So oncology patients are very prone to infections because of the immunocompromised status, because some are malnourished, some might have undergone chemotherapy or radiation therapy. So we have to give a therapy which is reaching the blood levels at the same time as we give our surgical incisions. So these are the subset of patients where is definitive, it is a role of a prophylactic antibiotic therapy. It has a definitive role and all the evidences mostly are from American, IDSA, SHEA, AHSP. They are all pointing out that perioperative prophylaxis has definitely a role. Now, which antibiotic to give? I mean, first or second generation cephalosporins are the choice throughout. The pitfalls of a prolonged prophylaxis, as sir definitely said, I mean, prolonged prophylaxis is nothing. It is either a prophylactic dose or if you're moving, it is evidence is still up to 24 hours at least maximum. And if you're moving above 24 hours, it is mostly, if you suspect infection, it's mostly empiric therapy for which you need to give send cultures and suspect something which is causing a prolonged infection. So when we say if we give a prolonged prophylaxis, the chances of having resistant organisms, all the VREs, ESBL, Clostridium difficile infections, resistant fungal infections, they all increase. So we have to be very careful what is the antibiotic therapy and for what surgery we are giving and for what, if it is a prolonged duration therapy, you might have to repeat a dose. So the evidence is definitely in favor of perioperative prophylaxis, but we should not give a prolonged prophylaxis more than 24 hours, sir.
Excellent. So second, again, the same thing, if you can carry forward, when we talk about PK/PD alterations in surgical oncology, and now you pointed out that we need to cut them short. So one thing is what you rightly said, probably within 60 minutes of surgery, we need to give it. Anything else that you'd like to, any one of you can take this question. Anything else that can help us in reducing the AMR burden?
So we should be aware of our PK/PD principles of all the antibiotics that we are giving. And then we should all be aware of what is a surgery that is prolonged, if it's a prolonged surgery, or if the high fluid shifts are there, if the chance of the volume distribution is increased in some part of surgeries, if high transfusions are there. So we need to, if the patients are hypoalbunic, the protein binding should also be taken into account. So all of these should be taken into account when we prescribe a broad spectrum antibiotic prophylaxis. So when we talk about a broad spectrum, it doesn't become stewardship. So we should keep it till 24 hours. Again, repeating the same point. We should not continue it beyond 24 hours until we want to treat some new infection in that same patient by which it becomes an empiric therapy. Now, if there are some surgeries which is, we give second generation cephalosporin Jolie or first generation, but depending on the subset of patients, we might have to choose another antibiotic also, like in HIPEC surgery or surgery involving the GI tract manipulations. And as far as PKD principles, if the volume of distribution is high, we might have to give a higher loading dose in these patients. If the prolonged surgery is there, we might have to give a second dose because if the 2 half-lives of the drug has been crossed, we have to repeat the dose. So we have to keep that into account as well.
So excellent. So as he is rightly pointing out, if you're choosing the cephalosporin, probably giving it 60 minutes before incision is fine. But if you are going for vancomycin, we have to understand it has to be started at least 2 hours before. And the same principle applies for fluoroquinones as well. So not every antibiotic should be given within 30 to 60 minutes. There are going to be few which needs to be given slightly earlier. And the idea is same that during surgery, you need to have the peak concentration around it. And of course, you need to know the half-life of that drug that you are giving, so that if the surgery is going slightly longer, you need to give the repeat dose. So this is the antibiotic stewardship lens that we talk about so much. The evidence is very clear. The cefazolin, probably what we are looking to target is the organisms which are there on the skin. We do not want to kill all the bacteria which are there on the gut, which are good bacteria. So prophylaxis is only about trying to prevent those skin commensals which post-operatively may spillage and turn into infection. Duration should be kept less than 24 hours. And of course, the prolonged prophylaxis risks, Dr. Saurabh is nicely elucidated. When you talk about PKPD lens, yes, of course, as intensivists, as surgeons, we need to understand what we are trying to give, and of course, what kind of surgery we are having. So quickly we go to this ITSA 2013 guideline, and this is where I want your attention. So this is the most exhaustive one, and they talk about peri-operative or pre-operative prophylaxis across classes. And when I was going through this, I realized a very smart thing. Only once, one subset of onco-surgery patient they speak about in isolation. That means what they recommended probably a decade back, that rest of the surgeries, they need to be considered like any other surgery. The oncosurgical patient in terms of surgical prophylaxis is not different as compared to other surgeries. So clean contaminated cancer surgeries for head and neck, that's the only place they say you need to have a combination, because you need to take care of the oral flora, which is there, which is far more diverse as compared to the skin flora. You're looking at the soft tissue reconstructions, and in situations you are looking at the bony constructions as well. So that's the only subset. So now I'll go to the onco surgeon. So when you talk about, we have this data from a decade back, and has anything changed in last 10 years? When we talk about prophylaxis in hematological patient, oncology patient who is undergoing some surgery or a solid tumor surgery per se.
So I am uro-oncologist, but I am still practicing immunotherapy and targeted therapy. So I am agreeing almost every aspect of this thing. But in hematological malignancies, especially, we need to see if patient is neutropenic or not. If he is severe neutropenic, that means absolute neutrophil counts are less than 500. Then probably we can extend our prophylaxis up to 3 days, 72 hours. And after that, we can give just targeted antibiotic prophylaxis or empirical treatment. About immunotherapy and targeted therapy, we need not to be we need not to change our protocol of all these antibiotics, even if we are giving immunotherapy or targeted therapy, because although there are concerns that the neutrophil count can go down with the targeted therapy, there can be immune-related side effect because of the immunotherapy, but still, the concept of immunotherapy, they are antibiotics, they are still same, whether you are using immunotherapy or targeted therapy.
Excellent. Because I think neurosurgery was, apart from head and neck surgery, at point of time, they were using extended prophylaxis for more than 72 hours. Yes. But I think in last 5 years, you guys have also come down a lot. And what he's rightly pointed out, so if you are giving antibiotics, broad spectrum antibiotics, and you are using immunotherapy, the chances of your antibiotics reducing success of immunotherapy is there, because they gonna kill the gut microbiota. But because somebody is on immunotherapy does not mean that you have to unnecessarily have broad spectrum antibiotics. So the opposite of that is not true. And this is what probably is spoken about. ANC less than 500 is what you need to consider. And if you expect that neutrophil count to stay for prolonged duration, probably that's the time we can have slightly extended duration. Hematological versus solid tumor, absolutely no change. What you do for any other patient, the things remain same. Hematological, then you have to do the risk stratification. Immunotherapy, we have already spoken about, and same are the considerations about gut microbiota. So let's move here. This is again something which started in 2013. And if you see, this is what they were talking about in 2013, the same guideline. They're very much not broad spectrum antibiotic. They are targeted antibiotic looking at the organism which is most prevalent. This is what has happened in 2015. And now you will see appearance of ertapenem as well. All right. So probably what they're also realizing that the gut microbiota is changing, or in certain situations we have prevalence of CRE, or in certain situations we have a high organism burden. So let's go now. My first question is should oncology patients routinely receive extended postoperative antibiotic prophylaxis beyond 24 hours? And if not, what is the domain?
So, I think every patient should get only for 24 hours, but there are certain exceptions. So we need to see our antibiogram and the resistance pattern also. So if the resistance pattern is more than like 20 to 30% extended beta, this spectrum, this ASBL sort of thing, and if the surgery is kind of HIPEC surgery, hepatopancreatic biliary surgery, where the duration is very prolonged, chances of immunosuppression is very high, then, and if the chances of Klebsiella, carbapenem, this sensitive Klebsiella is positive, culture is positive, then probably we can go with the carbapenems. But again, we need to be careful with the dosing of carbapenem. And but the duration, I think it's the same. 24-hour prophylaxis is only just.
I understand uro-onco surgery, they're not too long procedures except robotic ones. But
so except orthotopic neobladder, I think every surgery is just like 2 to 3 hours. Only neobladder goes up to like 5 to 6 hours. And in that case, we just repeat our antibiotic depending on their whole half-life. That's it, sir.
Excellent. And anything else apart from that? For example, there are certain surgeries which require lots and lots of blood products. Is there a consideration about that as well?
So when we are doing open RPLND for post-chemotherapy residual masses or retroperitoneal tumor in any case, then sometimes the blood loss can go up to more than 2 liters also. Then in that case, yes, we ask for.
So excellent. So this is another take-home message. It's not the kind of surgery. For example, if you have a surgery which has gone off for more than 4 hours, in that situation, we may have to continue it for 24 hours. Unexpected blood loss, usually more than 1.5 liters. Somebody who's needing more than 3 pegged RBCs. We understand nowadays when the RBCs are irradiated and all, but that blood loss also is a consideration apart from duration of surgery. So these are the situations probably where 24-hour prophylaxis is warranted. Otherwise, less than 24 hours is, and this is something which hasn't changed. Whatever meta-analysis or whatever evidences we have, they say 24 hours applies even in most neutropenic patient, except when the ANC has gone down below 500 and the duration is supposedly prolonged. So let's see. This is something which we all talk about. Are carbapenems justified? When we talk about in our scenario. What is the question? So when we talk about, like, for example, in our institute, if you see Saurabh, there 80% of the patients, they are having CRE somewhere or other. Patients who come from communities getting surgery. So are we over-interpreting our flora? Or is carbapenem, because we have seen so many times that the antibiotic prophylaxis has gone on to include carbapenem. So is it justified or I mean, what are the concerns?
So on one side, the chances of promoting antibiotic resistance is high. On the other side, the individual patient's life is at stake. So it is a very thin line of balance. And like in our institute or in most tertiary care hospitals in Delhi NCR, there are higher numbers of ESBL positive or CRE. So we have to choose a antibiotic which we are giving as prophylactic. I think more from first and second or second generation to an individual choice is the right way forward, at least in our settings. We have to take care what is the patient profile, whether it is a totally clean surgery or a clean contaminated surgery. Is the patient having any admission in the previous few days or few weeks or received antibiotics? And then we should choose antibiotics, because we might have to go for carbapenems in many patients in tertiary care hospitals, to be honest, because more and more ESBLs and more CREs are there. Although the WHO and all the guidelines of 2013, but at that time there was no such resistance patterns documented. I think we need to a new study for this or new guidelines for this, because individual patient's life is also at stake because of the resistance patterns.
So again, it's the same dogma. We start more or more of carbapenem as prophylaxis. We gonna give rise to more and more NDMs, not KPCs in India, but definitely NDMs and OXA 48 likes. So what the world literature so far is suggesting, okay, we do this screening, we look at if they are ESBLL, avoid meropenem, go for ertapenem. It's less inducer. It takes care of most of the things. And of course, we can have just one dose kind of a thing. So the reconciliation is really important. 72 hours timeout is definitely feasible. De-escalation can be based on microbiology and all those data. And when we talk about risk stratification, so can you talk about what kind of risk stratification, if at all, you use as a surgeon or as a physician? Is it ITSA or MSCC? Or what kind of practice should we follow in this broad subset of patients?
So, sir, I think the hemato-oncologist protocol, because I don't practice hemato-oncology, but I think the level of neutropenia is very important to look. But ultimately, now we need to see that we are treating the patient. So the guideline and clinician decision can vary from patient to patient. So because ultimately we want to save the life of the patient. So if the chance of infection is very high in a neutropenic patient, like suppose immunocompromised, going for transplant, anything, then probably we can tailor up this thing and we can just modify it every third day, so 72 hours. So we can have a discussion, then we can change it. So there is always a option of changing the antibiotic, but at least we can't just wait for sitting at the corner of the bed and just following the guideline. So I think patient is very important.
Excellent. So probably looking at antibiotics every 72 hours and have a multidisciplinary kind of, discussion, what is happening. So the idea should be that now we are ending prophylaxis and we are starting empirical antibiotics that are going to cover a new subset of infection that has come up if your patient becomes unstable 24 hours, 48 hours, or 72 hours post-infection. So this is the best evidence, as I said, head and neck surgeries, and this is the protocol which most of the time now we believe should be followed for these kind of surgeries. Saurabh, I'll come to you. So suppose I want to evaluate my patient at 72 hours and I want to stop this prophylaxis in a head and neck patient. So apart from TLCs, neutrophils, are there any biomarkers or anything else that can give objectivity to our decisions?
Sir, inflammatory biomarkers and biomarkers like procalcitonin definitely play a role, and we can look at the serial values if the trend is declining. But along with them, we should give enough emphasis on the clinical situation of the patient, and if they collaborate and they corroborate, then we can step down on the antibiotics or stop them altogether. But I would like to highlight one thing 2-3 slides back, and you had written meropenem 2 grams 8 hourly. I would like to emphasize that whatever antibiotic prophylaxis or for a empiric you are giving, give it at a proper dose. There is no role of underdosing any antibiotic, even if you're giving for 72 hours and stopping that. Sorry to say that, right?
No, this is absolutely valid point. I think we started with that. When you talk about dosing and timing, that's the most important thing. I mean, PKBD is about the same thing. If you have a patient who is 50 kgs, but now is weighing 60 kgs, you do not go by absolute body weight. You need to look at volume of distribution of that drug and probably give 30% extra or 50% extra, depending on what situation you are dealing with. And again, look at what is happening to the creatine clearance. In inflammation, your creatine clearance goes up. So you have a creatine of 1, but patient is producing 7,500 ml of urine. So probably your kidney is going to excrete more of the drug. So you have to overdose, not underdose drug in these situations. That's the most mute point we need to understand. So finally, is a neutropenic patient post-cytoreductive surgery? When do you stop perioperative antibiotics and switch to empirical fever treatment? This is what we need to understand. Like when we think it is not no more prophylaxis, now we are looking at a de novo infection which has come up.
I think if he's not severe neutropenic, then I think only 24-hour perioperative antibiotic is enough. And then we can rely on the clinical symptom. If he's having fever, send the culture sensitivity, 2 samples at least from central line, peripheral line. And then we can start the empirical treatment, antibiotics.
As an intensivist, any other perspective you want to give, Saurabh, or anything else?
We need to differentiate when we are giving prophylaxis and when we are doing empiric therapy. I mean, for each and every patient. And I'm perioperative, I agree, we should stop 24 hours. But if we need to continue, we will not say it's a prophylactic therapy. We need to send, it's a personal question as well. In these neutropenic patients, do we send cultures before they plan for surgery? Because, I mean, just to see the colonization, do we send it in every patient? Actually, I wanted to discuss, to be honest.
Okay, we'll come to that for the final one. But second one, I mean, do you dose differently? We have discussed it a lot, but again, if one point you want to emphasize, what will be that one point about beta-lactam and vancomycin dosages? What we are doing right now in our situations?
So vancomycin, we need to give a higher loading dose, so to around 25 to 30 ml per kg. Initially used to measure the trough levels, but now we should measure the AUC MAC levels, and it should be around 400 to 600. And for beta lactams, dose adequately, give it in a prolonged infusion, and time it so much so that when you give the incision, it is at the good levels in the blood. So
this is another really important point. I understand there was an article last year in JAMA which said prolonged infusion of meropenem does not change the kinetics. But that was a very controlled study on a very stable subset of patients. They were not sick patients. So probably if somebody is not sick, giving it over 30 minutes, over 2 hours will not matter. But patients who are really sick, patients who are critically ill, please ignore that JAMA paper. Read it if you want to read it in details. For sick patients, it still holds true that you should give all kind of beta-lactam antibiotics, including carbapenems, by infusion. You need to know the infusion half-life. For example, meropenem is stable for 2 hours, while doropenem is stable for 3 hours. So the longest possible duration for which that molecule is stable, you have to use infusion for that duration in order to achieve the best kind of kill kinetics for these molecules. Again, the same conundrum. So now we can discuss. So just put the critical occupants and then probably we'll have 2-3 minutes. What do you want to discuss? Yeah.
I just wanted, so suppose we say that, we say that neutropenic patient is there, and then we want to continue the prophylactic therapy for a long duration of time, maybe 2-3 days or maybe even longer, and then we change the name from prophylactic to empiric therapy, and which is often the case in our patients. So do we, and they say that you should always send a culture before you start empiric therapy. So do we send cultures because we don't know when we'll changing from prophylactic to empiric therapy? Do we send cultures before to look at the colonization just before the surgery?
Excellent. So what the current evidence is, if we have a high burden of ESBLs or CREs, it is mandated if we are going for at least hollow organ involvement in surgery, we need to do a rectal swab. We need to do a skin swab in Western world. We have to look for MRSA and we have to look for CRE. That will give me the colonization burden on that patient. And that's where it is really important to stop surgical prophylaxis at 24 hours. Because surgical prophylaxis was given to prevent any infection comes from skin, not from that CRE. Same way, if the CRE is high and we are giving carbapenem, the same thing has to stop at 24 hours or maximum 72 hours, depending on the surgical duration. If my patient stays sick at 72 hours, now is the time to think whether the surgical prophylaxis went wrong or it's a new set of infection which is coming up. This set of patients are as much prone to viral and fungal infections. If you have ANC of less than 500, that blindly upstepping antibiotics is not going to help them. So this is the differentiation one needs to make at every 24 hours time when we are talking about prolonged prophylaxis. And this is what they say, 20 to 30% probably consider ertapenem, not meropenem. Meropenem consider only and only if you have a situation where ertapenem is unlikely to work, and then we can go up to other kind of antibiotics. So again, a beautiful paper, and I want your attention to the second slide. If you see, this is what all the panelists have been highlighting. Timing and dose matters. If you screw even in one of them, a beautiful paper from JAMA, which came this year, it says you're going to have a worsening of surgical site infection. So you need to dose it well and you need to time it well. Rest, nothing matters. And when you do that, probably this is where if you can see the association of surgical site infection and the factors, you will not see the duration of antibiotics. It is only the host factor, dosing and timing of that antibiotic which matters the most. And probably that's how we can conclude. So your remarks, and then we can take it forward.
I think, sir, in most of the surgeries, 24-hour prophylaxis is enough, perioperative prophylaxis. You just stop the antibiotic, you follow your patient. If he's showing any sign of clinical like worsening, like fever, increasing counts or whatever, then you can start empirical antibiotic. So in uro-oncology patient, most of the patient, they are not neutropenic because even after chemotherapy, like suppose bladder cancer patient, all of them mostly they get NSCT. But still we don't see neutropenia because we operate them after 3 weeks of last dose of chemotherapy. So we don't usually face this problem, but we are just trying to modify the protocol in our hospital also just to limit the use of antibiotic.
Excellent. And do you, your comments about whether you should keep antibiotics on till all the drains are out? Does that ever make sense?
So now there are two scenarios actually which we are facing right now in uro-oncology, especially which I can tell you, especially in orthotopic neobladder, and one is robotic inguinal block dissection. So because of the lymphoria, these patients, they can be on the drain for at least sometimes even more than 1 month also. So what happens? They get surgical site infection. So in those cases, what we do, sometimes we just keep on continuing antibiotic, but we have seen that it doesn't help. You just stop antibiotic. If there is any cellulitis, you send the culture of drain fluid and then you restart the antibiotic according to the culture. So right now I am practicing this protocol only.
Excellent, excellent. Your thoughts?
As a last thought, I would say know the flora and fauna of your ICU or your hospital. Know your surgery and the patient. Know your PKPD of antibiotics and then select it. That is my last thought, sir.
Excellent. So probably there are certain high-risk situations. Repeatedly, the literature is saying head and neck surgeries where we need reconstruction timings go up. Contaminated dirty wounds is a no-brainer. Similarly, high-risk patients, we all understand we need to probably extend them. Immunosuppression, I think panelists, they have highlighted how you quantify and what is known as immunosuppression. Not everybody is having a TLC of 2000 is immunosuppressed. It's not. Look at the ANC and the depth of ANC, and that's it. Extensive procedures, yes, yeah. Timing beats the duration. Probably a perfectly timed cefazolin or whatever is there in the skin flora will obviously overcome whatever we can achieve by 72 hours. Dose for altered physiology is definitely, if you have the possibility of doing a drug dose monitoring or therapeutic monitoring, please do that. Extended infusions are must. Probably what we are also looking at is a situation in which evidence does not endorse routine use of vancomycin for like any kind of prophylaxis, except if you are MRSA. One very important point, whenever you are using vancomycin, we try to probably compromise on gram-positive cover. Vancomycin is a very poor drug for methicillin-sensitive Staph aureus. In fact, if you see certain studies, it has increased mortality because of Staph aureus, which was methicillin sensitive. So please do not compromise on MSSA coverage just because we are using vancomycin. That's really important. Golden rule, I think probably most of us are now moving away from the concept. Just because the drains are in, we need to continue surgical prophylaxis or antibiotics. Let's not do that. The golden hour is most important in perioperative surgical prophylaxis, and redosing versus extension, you need to know the amount of surgery. So what's to guide in our environment when we talk about CRE? Again, 2023 ECMID, they say the same thing. Do rectal screening and target for fluoroquine resistance enterobacteriaceae before we are doing for any kind of procedure. Screening is also important for ESBL producing enterobacterials. And you see two kind of words. ERAS protocol is really well done in Europe. So they do not go for oral decontamination of gut. While in if you read papers from US, they do recommend doing oral antibiotics. But if you combine the literature or whatever meta-analysis is there again the answer is the preparation of gut doesn't matter much. If you have CRE, use a CRE coverage prophylaxis and stop it there rather than doing all these things and gut handling and all. So probably this is where we can end, and these are the references. Thanks to Prashant, I had to go through quite a lot of new papers which were there, which I was blindsided as well. So thank you, and thank you all the attendees. It's good to see so many people attending before lunch and with intent. Thank you so much. And great panelists, and thank you so much. Thank you. Any questions from the crowd? If we have time.
You see, in our institution, when it comes out the antibiotic therapy, some of them give in the ward and they come. Some of them wanted to be given in the OT. You said 60 minutes. So how can we bring about this uniformity in the institution? Like I think Dr. Rawal cases, they already get the antibiotic from the ward and come.
So I write down that because now personally I prefer Magnixport, the third generation cephalosporin, and I write it down that should be given 1 hour before the surgery.
Yes.
So now what happens, because there is a lot of time between the shifting of the patient from ward to OT, and that is not under my control. So this is a very practical problem. Sometimes because of the PAC issues and all these things shifting.
No, because quite a few of them want soon after induction, because after induction it takes her at least half an hour, 40 minutes,
At least 1 hour.
cleaning, dreaming and all. So what would you suggest?
Excellent. This is exactly what we are doing from ICU. I won't be commenting about what, because I'm not the right person to comment about that. If somebody is going from ICU, we understand that patient should be already immediately taken in, but we understand doesn't happen. The cleaning, draping, all those things takes an hour. So what the nurse does, during handover, a vial is sent from the ICU. And as soon as they enter, the IV access is there, it's given, and then it definitely ensures that it's not a longish period of time way before the surgical procedure is about to start. So this is one change we have brought in last, you can say, 3 years.
Prashant, I think we should discuss it out with Dr. Neelam and try to devise a uniform antibiotic administration policy. Because some give in ward, some give in OT and all that.
Sir, it is not, with humble submission, it is not about only when to give the antibiotic. It is a choice of antibiotic also. Choice of antibiotic. Look, without a blame game on naming everyone, like it is like sometimes we receive a patient who has been given ceftazidime in avibactam in the OT, and when it comes to us, it is Magnex or Vitran. So this is, yeah, it happens very, very commonly.
I think we try to identify such issues in our setup and try to streamline the antibiotic administration.
Definitely, sir.
Yeah, that I think would be better.
What we feel is our clinicians, we are responsible for the next gen. Or maybe 10 days down the line, if we fall ill, we go to a hospital. Or the way we live in an era where there are no antibiotics left for us.
No, the point is, our discussion should not end in the room today.
Definitely, sir.
We try to identify some key lacunae which we have identified in our system and try to sort it out at the level of the administration, at the level of the surgeons, at the level of the microbiologist. Maybe we can discuss with the CEO and say that we should devise a uniform antibiotic therapy, especially in the perioperative period.
Sure, sir. Sure, sir.
Because that is what I find, that even if it is to be given 1 hour before, each one has his own preferences of antibiotic rather than the recommendations of the microbiologist. So we just look into it.
Totally agree with you, sir.
Any
Yeah.
questions from the audience? Dr. Nitesh, Nikhil? I think सब
Everyone is hungry.
हाँ, मैं वही कहने लगा था, आपने बोला everyone is hungry, मैं बोलने लगा था सबको भूख लगी है, बात तो वही है।
जो सबसे बड़ी चीज जो आपने हाईलाइट की यही है कि हमको आपस में बात करनी जरूरी है। पहले आपस में बात करें, फिर एडमिनिस्ट्रेशन के पास जाएं। सेम जैसे आपने एंटीबायोटिक चॉइसेस डिफरेंट है, तो 60 मिनट्स अगर मैं कर दिया और किसी को vancomycin देना ही देना है, it will make no sense then.
Yes,
So
that-
talk to each other, define the antibiotics, and for each one of them define the time, and probably that's the way to go about it.
Sure.
Thank you so much and congratulations to the entire organization.
Thank you. Thanks, sir. Pleasure having you, sir. Yeah. Can we assemble for a group photo, please, sir?
All of you proceed for lunch जब तक हम फोटो खिंचवाते हैं. For the residents now, because there was lot of rush, we have requested them. Now we have 2 rows. उनको बोल देना दोनों खाने खोल देगा यहाँ पे. अरे कहाँ गए भाई गौरव, मेरे साथ फोटो खिंचवानी है, अकेले खिंचवानी, इधर आ जाए ये माइक पकड़। रुक एक सेकंड।
खिंच गई है सर।
एक फोटो तो लेक्चर वाली लगनी चाहिए ना।
सर काफी चीजें इम्पोर्टेंट हो जाती है मतलब
कम कितनी दीवार
जमा आपको सर में बात करें
खाना खाया वो शायद नाराज तो नहीं हूँ
सर आप इसकी हेल्प करोगे तो फिर और और कुछ चलो कर दिए ना सर एक हमारी कॉन्फ्रेंस के वेबिनार है सर तो जैसा
Nitesh? Yeah. The senior consultant at NCC at Rajiv Gandhi itself.
हेलो। तो वॉइस पता है वो वैसे ही रहता है सर हमेशा। एड्रेनल जो है ना वो कॉर्टिसोल अपने चरम सीमा पे हमेशा रहते ही हैं। ठीक है सर। नितेश क्या हाल है, लॉन्ग टाइम। पोस्ट लंच सेशन है। गुड आफ्टरनून एवरीवन। आई वुड रिक्वेस्ट एवरीबडी टू कम इन फ्रंट, नहीं तो मैं पीछे आके सवाल पूछूंगा तो वो ज्यादा अच्छा नहीं लगेगा, खाम खा में कुरेदे जाएंगे लोग। ठीक है। सो विदाउट वेस्टिंग मच टाइम, टॉपिक बहुत इंटरेस्टिंग है ना। हाँ, पोस्ट लंच सेशन के लिए बहुत अच्छा है। खाने में किसी ने कम प्रोटीन ली हो तो हम दे देंगे। ठीक है। तो टॉपिक है एल्ब्यूमिन इन सेप्सिस। फाइन। और आई थिंक मेरी जेआरशिप से 2004 से लेके 2024 तक हम इस पे ट्रायल ही छाप रहे हैं अब तक। फाइन। एल्बॉयस से शुरू हुए थे, 23-24 में अराइज आया। ठीक है। 20 साल से ट्रायल पे ट्रायल, ट्रायल पे ट्रायल, और कहानी वहीं की वहीं। ठीक है। सो 20 मिनट में 20 सवाल, चार हमारे महान, जो खिलाड़ी तो नहीं कह सकते, विद्वान, तो एक्सपर्ट पैनल डिस्कशन बोला गया है। जो ये बोलेंगे वही सच है, और उसके अलावा, सच के अलावा कुछ नहीं बोलेंगे ये लोग। ठीक है। द स्टोरी स्टार्टेड इन 2004। ठीक है। जब हम बहुत ही छोटे थे, आई थिंक हमारे साथ के एक दो लोग होंगे और सर हमें पढ़ाते होंगे, तो एल्बियोस आया था उस टाइम पे, या सेफ आया था। ठीक। सो लेट अस सी, डिस्पाइट फिजियोलॉजिकल रैशनल and two major decades with trials like SAFE, Albios and ARISE. हम क्यों फेल हो गए? Why are we consistently failing since 2004 and we have reached 2024? सुमित, हम नालायक हैं इसलिए हम फेल हो गए?
Because we are looking at the wrong places. हमारा फिक्सेशन हो गया कि यही है, बस यही है, जबकि है नहीं. So basically short answer है कि despite all the studies, whether it was SAFE, Albois और अपना ARIS, किसी भी study में there is no benefit. It is just subset analysis which is showing there is a trend towards. So short answer, there is no benefit, but there are confounding factors like heterogeneity of shock. We don't know why it happens. Then at what point of timeline the albumin was administered. Then कितना दिया, कब दिया, क्या parameters है, cause क्या था. So all these factors are confounding factors. So maybe because of these reasons, we are not able to reach a consensus and what we are looking for.
So what Dr. Sumit has said, I will summarize it in one line. Yes, it has a role, no definitive proven role, because we were dealing with a heterogeneous population. कोई शॉक सेप्टिक शॉक है, कोई शॉक दूसरा शॉक है, कोई हाइपोवोलेमिक शॉक है, कोई सा शॉक है, क्या उस शॉक की पैथोफिजियोलॉजी रही, we don't know it exactly. We don't know when we started it, what was the duration, till what time we gave it, and what was the end point of it. Are we looking at short-term mortality or long-term mortality? ऐसे तो we can say the whole critical care is baseless. Hardly anything in critical care has been introduced which has changed the mortality as such. सब शॉर्ट टर्म में ही खेलते रह जाते हैं ना। गिनती चुनती की चार चीजें आ जाएंगी, एआरडीएस में ये कर लो, इसमें ये कर लो, थोड़ी बहुत मोर्टालिटी चेंज हो जाएगी। लॉन्ग टर्म देखेंगे तो फिर कहेंगे जी इक्विवेलेंस है, हो भी सकता है, नहीं भी हो सकता है। Why it is difficult? It is difficult because the population is different. You cannot do a randomized control trial in a sick patient. सेप्सिस का पेशेंट है, शॉक में है, आप उसको रैंडमाइज नहीं कर सकते, भाई चल तेरे को मरने छोड़ देते हैं, तेरे को दवाई दे देते हैं। So whatever data you get it on a observatory trials, and everybody of us knows that observatory trials are weak in nature. Fine. And डोजेज एंड टारगेट, पता नहीं किस डोज में देना, किसी ने किस डोज में यूज करा, किसी ने किस डोज में यूज करा। यस, सो 2004, 14 एंड 24 जैसे सर ने बात करी, सेफ, एल्बॉयस और अराइज, मोर्टेलिटी बेनिफिट नहीं मिला, बट यस इट डेफिनेटली हैज अ रोल। अभी तक सिर्फ इतना ही रखेंगे, ठीक है सर। अब चलो, जो सर ने कहा कि यस सब ग्रुप एनालिसिस में कुछ 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 मिला है। सो एवरी स्टडी हैज अ पर्टिकुलर सेट ऑफ डाटा एंड इट ऑल डिपेंड्स। आई थिंक इन द प्रेजेंट डे आ रहा, ये चीज मैं 10 साल पहले बोल रहा होता और आज बोल रहा हूं तो आई थिंक द पॉपुलेशन कैन अंडरस्टैंड इट मच बेटर, that everything you say, you conclude is a extrapolation and a jugglery of data, especially in the age of AI. ठीक है, किस डाटा को किस फॉर्म में प्रेजेंट कर रहे हो, कब कर रहे हो, किस टाइम पॉइंट पे कर रहे हो, इट इज जगलरी ऑफ डाटा। तो अगर इफ आई आस्क यू, जो ये ट्रायल्स हैं गौरव, ठीक है ना, तो इफ यू सी द सब ग्रुप एनालिसिस और ऑब्जर्व मोर्टेलिटी सिग्नल्स in septic shock, only septic shock. This is very commonly you receive a patient in ED transferred to your ICU. Is there any true therapeutic effect of albumin?
सर बेसिकली ये सिग्नलिंग है क्या सर? बेसिकली स्टडी इज गिविंग अ हिंट दैट the overall outcome may be neutral or harmful, but a treatment is effective in certain subset of patients. So specifically in LBO's trial, septic shock group was taken and it was pre-specified. So it was a better study rather than safe trial in which subgroup signals were there, but it was non-specified. So what LBO's trial gave us, it gave us that there is a certain mortality benefit with the when the patient is being treated with albumin with a relative risk of 0.87 and I think a p value of 0.03, which is significant. So it tells us some things, but it does not give us the conclusion that it is beneficial. Why? The subgroup analysis is they are inherently less powered studies rather than the proper study. And why is that so? Because the sample size, it may be adequate for a overall outcome, but it cannot be adequate for the moderate or minute effects which we are trying to see in the subgroup signals.
तो गौरव देसी तरीके में बताओ, हम तो आईसीयू में बैठे हैं, सेप्सिस का पेशेंट आया, एल्ब्यूमिन देना है कि नहीं देना, खत्म बात। पैसे लगते हैं भाई, 6,000 रुपए का है, कॉर्पोरेट हॉस्पिटल में वही 10,000 रुपए का लग जाएगा। ये बताओ बस हमें।
Sir, frankly, it depends upon what your patient is. There are multiple contexts to the patient. There are multiple. It depends upon comorbidity of patient. It depends upon the previous albumin levels. It depends how severe the shock is, the amount of the volume that has been already resuscitated. There are multiple factors to it, sir.
So what all factors Gaurav is mentioning over here, we will deal each one in detail. ने बोल तो दिया एक सांस में रटे रटाए कट 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 कट, ठीक है, बट इस हर फैक्टर को डिटेल में देखेंगे कि पानी कितना दे चुके हो भाई, हाउ मच द पेशेंट हैज बीन रिससिटेटेड बिफोर इट रीच्ड यू, व्हाट सोर्सेज डू यू हैव इन योर आईसीयू, ठीक है, इट्स नॉट easy and accessible that everybody will be having it. ब्लड, होल ब्लड, क्या पेशेंट ने रिसीव करा है, कैसा पेशेंट है, हेपेटिक एनकैफ का था, सेप्सिस में गया है, एब्डोमिनल सेप्सिस से आया है, प्रीवियसली प्रोटीन कितना था, मालनरिश्ड पेशेंट है, हाइपोप्रोटीनीमिया है, तो इट डिपेंड्स अपॉन वेरियस थिंग्स एंड वी विल टेक इनटू अकाउंट एवरी फैक्टर एंड अगेन वी विल कम बैक टू गौरव। अच्छा मैम, हम लोग जब भी पेशेंट आता है, इवन ये लोग जो एनेस्थेटिस्ट कन्वर्टेड इनटू इंटेंसिविस्ट है, उन्हें बड़ा कॉमनली पता है, या जो सीटीवीएस करते थे, हाइपोटेंशन हुआ, नॉर्मल सलाइन उठाओ, एल्बुमिन घोलो, दे दो, चाहे 20% हो, 5% रह जाएगा, 2% रह जाएगा, 2.5% रह जाएगा, रिससिटेट हो जाएगा पेशेंट, यू कैन रिप्लेस इट फॉर अ वॉल्यूम इफ यू डोंट हैव अ स्टार्च एट हैंड, or if you don't have a colloid at hand, you have albumin at hand, diluted, non-diluted, pochette, whatsoever, you can hemodynamically control it. So it's a very good physiological resuscitator and it optimizes the fluid balance also. But ये जो सारी physiological benefits हैं, ये survival benefit, mortality benefit या morbidity benefit में क्यों नहीं convert होते?
Because we all know albumin is a colloid and it increases oncotic pressure as well as it increases intravascular volume. So sometimes it increases mean arterial BP of our patient. And if we talk about sepsis, so in sepsis, there are multiple physiology are going on, like there are microcirculatory failure, the capillaries also, leaky capillaries are also there, and also there is a damage of glycocalyx. So in that case, if we give albumin, so it does not retain into the intravascular compartment. And also there is a formation of microthrombi that ultimately lead to a multi-organ dysfunction. So that's why albumin is not useful in such a sepsis and septic patient, because there are multiple physiologies are going on, and that's why they develop in they goes into the multi-organ dysfunction. So the albumin doesn't work in that scenario.
Perfectly, ma'am. What we are trying to say is कि अगर हम शॉक को सिर्फ फ्लूइड कंपोनेंट के पॉइंट ऑफ व्यू से देख रहे हैं तब तो समझ में आता है, बट सेप्टिक शॉक इज नॉट ओनली hypotension or only fluid component. It has got multiple etiopathologist going at the same point of time. जैसे कि इम्यून डिसरेगुलेशन होता है, माइटोकॉन्ड्रिया की एक्टिविटी चली जाती है, सो यू रिक्वायर मल्टीपल थिंग्स, नॉट ओनली फ्लूइड्स. It's a mixture. They're competing mechanisms. Fine, you require vasopressors, और ये जरूरी नहीं है कि the albumin we give will be able to sustain your pressure for so long till the time your organ recovers. इतना तो हम नहीं दे पाएंगे ना. So to conclude in one line, yes, it reduces the amount of crystalloid required, but due to multiple etiopathologies going at the same point of time, only albumin doesn't save the patient or doesn't work in septic shock. Fine. Nitish, coming to you. Again, a simple, straightforward question. ये बड़े-बड़े से ट्रायल थे, ICU, ICARAS, ED जो करते हैं इन्होंने करा था. Does the timing or the administration of albumin, इसको जल्दी देना चाहिए, लेट देना चाहिए, या कभी भी दे दो, does it really matter?
Sir, to simply give the answer of this question in one line is no, not yet. From this trial, ICA REST trial, what they have done, they have given albumin in first 6 hours, 3 to 6 hours. That is in early emergency period, not in the late ICU period. Theoretically speaking, when you are giving albumin, they have multiple effects. They increase the oncotic pressure, that tends to decrease interstitial edema. Then they try to stabilize the glycocalyx of the endothelial lining, and that in terms decrease the damage. They have a vasopressor sparing effect because they are increasing the intravascular volume, so the vasopressor requirement is decreased. And they also have some anti-inflammatory action. And due to these factors, it seems that yes, giving albumin in early hours does help patient to recover faster. But when they have done the study, after analysis, total analysis, the results were not clinically and statistically significant in terms of rate of mortality, terms of ICU stay, hospital stay, or any other complications which have developed. So as of now, as we are already discussing that everything is based on evidence or the trials. From these trials, we have found out, yes, it might be beneficial, but it is not actually significant to control the timing of giving albumin. If you are giving albumin, it might be possible that you have some time to spare to take action fast, but the ultimate results as of now are not different.
तो अब तक क्या समझ में आया? अभी कुछ महीने भर पहले 2026 की गाइडलाइन आई है, उसमें एल्ब्यूमिन को जगह मिली? देखी तो होगी हम सब, नहीं मिली ना जगह, तो इसका मतलब अभी भी हम वहीं हैं. Fine. So albumin has not been proven to be so efficacious that it would have found a place. कितनी सारी sepsis guidelines आ गई, तो it is still not there in guidelines. ठीक है, तो initial yes, when capillary are leaky, उस time पे oncotic pressure देने बढ़ाने के लिए कर सकते हो multiple points. Fine. So the timing doesn't matter. डॉक्टर साहब के हिसाब से तो देना भी मैटर नहीं करता. ठीक है, तो coming to Sumit. What is your general perception? When do you give albumin in your patients? Forget about sepsis. एक पेशेंट है आपके पास आईसीयू में, एक जनरल डिक्टम क्या चलती है आप बताओ? मैं बताता हूँ हम क्या सोच के चलते हैं. भाई किसी का एल्ब्यूमिन अगर लेस देन 2 एंड ओवर अ पीरियड ऑफ टाइम अच्छी न्यूट्रिशन देने के बाद भी उसका टोटल प्रोटीन या टोटल एल्ब्यूमिन कम रहता है, तो हम उसको we try to supplement albumin. The certain amount of oncotic pressure is built up, vasopressors are tapered off, or whatever so. But there are 2 trials जो मतलब starting from L boys, अराइसिस, अरिस्टोस, ये सब क्या कहते हैं कि try to maintain a level above 3. Fine. Now we are talking in terms of septic shock patients. They say try to maintain an albumin of 3. So is targeting albumin okay, good, bad, or we should not do it?
See, as you rightly said, both the studies, Albias and Arise, they had taken the cutoff value of 3 gram per deciliter. So they compared albumin 20% with crystalloids versus crystalloids alone, but this study did not show any benefit. So again, so whether to maintain this target 3 gram per deciliter is justified or not, it depends upon, there are points both in favor and against. So favor, yes, it is a critical level which is maintained and it is a important marker. But is it a therapeutic marker? The answer is no. Probably it is not a therapeutic marker. Albumin again may reflect the severity of the disease or the underlying illness, or there are other factors which may cause low albumin levels. So both the studies, even if we maintain the albumin level to 3 grams, have shown it has not reduced the incidence of mortality or the target organ damage.
इसको सिंप्लीफाई कर देते हैं। जब भी आप किसी चीज को, किसी भी दवाई को, एल्ब्यूमिन को एक दवाई मान के देते हो, ठीक है, तो उस मेडिसिन का क्या होता है? मेटाबोलाइजेशन, distribution and redistribution. So albumin distributes and redistributes itself very fast. ठीक है, तो वो जो इफेक्ट आप सोच के चल रहे हो कि विल बी सस्टेन्ड फॉर अ लॉन्ग पीरियड ऑफ टाइम, वो सस्टेन्ड नहीं रहे। दूसरा इसका एक व्हाट इज द देयर, जो हम सोच रहे हैं कि हमने एल्ब्यूमिन दिया, रिड्यूस्ड ऑन्कोटिक प्रेशर है एंड इट विल बी लीनियरली इंक्रीजिंग एज विल बी, लीनियर ग्रोथ होती है ना, आप इन्फ्यूज करे जा रहे हो और ऑन्कोटिक प्रेशर बढ़े जा रहा है, ऐसा नहीं होता। इट हैज अ नॉन लीनियर रिलेशनशिप। ठीक है गौरव, कौन सा एल्ब्यूमिन यूज करते हो तुम लोग?
4.2
करते ही नहीं है? करते तो हो गए यार, आज भाई
करते हैं
तो पड़ता है यहाँ पे।
नहीं नहीं
हाँ
4.55% कर
5% करते हैं। तो सवाल गौरव से ये है कि 5% देना है या 20 से 25% देना है, या जो सा सस्ता मिल जाए और महंगा लगा के बेचा जा सके?
सर ऑन द कॉन्ट्ररी 5% ज्यादा महंगा आता है।
हाँ। अब इसके आगे ऑन द कॉन्ट्ररी है कि अगर इसको और अच्छे से बेचना है तो आप कह दो जी लो सॉल्ट एल्ब्यूमिन है हमारे पास, सुना हुआ है ना सबने? ठीक है, लो सॉल्ट एल्ब्यूमिन में आज तक किसी ने ये जाके नहीं ढूंढा कि जो नॉर्मल सॉल्ट सोडियम है और जो लो सॉल्ट सोडियम है, दो मिली इक्विवेलेंट का फर्क नहीं है। गलत बोला क्या?
सही।
कॉस्ट का फर्क कितना है? वो 4,000 वाला 8,000 का हो जाता है। अब बताओ डॉक्टर साहब क्या यूज करें, 5%, 25% या 25% को पानी में घोल दें?
सर बेसिकली 5%, 4%, 5% जो भी है, 5% और 20% सर, दे बेसिकली रिप्रेजेंट टू डिफरेंट थेरेप्यूटिक अप्रोचेस। 5% आइसोएन्कोटिक है, सो व्हाट इट डज, इट बेसिकली होल्ड्स वाटर इनसाइड द इंट्रावेस्कुलर कंपार्टमेंट।
बिल्कुल।
सो 1 ग्राम अगर हम 5% दे रहे हैं, सो अप्रोक्सीमेटली 18 ml ऑफ वाटर वो होल्ड करेगा, and oncotic pressure is something in the range of 25 millimeters of mercury. Whereas if we compare it to 20% albumin, oncotic pressure is around 100 millimeters of mercury, and it is more of a use in patients जहाँ पे पहले से ही hypoalbuminemia है with positive water balance. शॉक उतना नहीं है, लार्ज वॉल्यूम रिसस्किटेशन की जरूरत नहीं है या पहले हो चुका है। एंड फ्रैंकली स्पीकिंग स्टडीज कंपेयरिंग बोथ ऑफ देम आर नॉट देयर। सो अगर रोल बोलें तो ये है कि 5% अर्ली रिसस्किटेशन में काम आना है फॉर लार्ज वॉल्यूम रिसस्किटेशन, एंड 20% इन पेशेंट जहाँ पे इस्टेब्लिश हाइपोएल्ब्यूमिनीमिया है विद सेप्सिस विद पॉजिटिव वाटर बैलेंस एंड नाउ नॉट रिक्वायरिंग लार्ज वॉल्यूम रिसस्किटेशन।
व्हाट गौरव हैज सेड सो सिंप्लीफाई। अब अगर इसको मैं यही चीज कहीं यूएस में खड़े होकर कहता तो लेट्स प्रोसीड टुवर्ड्स प्रिसिशन मेडिसिन, लेट अस प्रिसाइसली टेक इनटू अकाउंट व्हाट द पेशेंट हैज, what is the etiology behind the shock, what are the various vital parameters, and what does the biochemistry shows. So there are different ways of putting it forward. He has simplified it, but where he is taking us towards, आज की डेट में हम सब कुछ ऐसी बात करते हैं ना भाई, डिजिटल, AI, प्रिसिशन मेडिसिन, पेशेंट स्पेसिफिक, तो वो प्रिसिशन मेडिसिन की तरफ लेके जा रहा है कि किसमें 5% देना है, किसमें 25% देना है और किसमें नहीं देना है। विल कम टू दैट ऑल्सो। It is how you play with your words. वी आर ट्राइंग टू कीप इट as simple as it is कि आपको पता चले कि हाँ 5 भी दे सकते हैं, 25 भी दे सकते हैं, 5 पहले दे सकते हैं, ज्यादा वॉल्यूम दे सकते हैं, 25 बाद में देंगे, या बहुत जल्दी जहां पे देंगे जहां पे एल्ब्यूमिन पहले से कम है। यही है मैम। दिया एल्ब्यूमिन 200 ml भी है, 100 ml भी है, चलो, और क्रिस्टलॉइड देने बैठे तो मल्टीप्लाइड बाय 2 3 4 वॉट एवर यू वांट टू। तो वॉल्यूम स्पेयरिंग इफेक्ट का थेराप्यूटिक क्लिनिकल कोई एडवांटेज है?
So albumin has a volume.
मोर्टेलिटी बेनिफिट तो पूछूंगा नहीं, क्योंकि क्रिटिकल केयर में ना हर चीज का एक ही आंसर आया था लास्ट में आके, क्योंकि मोर्टेलिटी बेनिफिट तो नहीं हो रहा जी। 28 दिन तक हाँ कुछ फर्क पड़ जाएगा, वेंटिलेटरी फ्री डेज मिल जाएंगे, मुद्दा मोर्टेलिटी का है ही नहीं। आप बताओ कि जो ये वॉल्यूम स्पेयरिंग इफेक्ट है, डज इट हेल्प अस?
So albumin has volume sparing effect, and as per few literature, they have demonstrated that if we resuscitate with albumin based resuscitation, that can reduces crystalloid based resuscitation by 20 to 40%. But as per Indian scenario, albumin based resuscitation, it will be very costly for Indian ICU. So for me, I would means in our ICU we use basically crystalloid for resuscitation, and
गाइडलाइंस भी वही कहती हैं क्रिस्टलॉइड यूज।
yeah. So I would suggest crystalloid is better resuscitation fluid rather than giving albumin based resuscitation fluid, because it's a costlier for as per our Indian ICU, it's a costlier therapy, a costlier affair. Yeah.
See, let us take by the literature. ठीक है, we all practice in different scenarios. कोई छोटे हॉस्पिटल में है, कोई 100 200 1000, जैसी अवेलेबिलिटी है, try to follow the guidelines as long as possible. You can follow it. एक पंच लाइन में हमेशा देता हूँ, गाइडलाइंस आर नॉट गॉड लाइंस। ठीक है, वो भगवान की दी हुई लाइनें नहीं है। तो अपने लोकल सिनेरियो के हिसाब से उन गाइडलाइंस को पेशेंट बेनिफिट के लिए मॉडिफाई कर लो, अपने बेनिफिट के लिए कर सकते हो, ऐसा कुछ नहीं। नीतीश, ये सब बोल रहे हैं देख, क्योंकि एल्ब्यूमिन दे देते हैं तो लीकी कैपिलरी कम हो जाती है, तो कैपिलरी ग्लाइकोकाइलेक्स मेंटेन रह जाता है, तो जब ग्लाइकोकाइलेक्स मेंटेन्ड है तो एंडोथीलियल इंजरी कम हो गई, एंडोथीलियल इंजरी कम हो गई तो इन्फ्लेमेशन कम हो गया, इन्फ्लेमेशन कम हो गया तो एडिमा कम हो गया। ये सब ऐसी है या कुछ है भी इसके अंदर? डज इट रियली होल्ड? बेसिकली वी आर टॉकिंग अबाउट द प्लियोट्रोपिक इफेक्ट्स ऑफ एल्ब्यूमिन।
सर व्हेन आई वाज अ पीजी, आवर सीनियर यूज्ड टू टेल कि एल्ब्यूमिन कब देना है। ओवरी का पेशेंट आया, एसाइटिस है, यार एल्ब्यूमिन दे दो, बीपी गिर रहा है, ऑनकोटिक प्रेशर। आज भी हम वही बताते हैं, बट
आज भी वही है,
आज भी वही बताते भी है भी। पर एक डायलॉग है ना, पिक्चर अभी बाकी है मेरे दोस्त, इट्स अ स्टार्टिंग ऑफ अ जर्नी ऑफ एल्ब्यूमिन। Apart from maintaining the oncotic pressure, albumin has many more effects. It has antioxidant property due to thiol group. It prevents oxygen radical toxicity. It has a coagulation stabilization effects. It stabilizes the glycocalyx of endothelial membrane, decrease the permeability and thus the this interstitial edema. It has anti-inflammatory activity by acting on IF factor or neutrophil activation factor. So from these things, we can say that albumin has so many effective characteristics or properties, but still we are using it as a oncotic for oncotic pressure maintenance. Reason being, the albumin we are talking about is the actual albumin which is present in our body. But the albumin which we are transfusing to the patient is a commercially available albumin. When you are extracting the albumin and processing it and packaging it, then the duration, shelf life, during all those time period, the properties and the characteristics of the actual albumin decreases and deteriorates. The ultimate maximum effect which we see from those albumin is the oncotic pressure only. So currently, we can say that we cannot clearly say that albumin has a much more vital role apart from oncotic pressure maintenance.
So Dr. Nitish क्या कहना चाहते हैं? There is a gap between the physiological albumin and a commercial albumin. तो इसी को आगे बढ़ाते हैं थोड़ा सा और। What Gaurav wanted to say, अब so called fancy precision medicine में घुसते हैं कि किसको देना, क्यों देना, कैसे देना, कब देना। So do you think we should restrict ourselves to certain patients, certain phenotypes, to give albumin, or we can give it blanketly?
So we
certain phenotypes में cirrhosis, refractory septic shock, या hyperkalemia.
So, the question is very valid because we know कि across subset in the broad the intent to treat patients और जो भी पूरे subset of patients थे उसमें benefit बहुत limited था. So there are subset of patients which may benefit. And again, at the same time, we know that the incremental benefit, as you said, if the albumin levels are below, they go down below 2, the incremental benefit is more. So definitely it makes sense to consider it in those subset of patients like hypoalbuminemia, as you rightly said. In patients, cirrhosis-associated hypoalbuminemia is there, or the patients who are having refractory shock, or maybe in the post-surgical setting, maybe, I don't know.
See, again, the data is emerging. आजकल हर चीज एविडेंस बेस्ड हो गई है, बायोमार्कर बेस्ड चलेंगे, ये दवाई देंगे, बायोमार्कर कम हो गए तो बहुत अच्छी बात है, बायोमार्कर कम नहीं हुए तो basically here we will be looking for the biomarkers of endothelial injury. तो we'll move fast क्योंकि घंटी बज चुकी है. गौरव, स्ट्राश देते हैं किडनी खराब हो जाती है यार, एल्ब्यूमिन देते हैं किडनी खराब हो जाती है. So is it a myth? Renal safety of albumin?
It's a myth, sir. We have multiple evidences. सेफ ट्रायल ने बोला कि सीवियर सेप्सिस में रीनल फंक्शंस जो हैं बेटर हैं, रादर रीनल रिप्लेसमेंट थेरेपी की भी कम से कम यूसेज है. देन एल्बियोस ट्रायल ने हमें बताया कि सीवियर सेप्टिक पेशेंट जो सेप्टिक शॉक पेशेंट हैं उनमें बेटर प्रिजर्व रीनल फंक्शंस थे. एंड कॉन्सिक्वेंटली है भी बिकॉज उस यूज़ किया एल्ब्यूमिन का, बेटर हमारी हीमोडायनेमिक पैरामीटर्स हैं. एंड इफ द हीमोडायनेमिक पैरामीटर्स आर बेटर, definitely renal function will be preserved better. So this was showed by Albios trial. And multiple नीतीश सर ने पहले भी बताए 3-4 मैकेनिज्म है by which albumin preserves glomerular function. दोबारा रिपीट करने की जरूरत नहीं है सर. So I believe that it does not causes any kind of nephrotoxicity. Rather, one point I would like to make, sir. नेफ्रोटॉक्सिसिटी से ज्यादा जो प्रॉब्लम ये है, यूवोलिमिक पेशेंट में हम एल्ब्यूमिन का एक्सेसिव यूज कर रहे हैं, and because of that excessively intravascular volume expansion हो रहा है, that is more harmful rather than.
बिल्कुल, totally agreed with Gaurav. Now we have bedside, हमारे पास सबके पास एक अल्ट्रासाउंड है. धीरे धीरे हम इतना इवॉल्व कर गए हैं कि we have started using VEXES. So rather than overloading the patient and taking your kidneys into congestion, better look at, do a VEXES scan and then give. And he's rightly said that in EU volumic patients, there is no point in supplementing it with albumin. Fine. Shweta, pulmonary safety, renal safety भी हो गई, pulmonary brain की भी बात करते हैं. नीतीश से brain पूछेंगे. So do you think does albumin exacerbate pulmonary edema or ARDS? Capillary leak, or does it prevent capillary leak and prevent ARDS or something like pulmonary edema in a patient जिसको आप fluid resuscitate कर रहे हो?
No, sir. Actually, if we give albumin, it doesn't lead to a pulmonary edema or ARDS. But sometimes in some studies, they have also demonstrated, they have given albumin with diuretic to for decongestion purpose, and they have shown that there will the ventilator requirement and the ICU days were reduced in that that subgroup of patient.
So you have to always take into consideration which day of illness you are, what type of a patient you are having, how much leaky capillaries are there, whether all the fluids that you are giving are going into the extravascular space or the interstitial space of the lung, and accordingly decongest it. So what is this vascular permeability in sepsis, Nitish? Leakage of albumin,
So
does it
normally
negate? And how is this phenomena really relevant?
Normally in sepsis, it is said that due to increase in vascular permeability, whatever albumin we are giving, it is leaking out from the intravascular space. So it might not be beneficial. But actually speaking, what it is not that complete of the albumin is going from intravascular space to the interstitial space. Some of the albumin is still staying, which increase the oncotic pressure and thus maintain the intravascular volume. Moreover, whatever albumin is being sieved out, it will again reabsorb from the lymphatic and come to the intravascular space and will maintain the oncotic pressure. Third thing is the albumin which is being sieved out. It's not dead albumin. It has their own properties. So it might have a anti-inflammatory properties and thus decrease the interstitial edema. Also, the places where the permeability is changed, it is not same in all the vessels. It might be decreased and increased at some places. So if it is, you are saying that due to increased permeability, the albumin is lost and it is not maintaining oncotic pressure, it is not correct.
So we will skip something क्योंकि आधे लोग सोने लगे हैं, आधे लोग गपियाने लगे हैं, तो कॉस्ट इफेक्टिवनेस छोड़ देते हैं. हम सबको पता है बहुत महंगा है, ठीक है. हिसाब से इंडिविजुअलाइज द पेशेंट, इंडिविजुअलाइज योर सेटअप एंड डू इट अकॉर्डिंगली. इंटरप्रिटेशन ऑफ गाइडलाइंस, यू शुड बी वेरी केयरफुल. गाइडलाइंस आर नॉट गॉडलाइंस. हमने एक लाइन मार दी, जिसको अपने सेटअप के हिसाब से कर लो. बट yes, I would, Shweta, this is an important question which I would like to highlight. See, we have started in 2004, landed up in 2024. अभी भी trials आ रहे हैं, ठीक है. The trials like Aristos, building upon Arises methodology, Albios, albumin in Bunce patient. What is your take on these things? Arise आया 2023 में in septic shock. Just brief one line about Arise, Albios, style.
So SAFE and Albios trial, they have shown that there was no mortality benefit in both the trial, and albumin in Burns patient. So if we use albumin Burns patient, it may be beneficial because there is lots of raw area and albumin water losses and albumin losses is also there because of leaky capillaries and all. So in burn patient, it can be helpful, but we have to see how much percentage are involved in burns, and then we can decide upon how much albumin we have to give in that patient.
Fine.
Yeah.
We'll just finish it off. Medical versus surgical, Nitish, any difference? Or
Yes,
it's
there is
the
a
same?
actually there's a difference between use of albumin in medical versus surgical, because in medical sepsis, you don't know when the sepsis is setting in. It might be very late when you're using albumin, whereas in surgical sepsis, you know from day one what are the changes which are happening, either hypoalbuminemia, any vascular drainage, because during surgery, there is a high possibility the albumin is decreasing. So yes, definitely use of albumin and surgical sepsis has a much more advantage because you are tackling it at an early stage.
Rest all few unanswered questions which are of research point of time. एक line, biomarker based therapy.
Yes, definitely welcome, but it remains elusive. We don't
Again,
have.
big research centers, big research things. गौरव, ऐसी क्या चीज चेंज करें? 2004 से 24 आ गया, कितने 6 ट्रायल निकल गए. फ्यूचर ट्रायल अगर कोई प्लान करें तो कुछ चेंज कर सकते हैं?
फर्स्ट एंड फॉरमोस्ट बेटर फिनोटाइपिंग. ये सेफ ट्रायल लिया सर, एल्बियोस ट्रायल लिया, बड़ी ब्रॉड सी फिनोटाइपिंग थी, कईयों में पोस्ट ऑक एनालिसिस की गई.
So let us take specific subgroups of patient. We might have a better conclusive result. But again, with a pinch of salt, because they will be again observatory trials.
दूसरा सर, जो हम एंड पॉइंट्स ले रहे हैं वो थोड़े से जैसे हम लोग चेंज करनी चाहिए. रादर पेशेंट सेंट्रिक एंड पॉइंट्स होने चाहिए रादर देन 28 डे मोर्टेलिटी जैसे हम लोग अभी ले रहे हैं. उसमें पेशेंट सेंट्रिक होनी चाहिए.
So to conclude it all, we'll take Nitish's final word. दें, ना दें, कितना दें, कब दें, कहाँ दें, कैसे दें, क्यों दें?
सर ये तो सारा डिस्कशन हुआ अब तक, इतनी देर तक. फाइनल वर्ड है देना है, पेशेंट स्पेसिफिक देना है, सर्जिकल में बेनिफिट है, अर्ली लेट का कंसेप्ट नहीं है, एंड अभी ट्रायल बहुत ज्यादा चाहिए.
सर 2 चीजें ऐड करूंगी.
प्लीज प्लीज मैम, अभी तो डिस्कशन वहां शुरू होगा, यहाँ थोड़ी.
So there are only few indication of albumin in cirrhotic patient, like if we are doing large volume paracentesis, when there is a role of albumin. If patient has a SPB, spontaneous bacterial peritonitis,
That is very important. Spontaneous bacterial peritonitis following cirrhosis, sepsis,
and hepatorenal syndrome. So there are 3 main indications. Then we have to give albumin without any excuse.
एक आध में वो भी डाल देते हैं, less than 2 gram हो तो. Sir, please start off. Shoot.
So as a surgeon, I am a head and neck cancer surgeon. We do a lot of free flaps. Our surgery go on for 7 hours, 8 hours. And preoperatively, patient of head and neck cancers are little bit depleted, but it's not. Albumin level is mostly 3.5. नहीं, 2 वाला नहीं, वो एम्स वाला नहीं है, 3.5.
सूचर भी तो स्टे करने हैं ना जहां आप करोगे.
तो we usually have albumin around 3.5 तो रहता है. But immediate post-op में when patient is shifted from surgery, from eye to surgery, so albumin is low, you will find albumin will be 2, somewhere like that. And if BP is not maintaining, is it viable to give albumin for these patients or not?
See sir, From again, don't think of me as an anesthetist, as a critical care physician. अब मैं बिल्कुल एक सर्जन की तरह बात करता हूँ. Patient is most important for all of us. Fine. Why does it happen कि अंदर 3.5 था और बाहर 2 हो गया?
नहीं, आप सर आंसर दो, ये सब कहानी मत करो.
सर कहानी में देंगे, सर देंगे, एल्ब्यूमिन तो देंगे ही, क्योंकि आपके सूचर भी तो रुकवाने हैं. पर आप ये बताओ भैया कि क्यों 3.5 से बाहर आते ही 2 क्यों हो गया पोस्ट सर्जरी? Acute phase reaction, it will go down and it will come up also very fast.
So that's why we have been having this argument in our hospital also. Same, I think that's why we critically designed that which patient to be given, which not to be given. So,
Exactly.
so most of the thing, if you see these patients in post-op period after 2 weeks, the albumin
They will be normal.
albumin
You
level.
take anything, sir.
And if you give albumin, it will be used as a protein source for the patient. That's
एक
it.
प्रोकैल को छोड़ दो सर, टीएलसी कोई सा भी इन्फ्लेमेटरी मार्कर लोगे तो वो पोस्ट ऑप में बढ़ेगा ही, डिपेंडिंग अपॉन योर टिश्यू हैंडलिंग. फाइन. हाँ, अगर इंडिविजुअलाइज्ड पेशेंट, इफ यू टेक इनटू कंसीडरेशन कि भाई वी नीड आवर सूचर्स टू स्टे आल्सो, व्हाट इज द हिस्ट्री ऑफ अ पेशेंट, अगर वो शुरू से ही हाइपोएल्बुमिनिक है, नीड नॉट, यू शुड रिप्लेस इट. हाँ सर, बिल्कुल शुरू हो जाओ.
Sir, just want to know.
इतने सारे लोग हैं, बेस्ट क्यों भाई, बहुत लोग हैं.
Malignant ascites में what is the role of albumin?
कौन लीवर ज्यादा डील कर रहा है भाई, इसका आंसर दो. अनिल आया नहीं.
Ascites में
Ascites में do we need to give albumin always?
if we drain more than 5 liter, then we have to give albumin. Yeah, 8 gram per liter. Routinely no, but
routinely no.
If we do
इतना तो
large
सबको
volume
पता है.
paracentesis more than 5 liter, then we should give. Yeah.
Please, ma'am.
Sir, you've just said that cost effectiveness तो आपने सोची ही नहीं.
सबसे ज्यादा सोची मैंने, बीच में छोड़ दी. मैं कहा
No,
भाई
I
जिसके पास जितने पैसे हैं उस हिसाब से काम करो. मेरे पास BMW के पैसे हैं तो मैं BMW खरीदूंगा, ऑल्टो के हैं तो ऑल्टो खरीदूंगा.
There is a देसी इलाज also, there is egg albumin जो राइस ट्यूब से दे सकते हैं. How do you go with that? वो आप
See,
देते
we are
हो.
talking of.
Do you use it in your ICUs?
मैम
वो
हमारे यहाँ
surgical patients जो हैं उनको दे दो.
डाइट बनी बनाई आती है. We tell them to make it high protein diet. अब उसमें they make everything into it.
नहीं, what I'm saying is 1 egg white is 3.5 grams of albumin.
But
नहीं सर, ये वेजिटेरियन है, और भी तो है नॉन वेज वाले भी.
we get a diet, ma'am, which is
जेलेटिन जो होती है हर कैप्सूल में, that is again नॉन वेज. कहाँ तक भागोगे?
नहीं मैम, जब आपके पास टाइम पीरियड है, सी इन एक्यूट शॉक वो तो काम नहीं आएगा. अपने बिल्डअप के लिए द नेचुरल वे इज द बेस्ट वे टू बिल्ड अप एवरीथिंग.
So how do you go with that? I mean, does it really work as compared to?
आपके घर में कोई 70
6,000 नहीं है एल्ब्यूमिन के.
प्रोटीन और एल्बुमिन दो अलग अलग चीजें हैं. यहाँ पे आप
एल्ब्यूमिन,
हाँ, बट एल्बुमिन को हम घर पे नहीं दे रहे किसी को. इफ यू हैव अ गुड हाई प्रोटीन डाइट, इट विल बिल्ड अप ओवर अ पीरियड ऑफ टाइम. आपके घर पे कोई 70-80 साल का बुढ़ा है तो उसको यही बोलते हैं ना, कीप हिम न्यूट्रिशनली, गिव हिम अ गुड अमाउंट ऑफ प्रोटीन. अब वो किसी तरीके से भी जाए. This is, we are talking in terms of pure sepsis and septic shock. That's it, not beyond that.
No, just talking of the post-op scenario, like sir was saying, his patients.
पोस्ट-op
low
में
in
मैम,
albumin,
अगर कोई पेशेंट शॉक में गया है तो उसको न्यूट्रिशनली बिल्डअप करने में टाइम लगेगा. यहाँ पे वो मुझे नहीं लगता कि काम आएगा एनजी ट्यूब से देके.
नहीं देना चाहिए.
नहीं देना चाहिए, नहीं देना चाहिए. इट टेक्स टाइम. इट्स एन एक्यूट फेज ना, यू नीड टू टाइड ओवर
But then you can give it. It is an option.
ऑप्शन नहीं है लिटरेचर में, नहीं है कि अंडा आप खिलाओगे तो पोस्ट ऑप के हाइपोटेंशन उससे ठीक हो जाएगी. नहीं,
एल्ब्यूमिन नहीं बढ़ेगा.
मैम कोई भी कोलाइड दे दो, एल्ब्यूमिन की बात नहीं. यू नीड टू सस्टेन दैट प्रेशर. रिससिटेशंस कुछ है नहीं. एनीथिंग एल्स? चलो, होपफुली सबने एंजॉय करा, कोई सोया नहीं. थैंक यू. पत्र भी लेंगे तो आगे कंफ्लिक्ट से बोल के आज तो बनता है दोस्तों. you. Thank you all.
Let us thank our esteemed moderator and panelists for their interesting and engaging talk with a round of applause. For our next panel discussion on newer antibiotics, what's the future? May I request Dr. Amit Goyal, sir, Director and Head Critical Care Medicine, Sarvodaya Hospital, Greater Noida, Uttar Pradesh. Please welcome all the panelists.
Hello, very good afternoon, everyone. So, I'm Dr. Amit Goyal. Let me invite the panelists. May I invite Dr. Anil Gunani, sir, on the dais. Then Dr. Mudit Agarwal, sir. Dr. Neelam Sachdeva, madam. And Dr. Bhavnish Agarwal. So, after this engaging discussion by Dr. Khanna on whether to give or how much to give, when to give, let's discuss about the antibiotics where we don't have any debate whether to give or not. It's got its own subset of issues, what to give, and then what all antibiotic do we have in the future. Should I start, sir? Right. So let's discuss about the newer antibiotics. Before we actually move on to the newer antibiotics, we shall understand what exactly the antibiotics are. So we know that antibiotics they are against the life. So this is arguably one of the breakthrough discovery of the human or medical science in 20th century, which has changed or the human life by actually sustaining some more time or duration, quality of life by actually killing the bacteria which may be or are harmful. And it does not only help, has shown the benefit in killing the bacteria and working in sepsis, but also in organ transplant, many organ open heart surgeries, and many cancer surgeries as well. So when we talk about commonly available antibiotics, so this is a slide which shows the antibiotic which we have in our hands. So we've got penicillin, the aminopenicillin, uridopenicillin. There are cephalosporin, 1 to 5th generation of cephalosporin. There are certain combination of beta-lactamase inhibitor which is added to these penicillin or cephalosporins, and then we have got monobactams. We've got other group of antibiotics in the form of aminoglycoside, lingosamide, quinolones, monobactams, tetracycline, so on and so forth. So they are the large number of antibiotics which are there in our armamentarium. But still, we are in the quest of having newer antibiotics. Why? This slide is going to show us the timeline of antibiotics, wherein the first semi-synthetic or synthetic antibiotic was introduced in 1910, and then 1928, which was penicillin discovery by the great scientists. And then we had a word of caution that there could be a misuse of this antibiotic, and then it will lead to the antibiotic resistance. And this happened in next couple of decades. And then we had penicillin resistant, which was identified in 1940. We had some more antibiotic which was developed from this actinomyces mycosites, group of fungi. We had macrolides, we had glycopeptides, we have fluoroquinolones, but simultaneously, because of the regular use, overuse, and misuse, we would see the resistance. So we had seen the resistance to penicillin, then we saw the resistance to penicillin in the form of Staph aureus, having a development of MRSA, plasmid-borne resistance was developed. Then we have got Enterococcus, which is developing resistance to vancomycin. And we, in 2010, after 2010, we did not have a major antibiotic which is coming up. So there is a void, a big void, because antibiotics are being developed, but we have a resistance which is there within a couple of years or within 5 to 10 years. So I shall start my discussion with Gunani sir. Sir, why do we actually need new antibiotics?
Good afternoon, everyone. Before I actually embark on why we need newer antibiotics, do we really have newer antibiotics? Let me share a very interesting data with you. Since we have so many colleagues from the oncology section sitting here, in last almost 1 decade, around 63 new oncologic preparations have come. Almost same number, around 60 to 70 of cardiac preparations have come. And believe you me, only 8 new antibiotics have come, which have received US FDA approval. Out of this, barely 4 to 5 are available in our own country. After some time, we'll go into details. So when we really talk of newer antibiotics, it looks as if there is a huge magnitude. No, it's barely 4 to 5 new antibiotics have come. So we hardly have any newer antibiotics. On one hand, we have very limited antibiotics. On the other hand, you look at the magnitude of the problem. Do we know that India is the AMR capital of the world? If I'm quoting a data from Indian Journal of Medical Research, around 70,000 deaths every year due to AMR. Projected data from the network of Indian hospices, it says around 500,000 people die every year due to resistance. And in 2006 or so, India was seen on the world map, but for wrong reasons. New Delhi metallo-betalimase were discovered 2006. We thought it was from India. And by 2010, it had shown in the whole world. Recently, very recently, I think 2019 or so, we saw India at the number 145 among 204 countries. So we were very happy. It was again for wrong reasons. Again, wrong reasons. It was showing age stratified mortality is highest in the India because of antibiotic resistance. So on one hand, you have limited antibiotics options. So you need to develop more and more antibiotics with newer techniques, reduce the mortality by modifying their working techniques, their working mechanisms, so that we have less mortality. And of course, if like we heard in the previous, if not the mortality, at least we cut down the number of days in the ICU and number of days on the ventilator. That's why you need newer and newer innovative antibiotics.
Very true, sir. So this is the buzz around the antimicrobial resistance, which is there, published day in, day out in the newspapers as well. So Times of India has been reminding us regularly there is a rampant antibiotic overuse, over-the-counter sale of the antibiotic, which is fueling the resistance. And then we've got race against the resistance, reinforcing the curtailed use of antibiotics, and then we've got antibiotic resistance, delaying recovery, expanding hospital stay. So there are a lot of, hue and cry, or I would say rather eye-opener messages, which has been conveyed to not only in the medical parlance, but also to the, public. So that the awareness can be, spread. As sir has rightly mentioned, India is the strongest user, I should not say user, is abuser of the antibiotics. And then this is a reason why we are the stronghold for this superbugs. The superbugs play a hit in Indian tourism. And yes, this is the cancer oncological area is also no different to superbugs or antibiotic resistance or antibiotic overuse. So this is where this comes from National Academy of Science. India is antibiotic consumption capital of the world, as sir has rightly mentioned. So my question to sir, Dr. Mudit Agrawal sir, what are the challenges in developing newer antibiotics? So one is, of course, we are using, overusing, misusing the previous antibiotics. So if at all we think of generating newer group of antibiotics, newer antimicrobials, so what are those challenges which we have to overcome, and then we have to see that this challenge which was there in the previous antibiotic shall not come with the newer antibiotics?
For new antibiotics, basically, the mechanism has to change because we need to see the present antibiotic, how they are acting and how we have to circumvent because resistance is developing to these antibiotics. So how can we first by prevention, as we have told that not to overuse the antibiotics, and second by circumventing that area of resistance which is there. So to understand that technology and to come back to that thing, I think that is the thing which is holding back newer antibiotics.
Right, sir.
Yeah.
Right, sir. So as sir has rightly mentioned, so the antibiotic pipeline, so newer generation of antibiotic, which is being, worked upon in many countries. So the challenges are there. The major challenge is there is no big pharmaceutical company who is ready to invest their time and R&D to be done in the development of newer antibiotic. So as per this, from the Guardian, the only GSK and another major company who are ready to put in their time for development of new antibiotics, but the major leader, like in the form of AstraZeneca, they have retracted themselves for generation. But yes, AI can also help us generating this thing. And yes, again, we'll have to go back to the roots. We'll have to revisit how the first antibiotics, the previous antibiotics, or the first 4 or 5 antibiotics were, we generated, or we received, or we purified. So it was from the soil itself. So again, we have to look for the naturally produced antibiotics, and then we'll have to perhaps depend on these antibiotics. So we perhaps need to see to these. So ma'am, what are the newer antibiotics which are commonly there, which has been discovered or we are using in our parlance, in the medical parlance right now?
As we all know that we have a scarcity of medications, we do have carbapenem resistant bugs which are increasing year by year. But when it comes to antibiotics, we haven't coined anything. It is basically the Western world who has been doing everything for us. So what we have observed is that they realize that they have gram-positive bacteria and we have gram-negative. So why should they be doing anything for us? So they stopped researching. And even if they came up with new drugs, it was basically the combinations. They had been adding adjuvants only. You can see like ceftazidime, avibactam. So ceftazidime was already there. They've just added an adjuvant, but that also acts through KPC. The genetic mechanism is through KPC. And this Klebsiella producing carbapenemases are not there in India. So this was a useless drug for us. But then we were, like we being Indian, we are always jugadu. So we added azithromycin along with, and we thought we can go ahead, maybe it works for NDM and Oxa, but it didn't work for a longer time. Same way we came up with meropenem, but meropenem vibrovectum is there. So, but this is another adjuvant, but nothing called new. Same way ceftazolline is there, but then we have added tazobactam. We have imipenem celestin, that was already there. We have started adding relebactam. But then how promising they will be, we really don't know how. As we'll use, we'll come to know about it. But still, because one salt is already in use and it is resistant, I don't know why adding adjuvant, how long it's going to work, so nobody knows about it.
Right. So very rightly said, ma'am. So actually right now what all we have is just the adjuvant has been added to the previous existing cephalosporins, third generation or fourth generation cephalosporin, or maybe carbapenem. But having said that, we just have ceftazidime, avibactam only, which is available right now in India. We don't have ceftazidime, tazobactam, which is rampantly available. Viborbactam we are not still received. Relebactam is not available. So whatever we have, we just need to, have our experience with that. So I'll just ask Dr. Bhavnish, what is your experience using ceftazidime avibactam, and then what all group of this bacteria, what all group of patients, where do you use this? And do you add, as Madam has mentioned, we had used this with a Jugaad and Astronam, we've added for certain group of, resistance. So what is your experience in that?
Thank you for this question. And this is a promising combination, actually, third generation cephalosporin, beta-lactam and beta-lactamase inhibitor we are using right now. And in addition to this, if you are using ceftazidime, avibactam plus aztreonam, it is much more promising. If we see the AMBLUS classification, A, B, C, and D, 4 classes, because of the avibactam combination, it is very much stable for A, C, and D class. If we are adding the avibactam also, the class D, it will be taking care of. Regarding the indications, if you see the ceftazidime avibactam, it can be used in the complicated urinary tract infection where OXA 48 and KPC producing CREs. If you are adding more ceftazidime avibactam plus aztreonam, they are also for metallo-beta-lactam class B, they are taking care of. And regarding the indications, yes, complicated UTI, pyelonephritis, you can use HAP and VAP are also the indications. Skin and soft tissue infections, very promising, definitely. So as per the guidelines also, all the complicated infections, whether it is pulmonary infection, urinary tract infection, skin and soft tissue infections, we can use. But the appropriate usage and timely usage is important. Okay.
Dr. Bhavnish, we have seen at times, I mean, in the BioFire, we just received a report wherein a bacteria is there with a colony count or copy count of maybe 10 or 7, and then we've got resistance mechanism, which is just mentioned NDM. So shall we go with ceftazidime, avibactam, aztreonam? The patient is quite sick, of course. Or shall we just go with aztreonam, or shall we not use any of these combinations? Shall we think of something else?
No, if we are getting these type of reports, then we can go for ceftazidime avibactam combination in these type of patients. And if we are talking about the AMBLUS classification regarding on that also, newer generation or new drugs like combination of avibactam and aztreonam, they are also coming for this also. So we can use this thing, but better till now. And as per my experience, ceftazidime avibactam and aztreonam combination is really promising to things.
Right, great. Yes, ma'am, please.
What we have seen is ceftazidime avibactam or azithromycin avibactam, and when an organism is NDM, 20% patients may or may not respond because synergy is negative. That's what we have observed, and it's very common for E. coli and Pseudomonas, which is coming up. Although we had seen azithromycin works for Pseudomonas, ceftazidime works for Pseudomonas, but they have been negative as synergistically. So I really don't know. Practically, people can tell like how it really works when it's showing synergy negative.
For
But
the larger benefit of the house, I mean, just need to understand if it all synergy is positive. So shall I give ceftazidime avibactam plus aztreonam, or maybe avibactam and aztreonam only?
So either of the two will work, but then it doesn't, this azithromycin avibactam combination does not work for Pseudomonas at all. They only say that it is for E. coli and Klebsiella. So when you have Pseudomonas, ceftazidime avibactam plus azithromycin, that you have to do it.
Right.
Azithromycin avibactam is not going to work for Pseudomonas.
Fair enough. Right. Thank you. So there is another new group of antibiotics in the form of Sidrophos palosporin. There is a, great buzz about this cefidericol. So is it the new antibiotic of the future? Sir, what exactly is the buzz about? I mean, Dr. Gurnani, sir.
Certainly, this is a different, absolutely different class of cephalosporin, Sidrophore. Sidrophore, we all know, just like human beings, the bacteria also thrive on iron mechanisms. What this cefidericol does, it actually hacks the iron transport mechanism of the bacteria. It works like a Trojan horse. So what it will do is it will bind to a extracellular iron, and this helps him because it bypasses the pouring channels normally. So through this mechanism, it will enter the cell, and then from there, once the Sidrophore dissociates, it has the capability of preventing not only replication, but allowing its even efflux mechanism. That's the best part of it. Even the efflux pump mechanism, that's inhibited by once we use the Sidrophore. And once inside the cell, it is going to combine with the PBB3 especially, penicillin protein. And that is what helps in cell lysis and further cell death. However, since we do not have the first-hand experience, what the ITSA and other guidelines explain, this does not find a place as a monotherapy except in UTI. It got FDA approval for HAP and VAP, but not as a monotherapy. ITSA doesn't support it as a monotherapy, though it's a first-line drug. It says finds a place, especially for Acinetobacter, especially for Stauromonas, Steatoformonas, multifolia, and even Burgdorferi. First-line drug, but find as a combination. You either combine it with an TMP SMZ or with a minocycline, or sometimes even with the polymyxin if you're treating with a HAP and VAP, but not as standalone. Otherwise, yes, it works against KPC, it will work against Acinetobacter, it will work against so many other bugs.
Right, sir. Right, sir. So actually, this antibiotic, I mean, should be preserved. If at all, we can spare this. If at all not, yes, it should be used only and only with a combination, as you mentioned rightly, maybe with aminocycline or maybe with polymyxin B.
If I may quote the ITSA 2024 guideline, use it when you are exhausted all the antibiotics.
Absolutely. Right, sir.
There's a line it specifically uses.
Agrawal, sir, so we do have some new tetracycline as well, which are there. So what are those new tetracycline and what is exactly the where is to use these new tetracyclines, sir?
See, I think I am not the right person to answer all these things because these are the cases because we have if you have an infectious doctor with you, they are the person. So I would like to Dr. Neelam only will answer the will tell about that.
Fair enough.
Yeah.
Yeah. So we do have, you can see cycline is there, but then thing is ki, how promising it's going to be, we really don't know because it's against carbapenem resistant Enterobacteriaceae family. It can cover, they say that it does cover anaerobes. So ideally it should be used as a single drug because whenever we are going even for surgery and we are suspecting post CT-RT patient is there, if I'm talking about the our patients, the onco patients, and if it is like after post CT-RT when patient is all immunocompromised, there is a fear that they will acquire some carbapenem resistant bug also, and surgery is also like delayed. आपके 4-5-6 घंटे लग गए हैं. You want to start with all this. But then monotherapy, I really don't know that it will work or not because we do expect carbapenem resistant bugs, and what we have seen in our scenario, it is basically NDM. Oxa is hardly any, 10 to 20% is there. And NDM Oxa combination is also 10. IMVIM normally we don't have in our scenario. And KPC is also, I've never seen it in my 32 years of experience that KPC has also been also isolated. So I don't know whether it is really going to be promising. It'll work as a monotherapy in ICU setting or not.
I'm sure we don't have any personal experience with this, is it? We don't have the with the rivacycline or metacycline. Do we? We don't have any personal experience using this thing. Right. So aminoglycoside, ma'am. So what all the new aminoglycoside we do?
Yes, also like it is against carbapenem resistant Enterobacteriaceae family. It's against NDM, but it doesn't cover all.
Yes.
So once it comes into the market, like how will we benefited? I really don't know. Complicated UTIs definitely it cannot be, but otherwise like this is also something new. But then coverage against NDM is more important because whole Asia is loaded with NDM bacteria.
Absolutely right. So when we talk about aminoglycoside plasmomycin, so the new antibiotic which is there. So what all the indications? I mean, how does it help us in in the armamentarium of existing aminoglycosides?
I mean, it'll come out to be better. Otherwise, like Amica Genta, it's there. It is sensitive. When we talk about, obviously, you cannot use it for carbapenem resistant bugs. We don't have a actually hard to do it. But what we have seen is over the years, since it is not being used, they have become better as compared to even imipenem and meropenem also. Do we need really an aminoglycoside at their place? It's to be thought about. Because they themselves are sensitive if we use. Only thing is we don't use it. We think that it has always been a resistant part, but they are sensitive. Even cotramixazole has been sensitive now for even carbapenem resistant Klebsiella. But only thing is we don't have a heart to use it. That's a problematic.
Absolutely, sir. So you being clinician, sir, Gunani, sir. So we always tend to avoid aminoglycoside. I mean, in those group of patients who are sick and having a multi-organ dysfunction, we tend to have their creatinine, which is somewhere around hovering around 1.4, 1.5. So given a scenario, if at all we have to use aminoglycoside, would you like or prefer to use plasmomycin because they claim the plasmomycin has got less chances of nephrotoxicity?
That's very true. It's not 100% nephro safe also. Let me share with you.
Sure.
But what interesting thing I found was like in my hospital, I have not used in more than 3 patients. CRE, UTI was the only indication. We were just waiting for, although they are extrapolated to chest infection also, but I don't think it's FDA approved. It's only extrapolation. Main indication was CRE, UTI. Interestingly, despite this drug has not, it's been hardly being used in our hospital, most of the klebs I found resistant to plasmomycin.
Oh my God.
This was my surprise. I don't know why.
Okay.
Most of these, yeah. Please.
Not recommended even for sepsis. Like it's just UTI and that's all. Carbapenem resistant.
The
UTI,
product, product insert does specify about E. coli and Kleb. E. coli is sensitive, certainly. But some of the patients, recently I've used 2-3 patients who were in the ward. They are being seen by not less than 10 physicians. They have received every damn thing. Even before the culture, I had no option. But there's somehow they forced this patient onto us into one of the intensive care unit. Already 10 patients, 10 physicians have seen blah, 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 and he received every damn thing. We had no option just to drop plasmomycin. And to my surprise, the patient responded. So maybe it finds a place where when nothing is work, maybe it works.
Nice.
Later on, the culture came, it was an XDR E. coli, but sensitive to plasmomycin.
Right, sir. Fair enough. So, Dr. Bhavnish, we would be a bit quick from now on. I mean, what are the gram-positive newer antibiotics for, resistant gram-positive bugs?
We are having enough bullets in our revolver to fight with the gram-positive infections like vancomycin or linezolid and everything everybody knows. So, but for the newer generation, definitely fifth generation cephalosporin, they are considering it as a fifth generation. So ceftaroline and ceftabiprole is also available for MRSA coverage. Levodopa, one of the drug which is also promising. We are using since 2 or 3 years. And skin and soft tissue infection, osteomyelitis, and MRSA coverage it is giving. And newer drug like neotetracycline group, they are also very promising. And tadalafil, it is single dose and less melotoxic as compared to the linezolid group. So we are having newer drug gram-positive coverage, and they are enough to cover the MRSA coverage as well as streptococcus type.
So tadalafil does promise about the day dose, but it does not come in the parental form. It is right now available only in the
tablet form. It is available in the tablet form. And dalbavancin also, it is a weekly dose. Dalbavancin.
Right. So patient, I mean, coming to the dalbavancin, yes, I mean, there was some study, I mean, some, doubts or concern which I was just going through. I had a discussion with one of my colleague. So dalbavancin, of course, it does have a great potential for MRSA, for Staph aureus, but giving a dose which is once in a week, perhaps may not do the justice to the patient, wherein a patient who is perhaps requiring a gram-positive coverage, we are actually giving it empirically. So skin soft tissue infection. So we right now do not know whether this is MRSA, whether it would be not responding to levodopa, vancomycin or something, or maybe daptomycin. So how do we justify dalbavancin over there in this group of patient?
Weekly single dose, definitely it is very difficult to justify when patient is sick and admitted in ICU, because everybody knows that as a critical care specialist, that MRSA coverage, MRSA in shock patient admitted to your ICU and single daily dose, definitely it is very difficult to convince yourself also.
Right.
Okay, because already we are having very much drugs in our ICUs to cover the MRSA coverage. Even high dose of daptomycin can also cover all these things. So I don't think so. I'm not having very much experience with the dalbavancin, but it is very difficult to.
So as Madam has also mentioned, because I mean, we are right now in India or Asia, we are focusing primarily on we are having a problem with the gram-negative infections, not with the gram-positive ones, which is a problem with the West. So we'll just come to the Neelam ma'am. Ma'am, what are the emerging antibiotics we have, which are going to shape the future of antibiotics?
Yeah, are you sure that like there are sulbactam, durvalactam is there, cefepime. I told you it's all basically that we've been adding adjuvant to all those, the pre-existing ones. So when we add adjuvants, see for the first time when sulbactam and tazobactam came into the market, it went on for a longer time. But when we had later on the other combinations, it didn't work for a longer time in our scenario. Now, when it comes to gram positive, I don't think so we need anything. Because when we prepare a data, what we see is 90% is gram negative and carbapenem resistant bugs, the number is increasing each year. What we say, it's always been like going up the ladder kind, but when it comes to gram positive, we hardly have MRSA and VRE, you hardly see in the reports. 5% maybe, or at the most maximum, if you go ahead, like in summers, it increases, it's up to 10%. So what we exactly need is we don't need antibiotics for gram positive bacteria. We need basically for gram negative, and that too, like which covers the carbapenem resistant bugs, because our list is going up the ladder. Every year we find a lot of patients are rising, and with the scenario like in our hospital, what we see is all the patients are immunocompromised. Majority they are on prophylaxis, oral cephalosporins, quinolones, whatever is over in the OPD level itself. When they get admitted, obviously you start with beta-lactamase inhibitors, and then you go ahead with the beginning like ertapenem and all, and then finally you find imipenems, and then nothing is there. So they have multiple visits, but after 3 or 4 visits, you find that there is nothing. Now you save the patient when it comes to oncology, but when it comes to infection, if he has something and he loses his life, that's very bad. So basically, I think, like antimicrobial stewardship, which is more important rather than focusing. Obviously, we need to focus on new antibiotic also. I'm not saying like that, but what we need to focus is on the antimicrobial stewardship, because what we have, we need to save it. We have just been adding adjuvants and nothing that new molecule is coming out. So we want to discover new molecules so that it works for around 10 to 15 years or 20 years, and judicious use has to be there. Even if we come away 20 new antibiotic and they are resistant in 2 years itself because we have over-the-counter sales, it's not going to work.
Very rightly said, ma'am. So, I mean, this is a major problem. I mean, we are not being, focused for the Indian perspective or Asian perspective, wherein the problem is primarily the gram-negative infections, and we are not getting a new molecule. So, as Sir has rightly mentioned, so there are 80 to 100 drugs which are being, under pipeline in the phase 1, phase 2 trial, but we are still not getting a new class of antibiotic. We are just having 1 or 1 to 3 or 3 to 1 has been added. So this is a new molecule, again, a sub BLI, which has been added to the existing, and it's shown to be having a promising effect. So this is where we have got a problem. The superbugs are outsmart, and they outsmart the antibiotics. So Gunani sir, how shall the future antibiotic development be shaped? How should we use the judiciously the existing armamentarium of antibiotics? What is your thought, sir?
See, it's not just the future of antibiotics as such. It's the future of antibiotic use.
Absolutely.
Every hospital should have some kind of a strict antibiotic stewardship program. I'm sure most hospitals have, but are we really following it? Following means you should have a daily defined dose for each of the antibiotics. In our hospital, we are monitoring at least 8 antibiotics, and every month this data comes to the HIC, of which I am the chairperson. And we, of course, we do not ask them not to use this, but we send them a letter. At times, we invite them to the meetings. So look, your daily defined dose for such and such drug is increased this month. So kindly rationalize the use of this antibiotic. Then secondly, maybe early detection, like PCR syndrome. BioFire is available with us. It just takes 2.5 hours to get the results. It might not show you the culture sensitivity, which may take time. At least gives you an idea about what the bug. So you are not just using a very broad spectrum. You can narrow down your spectrum. Very important. Third, maybe you are early diagnosed. In times to come, we are going to have a lot of laser-based detection of the biomolecules, which we call as the CRISPR techniques.
Absolutely.
So this technique, it's already in the development in engineering. Like BioFire, we only thought of 10 years back. Today is available. So maybe if this technique is available, it's going to tell you the biomolecules, and within let's say a couple of hours, you can detect what bug you are using, and it's the genotype and the phenotyping, which will be available to us. They will help you in deciding what antibiotic to use early, because carbapenems are practically gone. If the patient already spent 6-7 days in ICU or comes from some other hospital, that's going to be with you. And in times to come, maybe we have why just antibiotic? You can have so many non-antibiotic usage also, which I think somebody else.
That's my question. Next question, sir, which you've already enumerated to. So, Dr. Bhavnish, so this is what I was taking you to. I mean, shall we rely only on antibiotics? So, shall we think of something else? We have to think out of the box for some revolutionary thing which can perhaps has a antimicrobial role, and then or existing antibiotics shall be used smartly. So as Sir has mentioned, so CRISPR or bacteriophage, and then molecular antibodies and microbiome therapy. That's what you perhaps have to be seen in the future.
Traditionally, we are giving antibiotics to kill the bacteria and to treat our patients. So we have to change our focus now, because already we are thinking about newer antibiotics and resistance again and again. So now the non-traditional antimicrobial or antimicrobial therapies are there, like bacteriophage therapies, they are monoclonal antibodies they are developing right now, or CRISPR microbiota. Microbiota is not a new thing. Actually, it is using since long time, but definitely it's a new thing for us we are using right now. Or the virulence therapy for the quorum sensing or quorum quenching rather, because quorum sensing is already they are giving signals and lot, and as the microbial bacterial load is increasing, quorum sensing is increasing, we have to do the quorum quenching. And the biofilm, definitely we have to consider the biofilm, because it is very difficult to treat, 10 to 1,000 times difficult to treat rather than a normal bacteria. So whether you are using EDTA, you are using nitric oxide, you are using or multiple other therapies to disrupt the biofilm. So there are multiple therapies available, but still under consideration and still experimental these days.
You rightly pointed out. So we have to not only think for the biofilm, we have to think and then use a newer way to treat and then streamline our therapies. So I'll just ask Dr. Mutit sir, can the antibiotic be used differently in oncology? Primarily coming to the oncology, so do you think they have got some role to treat, and then can it be repurposed in the case of oncology?
See, in oncology, when we deal, it is the same scenario how we treat in a normal patient. Only thing, these patients are immunocompromised as compared to other patients. So these patients, that's why the threshold of starting antibiotic
I'll just take
is
two
lower
more
as
minutes. Thank you.
compared to other normal patient. So how we look into this is similar to as you treat other patients. But for neutropenic patient, these patients are really critical where we need to start the antibiotics faster. For sepsis, it will be maintained like surgical sepsis in oncology because the parameters of the patients, because of immunocompromised status, the response to it will be lesser as compared to normal patient. Otherwise, it will be similar to how you do it for the normal patient.
Sir, any thoughts about the oncolytic viruses? I mean, can they be used for treatment of a patient with they come with a tumor, they come with a cancer. So these oncolytic viruses, which can be used, I mean, along with antimicrobial therapy. So any thoughts about that?
So I am not aware of this, but I think this must be going on.
Yes, so
Back to
this is
phage
the
therapy.
latest 2026
Yeah.
Journal of Young Pharmacists, wherein they could see this oncolytic virus. They can directly attack the tumor cells, the rogue cell, and then they destroy it and then they enhance the immune system. So that would be perhaps the future of antimicrobial therapy or therapy in oncology. So I'll just sum it up with the future of critical care antibiotics is moving towards a targeted therapy within hours, as Saras mentioned about taking the, maybe BioFar, PCR based or Malditov, and then giving or, addressing the targeted therapy. And then precision dosing should be done with the PKPD and target dose monitoring method. Non-antibiotics alternative shall be looked forward and looked for, and then AI-based stewardship can be done. So believe you me, so we have enough antibiotics, but we have to perhaps repurpose them and then use them judiciously and smartly. Thank you. Thank you, panelists. Thank you. Is there any question? We're happy to answer. Thank you, ma'am. Thank you, sir. Thank you.
I'm sure no one is having post-lunch slump due to such an engaging talk. Now we are going to pivot to a new topic for panel discussion, role of biomarkers in managing sepsis in cancer patients. May I request Dr. Ashutosh Bharadwaj, Director, Department of Critical Care Medicine at Dharamshila Narayana Super Speciality Hospital, Delhi, to moderate the session. Sir, please kindly start the session and introduce the panelists.
Thank you very much. You can just pass it off quickly. Huh? Yes. So we may call upon our esteemed panelists, Dr. Rakesh Garg, Dr. Pankaj Goyal, Dr. Vishal Bhatnagar, Dr. Anish Gupta.
Yeah. Dr. Rakesh Garg
Please
is a
join.
professor in names, my senior from college. Dr. Pankaj Goyal, our medical director at GCI, in medical oncology, Dr. Vishal Bhatnagar. He's a head at Yashoda, and Dr. Anish Gupta, my friend from Max Gurgaon.
So good afternoon, everyone. I know it's not an easy task to be seated at this time of the day. Our topic is very important from the day-to-day perspective. When we work in onco ICU, sepsis is very, very common. The reason we all know who work in the onco ICU, these patients are very frail. They have all sort of therapies. They have toxicities because of chemotherapy, because of radiations. They are, the muscle mass is lost, and then immunosuppressed and immunoparalyzed state is also there. So the chances of getting infections and the way they behave with the infection is very unique. So to help us in diagnosing, to help us in risk stratifying these patients, that how do we put these patients in high risk category or low risk category, how can we help ourselves in treating those patients, and then also biomarkers, if we talk, can be used to do these stewardship for antibiotics. So these are our esteemed panelists, and I have just told you the brief of the biomarkers. So as I told you, cancer patients have high chance of infection. It is confounded by a lot of factors. Cultures are often negative or maybe very delayed, may come negative also. The biomarkers aid when used in such scenarios can help in initiating the antibiotic, about deciding whether to stop or de-escalate. And then, prognostication also, very important thing. One of the very important thing which I find in my practice is the prognostication. That a patient comes to you with a PCT of say 3, and then on treatment you resend the PCT after 2 days or 3 days, and it comes down to 1.5. Then you can tell the attendants that maybe some effect of our therapies is there. So the goal of this panel discussion will be to give you some ready meal, that how can you use these biomarkers in your day-to-day practice. So I'll open this discussion to the esteemed panel. The first question to Dr. Rakesh Garg will be that what are the usual biomarkers which you use in your practice, and which is the one which you like the most?
I think liking is a little difficult to say, because as you rightly mentioned in the beginning itself, when we talk about onco-critical care and cancer patients, still yet we do not have the marker which will predict the sepsis or which will show the response to the sepsis in a very subtle way. But if you see, yes, we have markers. And as you rightly said in the beginning itself, when we use the, as we say, multimodality management, so same is for diagnosis also. So you have to use multi-pronged strategy for diagnosis. And when we say biomarkers, for example, to begin with, procalcitonin is the most affectionate one for all of us, which is being used as one of the marker, though a specificity or sensitivity around 60 and 80%, and it could detect with area under curve of around 0.78. This means it has a somewhat moderate prediction for looking for the sepsis. But then the other biomarkers which are again being used as a supportive measure, C-reactive proteins, very dose, time-tested one, sensitivity specificity again not very high, but yes, it supports something. Use of markers like lactate levels, they do support it. But now, if you see the recent research, there's something which is coming up on two aspects. One is when we say cancer patients, they have altered immune response. It could be immunocompromised. So we say either it is immunosuppressed or it is immunomodulated. So even the cancer therapies, many of the cancer therapies will lead to the elevation of various cytokines, whether we talk about interleukin 6 or we talk about tumor necrosis factor. These are though biomarkers, but they will be altered not only by sepsis, but the presence of cancer per se and the treatment. Because now cancer therapy is just not chemotherapy. People are working on other therapies which are called as in a blanket as immunotherapy. So when those therapies are being given, they will be altering the immune response also because they are targeting the immune markers on the tumor cells. And hence, we will not be able to have a subtle response when we're talking about those immune aspects. So chemotherapy nowadays, if you think in even in India, in a major sector, almost 40-50% will be getting targeted therapies or immunotherapies in some form. So these are altered. So we are looking for something more specific like presepsin probably, which will come up and they will be having little more specificity. But these markers are still in non-oncology setup. We do not know how they will support us diagnosis for patients who are immunomodulated. And obviously, interleukins and all those cytokine group of markers, especially when I talk IL-6 and TNF-alpha, they are important. But yes, all those markers have their own limitations, but still they are very helpful. And as Sir asked, which is more affectionate, I will put it in a way, say procalcitonin is good one. Interleukin is another one which is supportive when we want to start therapy. And CRP also sometimes works. So CRP is a poor man biomarker. Procalcitonin is probably a rich man biomarker, but yes, that's the grading.
Thank you very much. A very important point has been raised by Dr. Rakesh, which you all should keep in mind that the immune state is totally modulated. Now, the values and levels of biomarkers which you get in the general ICU population, you will not get in the onco population. That will be altered. The reason is that some or the other kind of chronic inflammation because of the presence of cancer or the treatment is going on in the body. So that is a very important thing. Now we move on to the second question. And it's about how you compare, the most available biomarker, which are PCT and CRP in non-neutropenic adult cancer patients. What is the comparison if you see in your practice, Dr.
So at times the patient will come with a CRP report, which we have not asked. So the lab will do it just like that. It will be raised and the patient will have a concern, so CRP बढ़ा हुआ. So now and then we see that it बढ़ा हुआ and we know that there is no symptom, there is no fever, there is nothing. So at times we have started thinking it is something like ESR. बढ़ा हुआ है कोई बात नहीं. So and another thing, this procal, it's just like the tumor cell markers. They are suggestive, but they are not diagnostic. So as sir has already summarized everything, around 75 to 80% sensitivity specificity. So there are instances patient is fit and fine. Someone has asked for procal is sky high, but it has no relevance in that case. So I think in cases where we are having some confusion whether sepsis is there or not, they we use them selectively rather than using them left, right, and center. So if the patient is having say fever, patient is having some hypotension, sepsis is evident. So maybe for monitoring it can help how to tune our antibiotics. We possibly change to tablet form or something like that.
Thank you. Yeah, that's very true that nothing can override the clinical application of your mind. Clinical acumen is very, very important. You have to see the patient in whole context. No value can tell you whether your patient is having single value, that your patient is having any kind of infection or not. Dr. Vishal, when we see patients of febrile neutropenia, how do we risk stratify those patients? One is the very common MASCC score, risk stratification score, where we categorize patients into high risk, moderate risk, and low risk. And we decide whether to start the therapy in the OPD, the antibiotic, or the patient needs ICU admission. How can you place PCT is in those scenarios, in risk stratification?
Like just you rightly said that MASCC is the marker. It's not a marker. It's basically the scoring system. So if the score has the points and it's less than 21, that's the high risk, and if more than 21, low risk. So it is only for the scoring, but it also has an importance. But if the patient is having the bloodstream infection with febrile neutropenia, so procalcitonin is the choice that we will go for that for the as a point of view.
For bacterial. Thank you. Yeah. So as you can see from this slide, that PCT in one of the studies has outperformed MASCC for bloodstream infection in febrile neutropenia cohort. But the better way will be to combine things, combination, like, clinical, microbiological. But if we stick to the biomarker only, so PCT and lactate we get, anyways in the ABGs. So PCT plus lactate combination can serve you that purpose. And one of the retrospective hematologic malignancy study, it has showed that PCT has performed better in neutropenic patients as compared to CRP or pre-sepsis. So in febrile neutropenia, maybe PCT will be of little more help as far as the biomarkers are concerned. Yes, please.
So if we see this data, so for the research purpose, we need to understand the critical appraisal for a research. That's very important, because when we want to do research, we want to prove one surrogate marker is useful. And that's why research will talk about a single marker for the prediction of sepsis or not. But if you see in actual life, we have to use combination, which you rightly mentioned, though the study says. And second concern is, if I remember correctly, the study was coming from the Western population, and the type of patients that we have and the type of flora we have, they are
Very
quite
true.
different from the Western population. So though we say in this study, the PCT was associated better in predicting it, but there is no confusion. So we should not have a message that without seeing a patient with no hemodynamics, no imaging, no looking for source of infection. In cancer patient, one of the most important aspect is to look for the source of infection. Majority of time, it will be generalized bloodstream, but at times it will also be focus collecting somewhere.
Yes.
As small as sometimes in liver, subdiaphragmatic area, or it's a gynecological malignancy, it will be in the adnexa. And just clearing them, draining them is equally important. So source of infections becomes important.
Very, very important.
So
First thing, cornerstone, yeah.
Yeah, so it has to be a combination, whatever study says. But I think final message which sir is again saying again and again, it will be a combination of a score like CISNI or MSCC, along with biomarker, along with hemodynamic parameters, along with
Microbiology,
microbiological
radiology, your
assays.
clinical acumen, patient's history, everything in, toto will serve you.
Even in the survival sepsis campaign, it's there that not about the only the onco, even if the suspecting sepsis, the primary
Yes.
source control is the must.
Yes, that's
initially.
cornerstone. That's true. So, Dr. Anis, do you use in your practice any kind of PCT guided algorithms to de-escalate the antibiotics or shorten the course of antibiotics?
So if you ask me whether it's only procalcitonin guided, then I would say no. If it is in combination with the clinical improvement of the patient, then definitely yes. So again, I think we are coming back to the same point, whether Procal should be used only alone, and is it the sole biomarker or some sole test that you can do and then decide on reducing the antibiotic or de-escalating the antibiotic. So the answer to that would be no. Now coming, and even the surviving sepsis campaign actually says that use procalcitonin with the clinical picture of the patient, not only Procal alone. Now, coming to a cancer subset patients, the studies are actually very limited and you do not have too much of data, because procalcitonin itself increases in some oncology cases, like thyroid cancers, maybe lung cancers, even the intestinal ones. So, if you're just going to use Procal to decide whether you reduce the antibiotic dose, difficult. Some studies like how we have the Procan also over here. The Procan study was it was an underpowered study. It did not show any difference or change in the arms of standard care or procalcitonin, the guided reduction in antibiotic. So it did not actually show that using Procal will help reduce the duration. But when a meta-analysis was done, it did show some benefit, mostly but this was by about a day of therapy. Now, all this literature again is from the Western world, where things are managed by insurance companies and hospitals. When you talk about our scenario where procalcitonin doing daily for a patient, which is costly, 3,000 to 5,000 rupees, I am not very sure how we'll be able to justify that also and reduce the antibiotic. So I think you'll have to individualize it for your patients and see where it's really required, and then probably take a call. But yeah, if asked, then it's procalcitonin with the clinical picture is what should be taken into consideration still.
And then, if I may ask from people in the audience, how many times do we really change or stop the antibiotic by seeing PCT? Actually, we don't. It is always a, collective things which we look in the patient and then we decide after a lot of deliberations and discussions.
Help sometime in the de-escalation of the
It helps.
antibiotic. Yeah,
It definitely helps when you see these serial trends.
Serial-
Single value will not serve any purpose. Maybe, there are a lot of studies on PCT in general population where they have targeted 50% reduction, absolute values 0.5, and then they have come out with some, good data. But there are, as our esteemed panelists have repeatedly pointed out, that we don't have data from the Indian population. So we cannot generalize. Replicability is an issue when we talk of these trials. But again, we can have some guidance from these, and we can individualize our practice as per these guidelines and seeing our patients and having our experience. Dr. Rakesh, single value, what we talked, single versus kinetics, single versus trend.
I think this is principle of life. You cannot judge a person at a single go. We have to interact with him to know how the person is. Same thing will be for our biomarkers. Single value probably will give a fair idea that how the patient would be. Uh, Obviously, if you say procalcitonin level is 20, 25, 30, a single value has some meaning. But then if you want to see for the response, why we are talking about for cancer patients, because cancer patients, as I mentioned in the beginning also, we are using various therapies which will affect the impact on those biomarkers. We use a lot of steroids, which is part of the cancer therapy itself. So they will immunomodulate. Patient may be a bone marrow transplant. He is already immunocompromised. Hematological malignancy, they will behave differently. These patients may also have certain therapies, as I mentioned in the beginning, immunotherapy and targeted therapy. So they will behave differently. So single value, that's why will not have impact. But
True,
yes,
true.
trends will matter. As all the panelists mentioned, we have to see the trends for escalation as well as de-escalation.
De-escalation. As you very rightly said, the values also you have to look in context. Suppose a patient is coming to you with AKI, with PCT of 20. I won't believe that. That will not be the right reflection of the amount of infection which is there in the patient body. So that you have to think. And then how much reduction is there? It has to be a significant reduction from the previous value. So hovering of PCT 3-4 values around the same will not serve any purpose. Dr.
And when
Pankaj.
we interpret, I mean, just to point out, we should also know their half-lives. Sometimes, say, for example, when you talk about PCTs and half-life of somewhere around 20, 24 hours. So getting a morning, evening PCT will not work much because it's not useful. Similarly, if you talk about CRP, its half-life is somewhere around 36 to 48 hours.
Yes.
So getting a daily CRP level will not help us to actually look for the response.
True.
If you look for the newer markers, they have a half-life of 4 to 6 hours. So they're in fact better. When we say febrile neutropenia, they crash within 24 hours. So that's why people are looking on those newer markers so that even initial, when we say 1 hour bundle, 4 hour bundle, the response can be seen.
What do you have to say about the combinations of
So
all?
I think if we have combination of the tests, we have more confidence what we're dealing it. Because there will be patients in which the interleukin 6 is rising, PC10, CRP are not that high. And probably we can predict that probably these are the patients who are going for cytokine storm, like we're using this CAR T-cell therapies also nowadays.
COVID, yeah.
And we know that when we have to escalate and start thinking or arranging tocilizumab in such cases. So I think in hematology analysis, it makes more of it. So we are not using a lot of these tests into solid tumors, but hematology analysis, I think this will make a difference.
And then cost also you have to look. Cost is a big issue. Availability of those markers in our centers, in our resource limited setting is a big issue. With a lot of antimicrobial resistance, which we all face, and more so in oncology patients, how should we use these biomarkers in the context of AMR? Is there any specific thing you want to add, Dr. Vishal, to this?
In context of the AMR, biomarkers only supports, but it cannot replace the things that we have to, that Dr. Rakesh previously said, a source control, that is important, and according with the culture, and not even a single dose of the empirical according to the biomarkers.
Very true. Yeah, so they can support you in all the treatment, but cannot replace the clinical findings, the clinical things, the X-rays you see, source control, Dr. Rakesh told about you. It is very important to look for the source. That is the first and foremost thing. And then cultures, which are the gold standard. Biomarkers are not the gold standard. Cultures are the gold standard. You should always track those cultures. Dr. Anish, PCT stewardship. What are the pros and cons? PCT, if used as a tool to steward antimicrobial in our hospital.
So I think you'll need PCT as a tool if there's no antibiotic stewardship in your organization. And I think now with probably all the, I mean, we are so aware of antimicrobial stewardship, and I think everybody has their own programs in place. So PCT as for a stewardship program, definitely no. But yes, you can again use it in patients, individualize it. From an Indian perspective, there have been studies, very few studies that have been there. Some studies have shown that using PCT as a tool to again stop the antibiotics or de-escalate care, it helps as a guide. But then if you go into the depth of those studies, the problem is like there was one study which showed in the control arm there were more patients of septic shock as compared to the PCT arm. And then they showed a reduction in the duration of antibiotics and a de-escalation when PCT was used as a guide. So these are some fallacies which come in when there are studies which are being done. The another pre-post ICU study also, the thing is now that is there was the timeline before when PCT was done and then a later timeline when it was done. So the patient profile changes. So again, using it as a sole stewardship molecule or a marker to decide will be difficult.
That's true. But if you ask me, if I am given a chance and the cost is not the issue, I will definitely like to include this in our stewardship program. If cost is not an issue, that can be of great help. But as Dr. Anish said, there are a lot of caveats to it. So to conclude, these are the 5-step algorithm for biomarker guided sepsis management, which you can take it from here. Whenever you suspect sepsis, never delay the administration of antibiotics. You have to hit hard and fast. Do not wait for the cultures or biomarkers or anything. Just send the cultures and give antibiotics. And then you have to know your epidemiology, your antibiogram. If you are not getting antibiogram from your hospital infection control team or microbiologist, you will not be able to do justice to the to rationalization of antibiotic usage. Then baseline biomarkers, as whatever you have in your center, whatever resources and facilities you have, you can go with that. You can use them, definitely use them, but you have to see it in the context of the whole picture. Risk stratification is very, very important. So you can combine maybe this, PCT plus lactate. You can combine, CRP with MASCC, the clinical scorings, the biomarkers, the clinical picture, everything you have to take in consideration. De-escalation will not happen, as I told you. Nobody stops that the PCT is normal and we stop it. Nobody does that. But we take help from the biomarkers. And if you put the Indian lens, you have to choose empirical antibiotics. This scenario here is very different. We have our set of problems. We have AMRs very high. We have huge gram-negative infections. We have NDMs. We don't have KPC. So all those things you have to keep in mind. Use biomarkers to shorten the exposure. Lot of audits are required, so it's a long journey, but you can start the journey. These are the resources. Thank you very much for the patient listening, and thanks for a very constructive and fruitful discussion, esteemed panelists. Thank you.
Thank you. Thank you. Thank you so much, sir. Thank you. Thank you. Thank you.
Let us thank our moderator and panelists for that insightful discussion with a round of applause. For our last discussion of the day, and probably the most sensitive one, working as a healthcare professional at a cancer institute, end of life care and palliative care, please join me in welcoming Dr. Arina Bhom Chaudhary, Director, Professor, and HOD, Critical Care Medicine, VMMC in Safdarjung Hospital. So please welcome all the panelists to the stage.
Thank you very much. It's the end of the day, and on a note of with thanks to the esteemed organizing team led by Dr. Rajiv Chawla sir, Dr. Prashant, Dr. Bikram Jyoti, and all others in the team for their kind invitation. And the subject on which we are having this panel discussion is the end of life care. And I invite my panelists, Dr. Can you see the list? Dr. Devan, Dr. A.K. Devan, Dr. Prem Sagar, Dr. Kingshuki Jain, and Dr. Harsha Agarwal.
Prem Sagar, I think, is gone for some other meeting today.
Welcome you, sir, for sparing this time on a weekend. And so very briefly, we are going to discuss and we will touch upon the key issues which pertains to end of life care and the practice of end of life, and palliative care no doubt goes hand in hand. So it is not possible to separate those terms because of obvious reasons. But we will just go through where we stand today. By using this case vignette, let us go straight into the case. A 75-year-old male, diabetic, hypertensive with ischemic cardiomyopathy with an EF of 30% is admitted with septic shock due to community-acquired pneumonia. Despite 14 days of maximal ICU support, which consisted of ventilation, vasopressors, RRT, culture-directed antibiotics, he develops refractory shock with multi-organ dysfunction and persistent high lactate. MRI brain shows hypoxic ischemic injury with no chance of meaningful neurological recovery. Prognosis is considered extremely poor by all the treating intensivists. There is no two minds on that. And there is no documented advance directive from the patient. So sitting in here in 2026, is it possible for us to let go the patient peacefully despite being safe legally? I will start with Dr. Devan, sir.
More a legal issue, but we face such problems day in and day out in ICUs and post-op wards. One thing you have written is no meaningful neurological recovery. If I say that patient is brain dead, then the person is legally dead.
No, patient is not brain dead.
Okay. And the other important point is you have raised is no documented advance directive.
Right.
So I think in today's context, short answer is yes, we can let the patient go with riders. We have some medical boards in the hospital, and we discuss the matter with the family.
Yeah, thank you, sir. I'm sorry to interrupt you there, but I will go to all those key issues. But I want to go to the other panelists, Dr. Kingshuki and Dr. Harsha. That do you differ or do you agree that in this scenario, with whatever the legal system, the legal safeguard, we can let go this patient peacefully without much hurdles? Do you differ or?
Can is actually, it comes later to should.
You want that it should be should?
Yes.
Okay.
In such a scenario, because let's have a vote here. We have so many medicos. In this condition,
Yeah,
who would
okay,
like
okay. I will put it the other way.
life here.
I will put it the other way. Yeah, actually, see, whenever when we talk about should and can, every doctor has his in its own capacity. Sometimes hurts you because someone told me, because I am also in that main committee which is looking after the government of India, that ये तो treat करने इलाज करने वाला doctor है और वो मुक्ति देने वाला doctor है. So nobody wants to identify himself or herself as a mukti giving doctor who cannot treat patients. Whose only purpose is to get such patients whom people are, अब कुछ नहीं हो सकता, आप इनके पास चले जाओ, ये दवाई ववाई दे देंगे, चले जाएंगे. Nobody wants to be labeled as a doctor who is only passing the
There are
patient the hand.
instances, sir, there are instances where people want mukti dene wala doctor. People in India, especially.
It may be, but no
Yes.
doctor as of now confidently says that I am a mukti giving doctor, I am not a treating doctor. That's what I mean to say.
Treatment. There also the treatment is there, intervention is there.
Exactly. There is a there. But getting identified that this branch, this palliative care, what is their purpose? They cannot treat.
No, here is
Exactly.
the difference.
So
Here
that
is
is-
the
that is-
difference.
we are
Here
going-
is the difference. There are lots and lots of treatments available under palliative medicine as well.
These are not curative treatment.
Not
When I'm talking about curative treatment. I'm talking about patient
In
treating
allopathy, how many
and patient getting cured.
afflictions can we actually cure? That
We are
is
not
the-
talking about, I'm not talking about the extreme situations.
Yes.
I'm talking about those reasonable situations or those circumstances when the patient has an option to decide that which doctor can cure him and
Definitely.
which doctor will raise his hands and say that
Definitely.
we can't do anything.
That
We
is
will give only comfort care. Yeah. So if we go by the evolution of jurisprudence in end of life care, you will find the first was the Aruna Schonbach case 2011, which recognized that withholding or withdrawing life support may be permissible in rare cases with a high court oversight. Now, this did not work well in India. A lot of times you send people to go to the high court, they will get a permission and the patient here in a utterly bad shape. So the common cause is an NGO. So they filed a case in 2018 versus Union of India, where the Supreme Court gave recognition and advanced medical directives, which the person in his sound mind has made it. And this advanced medical directives or living will, which we can process for withdrawal of futile treatment. Now, this was the first positive step to make the things which court suggested in 2011 in an easier way. And they gave that the right to death with live with dignity is as much is important as the right to live with dignity is the right to death. So under Article 21 of the fundamental rights, this was incorporated. This was further made easier in the common cause guidelines in 2023. I'm coming to that on how this medical board system, how the necessity of a judicial magistrate first class from which was necessary became just for intimation purpose. And of course, this year we saw the Harish Rana case, which was the first real-time implementation of passive euthanasia under the common cause framework, where Supreme Court expresses directly the withdrawal of life support treatment for a man. Harish Rana was in permanent vegetative state for 12 to 13 years from Chandigarh, and with a mandated palliative and end of life care. In the aims, we know that the patient passed away. I'm moving on to Dr. Kingshuki. What key principles does Supreme Court reiterates in 2026 in the context of Harish Rana when it discussed the 2018-2023 fallout, which we can directly use in our case Vignet, that we have just now seen?
It is not escalating the supports any further, first of all, and then we can even go ahead with withdrawal in case time permits, in case the patient, because we are actually not very aware of the patient's condition. It seems to be very grave. So in case time permits, then we have to go through primary board, secondary board, and then to the magistrate for withdrawing the support. So it is first not escalating the supports any further. Second is withdrawing the support.
So I'm coming to Dr. Harsha on that. So when we talk about non-escalating and when we talk about withdrawing, many people are quite comfortable in non-escalating. That yes, we should not escalate. The patient has no chances. Let him go. There's no point in using further. But when it contains of withdrawing, they're a bit reluctant that no, once you have put the patient on ventilator, you can't take it out. It's a crime. So how do you take that? Or what does the rules tell about that?
Sir, so basically in such scenarios, when we have to withdraw and we have to think about withdrawing, then the first thing is I must be well aware of as a caregiver, because it's a decision taken by a caregiver. They must be aware of about that prognosis is poor. Whatever we are doing is completely futile. We are not able to prolong the patient's life, rather we are prolonging the suffering. So whatever we are doing is rather prolonging the suffering of the patient. And when they are well aware of it, when they understand the importance of why it is not to be done, then they can take this consented decision.
I fully agree with you, Dr. Harsha. We are at our own liberty when we can rightly practice withdrawal by all the same reasons in which we are doing non-escalating. So withdrawal is permitted and there should be no two minds. There should be no hesitancy or no ambiguity in practicing that I am withdrawing. So if that, in case I have put a patient on ventilator, I cannot withdraw, it is now becoming my responsibility, duty to continue ventilating the patient till he passes off peacefully. No, nothing like that. So if you look into this, the editorial which was published and which quoted these lines, the judgment repeated certain principles that the specifics of the case are crucial in arriving at the decision. The focus should remain on the best interest of the patient, protecting patient dignity and autonomy. The patient should never be abandoned after withdrawal of treatment, so palliative care becomes mandatory. And it emphasized that euthanasia actions directed at end life continues to be illegal in this country. Now that, of course, has raised a few eyebrows, especially from the medical community. But what it touches upon very clearly is that the right to live with dignity includes dignity at the end of life. And that is a part of the Article 21 of the fundamental rights. And it says that passive euthanasia is permissible. That is withholding or withdrawing treatment. It considers it as a form of passive euthanasia. But active euthanasia and physician-assisted suicide, which in some other countries, that is considered as illegal. Now, I want to ask Dr. Diwan on this kind, that when we have made such a distinction, which the judiciary has made, doctors haven't made, between passive euthanasia and active euthanasia when you actually assist, which nobody actually does in our country. Now, is there any reason that we fall into the trap of this active versus passive debate, or that can it actually impede the practice of end-of-life care?
I think we are clear about active euthanasia, which is not permissible. So I think leave aside that.
So why should we call this withdrawing or withholding treatment as passive euthanasia? We can avoid that term passive euthanasia in the context of.
I think even passive euthanasia, if you go through the literature and I search the AI, that what is passive euthanasia in India, there are at least 4 categories of passive euthanasia also. It is involuntary passive, it is non-voluntary passive, it is some other 2 more categories are there. So it says in today's context, it is non-voluntary passive anesthesia which is permissible, even if the consent, what should I say, the AMD is not there, advanced medical directive is not there, even then you can withhold treatment, life-sustaining treatment.
Exactly, we can hold the treatment. Dr. Kingshuki, do you think that this distinction between, as sir has said, between further classifying passive, all these are mere forms of intellectual gymnastics rather than trying to solve a problem which exists and which we have a very simple and clear reason of saying that it is euthanasia and it is not euthanasia?
That is what needs to be taken into account. What is euthanasia? First of all, what is euthanasia? It is the intent of killing. It involves the intent of killing a person. What we are talking about is not killing the person. We are talking about letting the nature take its course, not interfering with the nature. And that is every human being's right. Do we want treatment or we do not want treatment? Even if it is a life-threatening situation, if I'm asked, and if I say no to a treatment, even if it's life-threatening, it's my right. That does not amount to euthanasia. The intent is what makes a difference. In passive euthanasia, that is where this passive euthanasia, what we say is somebody writes something and then the patient performs that procedure or does something, that probably with the intent that if it's written with the intent of letting the patient end the life, then that becomes passive euthanasia. So physician assisted suicide may be termed as passive euthanasia, but not withholding or withdrawing the treatments in an actively dying patient. These terms are very important. The
Exactly.
person
I
could be
get your point.
actively dying.
Thank you, Dr. King Shuki. I think, which one? Passive. As per court, as per court.
And as per law, who can give the consent? Patient is having a husband, 3 sons. 1 or 2 people are there. So how safe we
I'm
are?
coming to that in the subsequent questions are on framed for that. Now coming to Dr. Harsha, what is the duty of the treating team for assessment of end-of-life care? Assessment of end-of-life cannot go in a haywire fashion. There has to be follow a certain pattern, if not a protocol. So what should be the way of assessment of the treating team towards end-of-life care?
So first of all, to see whether the condition is reversible or not, what the prognosis is all about, what the needs and the wishes of the patients are, what the attendants have knowledge about or not, whether they are clear about the situation or not, and what actually their intent of the treatment is, that has been cleared to the patient and the attendant, and whether these have been documented at the right time or not, and also whether when the things were progressing towards, let's say, poor prognosis, what the understanding of the attendant is, what their wants and wishes are. These play a vital
Yeah,
role.
very correct. I fully agree with you. So it is to first to recognize and confirm futility. There should be no two opinions within the treating team. Like surgeon feels something, the medical oncologist feels different, or a intensivist feels a different. No, there should be a common approach, consensus, and there should be an internal consensus that the goal should shift from cure to comfort, and there should be clear, honest, and repeated conversations with the patient and family about the prognosis, respecting their values and preferences. They have the right to disagree to what we propose, and in that case also their preference should be respected. All assessments and meetings should be clearly documented. So as we know that our documentation of the conversations, etc., for required for legal and institutional processes which may exist should be activated. And throughout this entire process, there should be no interruption of the high quality palliative care and holistic support. So this will go along uninterruptedly, and the flow should be taken. I go to Dr. Dewan that, sir, as the question was raised by from the audience also, that what is the role of the hospital medical boards as per the 2023 guidelines and the later clarifications?
We should have a primary medical board. Every treating surgeon or physician could be part, and 2 persons from the same specialty. They go through the records, they go through day-to-day notes, all investigations, and maybe talk to the relations. And I think you've given the answer.
So I have given this answer. So it is a primary medical board with having treating physician plus at least 2 subject experts with more than 5 years of experience, examines the patient, reviews the records, and gives a preliminary opinion within 48 hours on whether withdrawal is in the patient's interest. If it certifies, then a second medical board of different clinicians, including 1 external expert, reevaluates and the case and either concurs or again within 48 hours. And their certified opinion, along with consent from the next of the kin, is communicated to the first-class judicial magistrate, creating a documented, safeguarded pathway. Now, this was till 2018. So what, Dr. King Shuki, what are the further steps what have been done to make this process easier? Yeah. This is the same 3 members, including the external expert. No. The different. There will be a different board.
Secondary में different.
First, primary is different, secondary is different.
No, that is what I'm saying. Primary had a treating physician plus 2. In secondary again,
Here
have
you can
3
see
or you have
clearly,
2.
I have written secondary medical board has 1 registered banker from a permanent panel of such practitioners impaneled
2
by the
subject.
district CMO,
Okay.
2 subject experts with more than 5 years of panels and not part of the primary medical board. Yeah, Dr. King Shuki, how this process has been made easier subsequently 2023. So the requirement of first class judicial magistrate approval has been
That's
condoned.
what. But it
So
needs to be intimated to
it
the
will be
magistrate
intimated.
again.
So you have just to intimate. And as for the advanced directives, we don't require the magistrate. We require a gazetted officer with the presence of 2 witnesses. And if it is a notarized, that serves the purpose.
And it again has a process where we need to have a copy with the civil body and, huh? Not CMO also, and there is a depository needs to be created and all that is a little to be sorted.
See, the process which has been is that the patient's relatives don't have to rush to the court or to the magistrate for all these processes. The hospital, if it decides, the secondary board, if it permits, that the primary board, and if they are in the same page, and if the decision is consensus, and the patient's patient's relatives or the caregivers are able to produce the advance directive, which is there. So this has only to be communicated to the jurisdictional magistrate, and it is not necessary to wait for the permission of the magistrate to come. You can begin your process of end of life care after you finish the intimation process. So this is very clear. So there are 2 arms of it. One is the advanced will, advanced directives if the patients have, but many of the patients don't have. In the patients don't have, then we have to rely on the decision of the primary and the secondary board. And after the secondary board gives its consent, inform the decision of the consent to the first class judicial magistrate and go ahead. If the patient already have an advanced will, then it makes further easier. You just don't have to go. You just forward that to the jurisdictional magistrate and you go ahead. So this has been the easier steps. Now, what are the obligatory steps during family engagement and consent? I will ask this question to Dr. Divana since he has a long experience, because the family finds it difficulty to accept in the beginning. Maybe at a certain point of time, they accept it. Now, if initially the patient has 3 different relatives, son saying something, brother saying something, wife saying something different. So how do we go ahead to gain their confidence and gain consensus and their consent?
I think meeting with the family members is extremely important. The treating doctor, maybe 1 or 2 other doctors who are involved in care of patient. And you need to convince them and counsel them about the futility of treatment, whatever you are doing. And now you need to also emphasize that this cure is shifting to care. And then once they understand the futility of the treatment, and also emphasize that the palliative care will not end, that will continue, we'll keep taking the care, but active treatment will stop. And then, of course, the consent of who is the surrogate family member or whosoever is the in charge of the family can sign. And then we go to the medical boards after this and continue with the palliative treatment.
So do you have any personal experience or you cannot share any such story where there are differences between individual family members and it is difficult to figure out who is the right person to give consent to and who we should accept in this account? Because many patients have a lot of relatives who think differently and different people turn up on different.
Not done all this here. It is very easy to talk about, but to practice, it is extremely difficult.
Yeah, fully agree. Yeah.
There are set steps of autonomy defined. I do not remember in which guidelines, but it is already defined. Like the wife, the spouse holds the first priority in case a primary caregiver, surrogate caregiver has not been identified by the patient. If the patient claims that this would be my surrogate, the autonomy person, then there's no question about it. In case it's not there, then the spouse, then comes the kids, the parents, and this is the order. Everybody else comes.
So there is a chronological order. You are absolutely right, Dr. Kingshuki. I move on to Dr. Harsha. See, having said all these chronology orders and all those documents, but how important and how difficult it is to gain actual confidence before you start the process.
But yes, I think that constant when you are having a repeated communication with always having the same attendant or a caregiver, whosoever is the primary one, when you are explaining that and the person is explaining it to the other family members. Because that person has from the day one till the day about the diagnosis has a clear communication from your side. One about the diagnosis, how the treatment has gone through, what the stages it has crossed, and what the decisions has been taken from their side and from the doctor side as well. Second, it is very important to let them know why and when the changes are happening. When they are aware of it and when they are a part of it, they understand the decisions that have been changed. And also, it plays a very big and important role that when they are having that trust on the treating team and the doctors, that yes, whatever they are doing, it is for the benefit.
Yeah, I fully agree. What also I think is that there should be no there's ambiguity within the treating team, because a lot of times we say the nurses sometimes in the end of the night have conveyed probably a different message. Again, the patient started rethinking. So if everyone should be on the same page, and it may be so that the relatives may have a certain longing towards particular physician, to the primary physician or whomsoever they may trust a bit more. And also that person, the onus becomes that he should try to explain the more clear terms, more genuinely, that this is a process and there is so everything said that every meeting decision and consent form should be carefully documented in the medical record. I'm moving on to Dr. Harsha again, that during what steps should be followed, because now we are living in an age of where a lot of times the court sees the merit of the case on different grounds. Without mentioning, I said that very recently we had a judgment where even the children of the doctors are not getting spared. Now, so what steps should be followed for documentation and documentation of the communication?
Caregivers and the patient. Next comes the discussions about the prognosis, when and however it has been done, should be clearly documented. Should also be noted that whosoever was the participant. One, the primary caregiver, obviously, and two others were also there, should be documented in the scenario, right? And then comes what were the concerns from their side? What were their questions? If we document that and also that they were satisfied with the answers or not, because we do answer from our side, but at times they still want to have more options. Then also about allowing them to have second, third, or whatever opinions they have, and letting them take that also, and letting them understand that they can come up again to ask us if they have any queries. Also referring to the due persons and to the due doctors if any references are being done and needed.
Thank you so much. Dr. Dewan, yeah, please, if you want to add.
I think most important point in today's practice is communication and documentation. कोर्ट आपको कुछ नहीं कहेगी अगर ये दो चीजें पूरी हैं तो। डॉक्यूमेंटेशन में डेली नोट्स 2 बार 4 बार जब भी कंडीशन चेंज होती है they should be documented, and then even the investigation reports should be entered by doctor. If you have established a primary medical board, secondary medical board, those should be documented. That's yes. If you have informed the first class judge, should be documented. If you have obtained a consent from the surrogate, should be documented. And communication should be one-to-one. डॉक्टर की साइड से एक ही डॉक्टर होना चाहिए जो डेली उसी रिलेशन से बात करे जो उसका रिलेटेड है। डिफरेंट डिफरेंट लोग आ जाते हैं, डिफरेंट टीम के मेंबर बात करने लगते हैं। Here is the confusion.
So that is in a very ideal situation, sir. But how practically possible do you think that for the same person to communicate every time?
It's possible. I think if I say that from my medical team, the intensivist, he is the person who is going
No,
to
among the intensivists, someone may be absent someday, someone may have gone for a leave, someone may have off.
And then he communicates with the other team member from our team that yes, this is what I have communicated and this is our stand, this is what should be communicated further.
Yeah, I fully agree with you that whatever we have the communication, documentation of the communication signed by all the treating team members should be preserved. And although sometimes I see a lot of corporate hospitals going overboard because sometimes I get those way from the medical council with some very voluminous pages. Half of them carry no meaning, of course, but still I think that they have no choice left but to also communicate. So all decisions from recognition of futility to the agreed EOLC plan should be recorded contemporaneously and the case sheet with date, time, and name. Each formal family member meetings need a brief summary of what was explained, the questions raised, and the family's responses. Checklists were available. Written consent or family wishes for withholding life support must be taken on designated forms and filled in the medical record. And the team should also document the communication of goals. And yeah, please.
This is the day-to-day problem. Say patients' relations say that don't do this particular step. Don't put the patient on ventilator. Or something
Yeah.
He did, he refuses. Should it be signed by the relations every time? Some of the oncologists, they insist on morning, evening notes by the doctor to be signed by patient's relations. Is it a must?
I think no, it is not a must. As far as the legal framework, it is not a must, but it has to be ensured that they have been apprised of their situation.
Suppose I am communicating and I am writing that I have communicated the matter to the patient's relations.
No, but the patients can deny later, no, it was not communicated until the patient's relative signature is there. How can alone the doctor's signature be justified that the patient has been counseled? Even at it is important to have the other person's signature as well, or at least some kind of someone. If they are doing video conferencing, they have everything stored in the camera, of course. So in that case. So the court always sticks on to Dr. Kingshuki that the best interests of the patient. Now, what actually means the best interest is something which varies from person to person. What may be my best interest, what may be your best interest, patient's best interest, court's best interest. So all these things, so it talks about best interest of the patients. That same thing can what I feel is the best interest for the patient, what the patient's son thinks is the best interest of the patient, etc. So how do we take this best interest and the mandatory palliative care? Yeah.
Mandatory palliative care is actually, it has to be given. Everybody
So what
deserves
mandatory
palliative care.
alone it's suggested?
Palliative care is comfort care, be it given by the society, the community, be it given by the family physician, anything. Mandatory palliative care is caring for the patient. That is the patient's right. Now, coming to the best interest, because each of us are not hardwired. We are not machines. We live in a society. We have our own microsphere. So, what works best for that microsphere of the patient? For example, if we think the patient can be saved, but the family does not have those financial means to save the patient. So, in best interests of the patient should receive all the palliative care which can be given to his microsphere. So, that is what I believe is best interest.
Dr. Harsha, when we talk of best interest, something we are also not sure that what is in the best interest. So, how do you define best interest in that case?
So it starts with first what patient wants. At
The
times,
patient is, say, it's not in a position to.
maybe currently he is not, but he has been talking about, let's say, there have been few cases where patient wanted to go home, but he or she is in hospital because the family wants to carry on with the treatment. So that happens at times.
So that becomes family's best interest. Dr. Dewan, sir, how do you define best interest when yourself you are not clear to you that what is the best interest?
The course of action which you are taking or whatever you are doing, what the patient values and what you are giving a dignity to the patient's life and dignified death. So maybe if the patient was there, I will put it as that if I were at his place, what will I expect?
Exactly. So I think that is a very reasonable, that is the best way to
And it should not be in the interest of the medical professional or in the interest of the surrogate.
Or the surrogates, right, sir. So best interest means choosing the course of action that most respects the patient's dignity, values, likely wishes, the relief of suffering, or rather than convenience or distress of relatives or clinicians. In Harish Rana case, the court applied this test by weighing irreversible medical futility against patient's devastated quality of life, although Harish Rana's case was an exception because it was 13 years. And this, we don't have 13 years old patients routinely, but we do have 15 days to 3 months old patients. The court as well as the stakeholders, that once the treatment limitation is decided, high quality palliative care becomes mandatory. It is not an optional thing. And this includes symptom control, psychological, psychosocial, spiritual support, and a humane environment so that withdrawal of support never amounts to abandonment. So my next question again goes to Dr. Harsha, that when there is a thin line between abandonment and treatment futility or palliation, how do you go ahead? Because you have 7 or 8 patients in the ICUs. Suddenly, you know, well, this patient is end of life. So momently your time dedicated becomes 5 minutes, whereas other patients it becomes 1 hour, 15 minutes, 20 minutes, whatever. So that also conforms to some kind of abandonment. So how do you overcome that?
So one, we should not abandon a patient, even if it is for a 5 minutes. We need to give that due 5 minutes to the patient they deserve, right? I understand that at times it becomes difficult for a clinician to give that 5 minutes to the patient. But what we are doing is for the quality of life for that patient. The symptomatic relief, whatever can be given for the patient, whatever can be done to for as per the dignity of the patient, dignity of life, which we should do for that patient, should be done. And at least it is the patient's right to have that palliative care for them till their last breath, and we should be supporting that.
Dr. Diwan, I can ask you that when we take the end of life decision and once we start practicing, don't we subconsciously or unconsciously also push the patient towards abandonment sometimes, because we know, well, nothing is going to come out, so there is no point discussing too much about. Let's concentrate on the other patients.
I think I run a hospice, so I know the patients who are getting admitted have got limited span of life, less than 6 months. And
So in a hospice, the situation is different. I'm saying in a mixed, where we have a mixed population.
I think, as she rightly said, that all mandatory palliative care should be continued, and nobody should feel even that the person has been abandoned.
Dr. Kingshuki, you wanted to add something?
Abandonment, that sensation, that feeling comes when the patients and the families feel helpless. अब आप घर ले जाओ, सेवा करो. That is the point of abandonment. Because the family is completely ignorant कि उस sentence के बाद घर पर उन्हें करना क्या है, patient की care कैसे करें. So if that is taken care of, if the patient and the families are well equipped to handle their symptoms, so that is where palliative care steps in and prevents that feeling of abandonment. And it's not even the feeling there then, The patient feels cared for, and this is my job day in, day out, dealing with such end-of-life care patients.
Can I add
Fine,
something on
fine.
what she's saying? You see, the important thing is it all depends upon the financial burden that the family is facing. If the patient is in a government hospital and there is no financial burden on the family will say continue the care. They will not want abandonment. They will not say that no. They will say because at the back of the mind they know कि हम इसको घर कैसे संभालेंगे. But one second. But in case with the patient being in the hospital, there is too much of the financial burden which the patient have to face. It is the same family which will say कि हम इसको घर लेके जाना चाहते हैं, and you will tell him कि नहीं हमने तो palliative care करना है. So you have to weigh what is the financial burden and the extent that the family can bear. Unfortunately, palliative care, if free of cost or gather philanthropic activity, people will continue to.
I fully agree with you, sir, that things depend from time to time, place to place, situation to situation, context to context. There is nothing wrong in someone saying that a patient ko ab ghar le jao. Yeah, if it is a busy hospital and we have to give the bed to someone more needy, a reversible condition, and if you have to counsel in a single sentence, it amounts to the same thing, whatever big lecture you can prepare. But it comes to the same thing that we don't have anything, we don't have palliative care services. So you please take the patient home and follow certain principles that 1, 2, 3, 4, 5 you can enlist. But at the same time, when it becomes a service sector where the patient is paying for all his services, when you don't want to let the patient and the patient himself wants to go home, that if there is no further treatment, what is the point for him? A patient's relatives is a loss of income. Everyone has to stay in the hospital. He has to come and bear. So in that case also, I think suitable options, the financial packages, the costs of the treatment, the overburden, everything requires a holistic appraisal from the various. Yes, Dr. Harsha, you want to add something?
You see, I have one of our family friends and all. The mother probably had a stroke and she was in this palliative care stage. Being in the private hospital, the family wanted to take back the mother. But the hospital said, unfortunately, we are not legally permitted to do euthanasia, so we will not do this and that. So let us be practical of the present situation. There are instances where the private institutions will probably not like to send the patient home, even when the family is desperate. And in a government institution, you will like to send the patient home because you need bed and you feel that more bed can be utilized for a better patient, but the family says no. So that difference does exist.
Actually a very practical one, but here we are discussing the statement given by court that there shouldn't be any abandonment. So abandonment, that feeling is a very regular feeling. It's not related to financial thing. Finances come under the kind of care which can be delivered post discharge of the patient at home. Jitna गोड़ डालोगे उतना
Yes,
हो जाएगा।
I get you. Yes, Dr. Harsha.
And at times that feeling of abandonment comes when a proper communication is not been done at right time.
Dr. Harsha, I again go to you. That this feeling of abandonment can be because of an expression of the patient's end-stage disease, which is reflecting poorly on the doctor because he has to communicate. So patient feels abandoned because ultimately there is no treatment. It is not that doctor has said that we are not going to treat you. Doctor has also said that I'm going to treat the care for the symptoms and everything, pain, this, that, temperature, etc. But just because the patient's condition does not have any treatment, it may reflect upon the relative's mind that a feeling of abandonment. That can also give rise to abandonment.
It does, but the point is patient doesn't have curative treatment, but palliative is there. We need to make them understand this, the difference.
I think that is a very important point which Harsha has mentioned, that if we are able to convince patients' relatives that the distinction between curative and palliative to the point that they realize that the value of which they will probably value palliative much more.
Absolutely.
So since we are running out of time, I'm going to the last case. I will go to Dr. Kingshuki. In our case, Vignet, if we finally, from all those discussions, if we have to practice successful end of life care, what should be the key steps? The case which I told, 70-year-old man, refractory shock, brain MRI showing irreversible damage, etc., etc.
I don't know if the patient would be in his senses also or not during that situation. And our case only, we are discussing about our case
Our
only.
case, yeah.
So I take it for granted that the patient is on ventilator and must be sedated as well. So the primary thing is counseling of the family members. First of all, checking their goals of care, what they want. If they want no further escalation of the treatment, that should be done. If they want withholding or withdrawing the treatment, then that can be proceeded ahead with. And it has to be collaborated, a team effort, along with the treating physician, the ICU team, as well as the palliative care team.
Very true. Dewan sir, you want to add anything more?
I think we have discussed all the points. If we summarize, that gives your answer. Yes. Okay. Here is the answer.
So on the ICU floor before withdrawal, we have to initiate pain and symptom control because palliative care, opioids, sedatives, address dyspnea, secretions, agitation, prepare the environment. And during and after withdrawal, monitor and treat the distress, provide psychosocial and spiritual support to the family, ensure staff understanding that this is a goal concordant care, not neglect. Because many a times the attitude of the sisters also, they become less intense towards patients who have been earmarked as end of life care. So probably they find that missing 1 or 2 feeds may not make too much of a difference. Anyway, usko to jana hi hai. So such a thing should not happen. So the Supreme Court 2026 Harish Rana case, but all there is explicitly, so we know that it is possible. We are not wrong. We are legally safe to practice end of life care in patients with treatment futility. And it has linked withdrawal to a structured end of life or palliative plan and warned that directly jumping to euthanasia without such a plan may be an abdication of medical responsibility. So we cannot just immediately think of euthanasia. It has to be a stepwise process where we need the concurrence, the acceptance, and the consent of the patient at each and every stage. So my take-home message would be that recognize and diagnose futility. 2, build internal consensus within the team. Initiate end-of-life care discussions with the patient and the patient's family members. Document and trigger the formal end-of-life care process and ensure ongoing palliative care and holistic support till the last end. And of course, that includes the bereavement support too. I once again thank all the panelists for sparing their valuable time and joining this integration persons and also
Can I ask one question?
Yeah, thank you.
You see now these are practical issues when you have person requiring palliative care. One son is in India, the other one is abroad, and you have to take consent. Is the consent from the person not in India also required to be taken? And if the answer is yes, how?
Consent has to come from the surrogate. By surrogate, there are only 2. Who is the legal? See, there is a chronological order. One is the spouse. If the spouse is not there, then the children.
If there are 2 children, no spouse, 2 children, one in India and another one in UK or USA, तो UK USA वाले का भी consent लेना होगा और अगर लेना होगा तो कैसे लेना होगा?
In that case, what is the consensus? I don't know, but what consensus I have seen being followed, usually the people take the person who is physically present and for the hospital who is person who is paying the bill. That is also an important aspect. But the point remains that someone is on video conferencing and he is not in a proper state where he is in full knowledge or full understanding of the facts related to the welfare or care of the patient on the basis of which he has to take a decision to be fulfilled. So a physical presence, a direct presence, person who has brought, who had admitted, who is coming daily visiting of the two sons or one son and daughter. So
the problem is the son in UK or USA might file a suit against the other sibling. कि मेरे भाई ने इनका ख्याल नहीं किया. What are the legal problems that the
So the illegal, I think we didn't get any such instance as of today. Probably until that.
no, there must be. Are you sure on that? अगर किसी के दो बच्चे हैं, एक इंडिया में है, एक दूसरा यूके में है, सिर्फ इंडिया वाला लिख दे कि मेरे पिताजी को वेंटिलेटर से हटा दो या पैलिएटिव केयर में डाल दो, you agree that the person in UK, USA will not likely to object.
So whosoever is the science authority that time?
He is not the authority, na? He is not a single authority.
He is not a single authority.
सर कुछ कहना चाहते हैं? अमेरिका से हाथ छोड़ी जाएगा. अरे भैया, जैसे ईरान इराक की वॉर चल गई, वो आ ही नहीं सक रहा. Suppose even if he wants to come, my point is very simple. Is there a modality available in the
Sir, this point has not been discussed. There has been no cases.
I think we should try to find it out, because now every family you have one or if not both the kids are away. Such situation.
And there may be difference. You are very right, sir. There may be difference between two brothers.
No, even if there are no differences, suppose I am here and my younger brother is out, and both of have to decide
Sir,
that,
if
okay,
there is no difference, then there is no question of feud or a case. The question only comes if there is difference.
I will again like to differ. If in the history it has been written that the patient has two sons, the hospital will say we need the consent of the other son also. तो वही तो ये बताया that the male is the consent.
That court will consider it on a case-to-case basis.
We are not aware of it. We need to find it out. Let us not argue on something about which we are not. And is video conferencing required to be done for the consent purposes or no? Quite a few private hospitals are doing it.
Yeah, a lot of private hospitals are doing it. It is accepted in the court of law.
It
is not a requirement.
It is not customary.
It is not customary. Okay. But if you have it, it will be accepted.
And what about living will?
Living will is accepted. Living will is very, it is very clearly.
Should we try to initiate in every hospital?
Living will has been, now Lions Club had recently organized one very big living will camp somewhere in South Delhi. I couldn't go that, but now there are a lot of camps are happening that with living wills, and
In Turkey, we should organize one such camp. Chalo, thank you. नहीं, let us not be so very negative. अगर Lions Club organize कर रहा है और club में responsiveness आ रही है, let us not say that it is not doable or feasible. चलो.
Thank you so much. Thank you once again to all the panelists.
So, with end of live session, we come to the end of this conference also. And I think I'll invite, while I thank everyone, I'll invite Dr. Prashant to formally deliver the vote of thanks and conclude the event. And I think prior to that, I will request Dr. Dewan to give in his inputs. We'll have your comments on the conference conducted, and then we will have a vote of thanks.
Thanks to all the audience who are there till the end. And I must compliment the organizers. the ICU people, Dr. Rajiv Chawla, मैंने ऐसा देखा नहीं कि एक वर्चुअल कॉन्फ्रेंस हो जाए एक दिन पहले। डॉक्टर साहब कल अपनी टीम को लेकर यहां खड़े हुए थे कि कौन कैसे क्या करेगा। एंड so much written work, preparation of slides, because I sit in his room only in the OT complex. So I see him day in and day out putting so much hard work in preparing for this event. And hats off to you. And kudos to the ICU teams जो सुबह शाम लगे रहे। तो आईसीयू वाले डॉक्टर साहब मेरे पास आए, जी आपके पास कार्ड गलत आ गया है। मैंने कहा कार्ड तो एक जैसा ही है। कहते नहीं नहीं नहीं, मॉर्निंग लैंप लाइटिंग में आपका नाम नहीं है, ये वाला कार्ड आप चेंज कर लीजिए। So I think you were very meticulous in all that. Who has been given what? And regarding the program, I think well drafted, and you try to cover all the points, especially related to sepsis. And 6th to 12th happens to be the nursing week. And I think 5th of this month was probably hand hygiene day. So, right tributes given by the course program to the hand hygiene day as well as nursing week also. So, and I am very much impressed by the way Dr. Saab has conducted this end of life care session. जब मैंने सुना कि एंड ऑफ लाइफ केयर के बारे में इस तरह का कुछ सेशन होने वाला है, so I thought it'll be more of a lecture, but you made it very interesting. So thanks to all the moderators, participants, audience, everyone. I think अभी थैंक्स गिविंग होनी है और मैं ही देने लग गया हूँ। आ जाइए आप अपना काम करिए।
I won't be taking too long. First of all, a good evening. Thank you, everyone. There's a long list who I want to thank, starting with Rajiv Gandhi Cancer Hospital. You have been fantabulous, fantastic, all your support, right from purchase team to marketing team to finance team, whether be it RF, Kunal, Manish, Manoji, everyone. They have guided us throughout. कि सर ये करें, अब ये करते हैं, अब ये करते हैं. Thank you all. Not to forget the PR team also. I might miss a few, but that's human. Including the list is the F&B, housekeeping, all the ward boys, all the front desk staff who have been there with us, not today, but throughout all the 1.5 month, hour long period since we have been arranging and organizing this conference. Thank you all. A sincere thanks. Not to forget the security team, Mr. Jaydeep, for efficiently providing the security and covering with the parking and extra issues. All doctors, all faculties who are not here, the faculty, internal faculty from RGCI, all directors. Divan sir is there, sir. Thank you very much again. And all the external faculty, all my colleagues, some of my seniors, some of my juniors, right from Max Arcade to NH to Medanta, everyone, a sincere thank you. All nurses, thank you everyone. You have been staying back. All the anesthesia department, it's a love relationship with you. Like anesthesia, being from the anesthesia background, it is our parent field. Yes, we have diversified to critical care, but yes, anesthesia will always stay. And whatever we are because of anesthesia. A sincere thank to all of you, all the DNBs, fresh DNBs. I know it's a new learning experience for you. Thank you very much. A sincere thanks to my colleague, my brother, Dr. Bikram. Dr. Nitin Bansal is not there. My whole ICU team, Dr. Manish, Raghav, Dr. Praveen, Avirak, I think he's having night off. Sora Avirak? Nahi. Dr. Poonam and Dr. Shikha for this wonderful comparing, being the MC, all my staff. एक चीज बोलना भूल गया जो मुझे शुरू में बोलनी थी. Today is incidentally, I think, just say Dr. Rabindranath Tagore's birthday. So just going by his quote, Dada, forgive me if I'm wrong. जो भी तो वे दक्षिण के ना आशे तो भी एकला चलो रे. If no one is with you, be alone, walk alone. But I was lucky enough that I had a great bunch of people like you supporting me. Today is incidentally also Maharana Pratap Jayanti, World International Trade Fair Day, and National Train Day. Lot of big occasions and our small conference. And last person whom I want to thank from the bottom of my heart is Chawla sir. He is a big inspiration and an encyclopedia. हमें भी नहीं पता था ये. We have been sitting with him since last 1.5 months. The kind of inputs he has given us, ये लाइन ठीक नहीं है. कई बार आई थिंक दादा भी लग रही, कई बार सर ने क्या बोल दिया, ये कॉमा यहाँ पे नहीं है, ये लाइन ऊपर हो गया, ये लाइन इधर है. बट येस, he is so meticulous. Mata, he is an encyclopedia. We had a lot to learn from him, and we will keep evolving and learning from him. From the bottom of heart, from all our team, everyone, thank you very much, sir. You have been a big inspiration. Thank you very much, sir. Thank you all. Thank you, and have a good evening.
You say I've always been correcting him, and he has again missed a very important thing. He has not thanked the companies who have given us financial support. And by not doing that, he's trying to dig the grave for the next conference if we have to plan one. From the core of my heart, I would like to thank all those companies, industries who have provided us support. And we do hope that as and when we plan to do something else in Rajiv Gandhi Cancer Institute, not only the Department of Anesthesia, but even for the other departments, you will continue to serve the cause of cancer, make us educate the people, be it nurses, be it technicians, be it anyone. Because your sponsorship is not for our personal gains. It is primarily to serve the humanity, to serve the cancer patient who are suffering. The more educated and literate we become, the better we are in a position to treat. So I do hope your support will continue. And we do hope we will continue to gather here for various educational programs. Yesterday or this week, we have the Nurses Week. Today, we had code program. Day before yesterday, we had the Thalassemia Day. So it is not the publicity, but it is our commitment. It is our belief that we can do it and we can do it better. And that is exactly the reason we took that pledge today in the morning when it was the inauguration function. So thank you, everyone. Thank you, my new DNBs, for being here. You have been a support. And I told them, since it is a coat program, you should come in white coat. They have all come in the white coat. And they told me कि हम मोटी में जाते हैं, हमें white coat पहनने का मौका नहीं मिलता. We will like to have a photograph with you in the white coat. So I have also brought my white coat. Thank you, everyone. And thank you very much. सब लोग आ जाओ भाई, सब आ जाओ, आइए
मैं छोटी हाइट समझ गया मैं छोटी हाइट वाली